session will be moderated by S.M. Khaled Jahan. I would like Professor Nurul Fattar Rumi sir, S.M. Hassanur Rahman Babar sir, and Abdullah sir to chair the session. I request Dr. Muhammad Khabiruddin Patwari sir, Associate Professor, National Institute of NIENT, to start the session. The session is Basic Surgical Anatomy of Nose and PNS.
Assalamu alaikum. Good morning. Welcome you all in the 8th Endoscopic Sinus and Skull Base Conference 2024. I am Dr. Muhammad Khabiruddin Patwari, presenting on Basic Surgical Anatomy of Nose and Paranasal Sinuses. Introduction. Hello. Anatomy of nose and paranasal sinuses is one of the most complex anatomy. For proper technical skill and good surgical outcome, one have to know appropriate anatomy and anatomical variations of nose and paranasal sinuses. In the changing scenario of indication of endoscopic sinus surgery, detailed knowledge of sinonasal anatomy is of paramount importance for the endoscopic surgeon. First, nasal septum. Nasal septum provides projection of the nose and divided into three parts. Bony septum formed by the perpendicular plate of ethmoid and vomer mainly. The cartilaginous septum is formed by quadrangular cartilage, and membranous septum lies in between cartilaginous septum and columella. Here is the picture of anterior nares. As you see, this is the cartilaginous septum, and here is the medial and lateral crus, which is formed by the upper lateral cartilage. And this picture is the lateral wall of the septum of the nose, which is mainly formed superiorly by the perpendicular plate of ethmoid and inferiorly by the vomer, and some minor contribution from the nasal bone, nasal process of the ethmoid bone, and below from the nasal crest of palatine bone and nasal crest of maxilla. And this is the quadrangular cartilage. Nasal septum is studied for different types of deviations and spur formation. Spur may cause turbulence of airflow and leading to nasal polyp, and deviations may cause changing in the airflow, causes chronic rhinosinusitis. And in both of these forms may causes difficulty during the endoscopic sinus surgery, and view of the field may obstruct by them and should be corrected during the endoscopic sinus surgery. Now the ethmoid bone. Ethmoid bone needs to be understood in a proper way. Form most of the skeletal framework of the nose. It consists of a horizontal part and a cribriform plate. Yes. And a vertical part in the midline, the perpendicular plate, and perpendicular plate forms the posterior part of the septum. Cribriform plate feeds into the notch of the frontal bone. It transmits olfactory nerves as well as anterior and posterior ethmoid arteries. Histocele is a projection on cribriform plate in the midline. This is a picture of an ethmoid bone. here, this is the medial projection, midline projection crystallically, and the downward projection got the perpendicular plate of ethmoid bone, the medial nasal concha. This is the anterior view, and this is the superior view. There is a numerous air cells. Here the olfactory fossa is clearly visible, and it is the lateral lamella, and this is the horizontal lamella of the olfactory fossa, and this is the orbital plate, and this is the ethmoid cell. Surgical importance in endoscopic sinus surgery. The ethmoid phobia is formed medially by the lateral lamella of cribrium plate, which is 0.2 millimeter, laterally by the frontal bone, which is 0.5 millimeter in thickness. The region where the anterior ethmoidal artery passes the dura medially is the thinnest area of the base of the skull and only 0.05 millimeter in thickness. If we look here, this is the olfactory fossa, this is the horizontal lamella, lateral lamella, and the orbital plate of frontal bone, and which forms the olfactory fossa. The depth of the olfactory fossa and length of the lateral lamella forms the fossa is classified by Caros type 3. The type 1 is 1 to 3 millimeter. That means the lateral lamellar length is 1 to 3 millimeter. Is it called type 1, which is safest for the surgery. And type 2, which is 4 to 7 millimeter in depth. The lateral lamella and olfactory fossa is depth in inferiorly. And the type 3 is 8 to 16 millimeter depth. And type 3 is difficult and to understand by an endoscopic surgeon by doing the CT scan. That is type A, type B, and type C. Sometimes there is a variation in between two sides, right and left, in the same patient, and that is why one part may be easier to execute and another side may be difficult. Lateral wall of the nose. Anterior part is covered by the skin and beard's hair called the vestibule of the nose. After that, there is structureless area, the atrium, and the agar cell lies anterior to the middle turbinate, which extend up to the inferior turbinate. And there is a three scroll-like structure called inferior, middle, and superior turbinate. In between them, the corresponding meatus. The most important aspect is middle turbinate for the endoscopic surgeon, and middle turbinate is attached with different structure in three different planes. The anterior part is lie in the sagittal section and which attached in a cribriform plate of ethmoid bone in between lateral and medial lamella, and most anteriorly is it attached with the frontonasal process of maxilla, and middle portion is lies in coronal plane which attached with the lamina papyracea, and which causes the strength of the lateral turbinate, and most posteriorly it is situated in the axial plane and attached with the perpendicular plate of palatine bone. After medialization of the middle turbinate, or if we trim the middle turbinate or dissected the middle turbinate, we can see most anteriorly the curved ridge called the uncinate process. The uncinate process is sickle shaped with vertical and horizontal leaf, and the intermediate portion behind this there is a pneumatized and most constant anterior ethmoidal cell is called the bulla ethmoidalis. If we look at the picture after trimming of the middle turbinate, this is the uncinate process, this is the bulla, and in between there is a semilunar space called the hiatus semilunaris, which is two-dimensional structure, and it leads to three-dimensional structure called the infundibulum. The most important structure here is the uncinate process, which is dome-shaped structure, and it is malleable. It is attached in its superiorly in different variations. Most commonly, it is situated in the lamina papyracea, and it is closely related with the frontal sinus recess, like the upper dome, and the recess enclosed this upper dome like a eggshell in an inverted egg cup. That means the drainage of the frontal sinus lies medial to the uncinate process. And the sinus is situated anteriorly. And another type where the uncinate process is attached with the base of the skull, and the drainage goes to the infundibulum, and also in type 3 it is attached to the terminate and goes the drainage goes to the infundibulum. In these two situations, the frontal sinus disease may extend into the maxillary sinus, and also the vice versa maxillary sinus disease into the frontal sinus. The another type where the frontal sinus float on the middle meatus. After dissection of the uncinate process, we can study the lateral structure clearly, and mainly we can see the maxillary ostium, which is oval in shape, and and this sorts of ostium which is formed by the different bones and intervening mucosa. Bones mainly by the uncinate process enter inferiorly the lacrimal descending part of the lacrimal bone, inferior terminate maxillary portion, and also by the perpendicular plate of palatine bone, and which intervening the mucosa. And somewhere there is no intervening bone, only mucosa, that means anterior and posterior fontanelli. Sometimes the mucosa may be dehiscence in somewhere called the accessory ostium. In this situation, when accessory ostium is present, it should be incorporated with the main ostium to prevent the reverse flow. Here is the close view of the ostium. Surgical importance in endoscopic sinus surgery. A branch of sphenopalatine artery runs along the lateral nasal wall in the middle meatus. That branch may be encountered whilst widening the maxillary ostium posteriorly. The normal ostium should be widened in an anterior-inferior direction to prevent injury to the nasolacrimal duct, which lies 5 mm anterior to it. The uncinate process, the bulla, and the intervening infundibulum form the key area of the osteometal unit, into which the frontal, the maxillary, and anterior ethmoid sinuses drain. This is the osteometal complex. If you see here the bulla, the medial turbinate, the uncinate, and the intervening portion of the hiatus semilunaris, the anterior sinuses, that means frontal sinus, maxillary sinus, and anterior ethmoid sinus drains into the hiatus semilunaris, which is the key area of the osteometal unit. Ethmoidal bulla. Ethmoidal bulla is usually a well-pneumatized, most constant anterior ethmoid cell, can be absent in 8% cases. The ethmoid bulla is separated posteriorly from the ground lamella of the middle turbinate by a recess called the retrobullar recess. The bulla does not extend up to the base of the skull and is separated from the base of the skull by suprabullar recess. Here is the picture we see. This is the retrobullar recess, and this is the suprabullar recess, and two recesses combinedly form the sinus lateralis of the ground wall. And this recess enter into a semilunar cleft known as hiatus semilunaris superior, which is opposite the hiatus semilunaris inferior. That means hiatus semilunaris inferior and in a infundibulum and hiatus semilunaris superior and are open into the sinus lateralis. Surgical importance. Clearance of the bulla, anterior and posterior ethmoid cell should be done using blunt instrument to prevent injury to the lamina papyracea and orbital contents. The anterior wall of the bulla lies just in front of the anterior ethmoid artery at the base of the skull. Now, frontal recess. Frontal recess has variety of anatomical variations. Anteriorly, it is bounded by the Agarnazi cell. Posteriorly, by the bulla ethmoidalis. Lateral wall is formed by the lamina papyracea. Medial wall formed by the medial terminal. And superiorly, the frontal recess open via the frontal ostium into the sinuses. That means if we look from the superior, the frontal orifice is a funnel-shaped structure. And this funnel-shaped structure is known as infundibulum. The frontal sinus, frontal orifice and frontal recess give the impression of a configuration of hourglass contracture. This is the frontal sinus, this is orifice, this is the recess, and this is the infundibulum. Combinedly form an hourglass configuration. This is the close view of hourglass configuration. This is the now ethmoid sinus. The anterior ethmoid air cells are variable in number. The posterior ethmoid air cells are fewer and larger. Anterior group drains into the middle meatus by the way of infundibulum. The middle group drains in the middle meatus if present, and posterior group drains in the superior meatus and sometimes one or more into the sphenoid sinus. The anterior ethmoidal cell may migrate anterosuperiorly into the frontal recess to produce different types of frontal cell. Kuhn describes 4 types of frontal cell. Type 1 cell, single cell above the Agarnazi cell. Type 2 cell, 2 or more cell above the Agarnazi cell. Type 3 cell, a large cell extending well into the frontal sinus, mimicking the frontal sinus itself, sometimes called frontal bulla. Type 4, an isolated or lunar cell separately within the frontal sinus. Here is the structure we see. This is the frontal cell, frontal sinus, frontal orifice, frontal recess. And if we see on CT scan, we can see clearly the frontal cells. This is type 1 frontal cell, single cell above the Agarnazi cell, just below the frontal beak. Type 2 cell, 2 or more cell, here 3 cell below the beak above the Agarnazi cell. These two sorts of cell can be operated easily, but in case of type 3 and type 4 cell, here the type 3 cell we extend the frontal sinus and it is 50% in the frontal sinus, but in case of type 4 cell, more than 50% cell extended into the frontal sinus and it is isolated cell. And it is very much difficult to operate. Sometimes frontal beak may be drilled to correspond the sinuses. Surgical importance endoscopic sinus surgery. While dissecting in frontal recess, the surgeon may think he has entered in the frontal sinus when in fact he is within a frontal cell. It is necessary to deroof this frontal cell as to reach the frontal sinus and establish the drainage. The posterior ethmoidal cell may extend posteriorly over the sphenoid is called onody cell. Thus, the Onodi cell insulates itself between the optic nerve and the sphenoid sinus. The optic nerve therefore to produce a bulge in the Onodi cell instead of the sphenoid sinus. This is the picture we can see the Onodi situation here. That this is the superior surface of the sphenoid sinuses, and this is the optic nerve. Optic nerve may give impression in the Onodi cell instead of sphenoid sinuses. Even the optic nerve can enter into the Onodi cell. So, one surgeon should be encountered that in Onodi situation, he has to give extra care and not to damage the optic nerve and the carotid artery. Sphenoid sinus ostium is high and its anterior wall close to the roof. The sphenoid ostium lies 1 to 1.5 centimeter above the roof of the posterior corona. It drains into the sphenoethmoidal recess. The superior turbinate in the sphenoethmoidal recess may overlie the opening of the sphenoid ostium. Relation of sphenoid sinus, its lateral walls is related anterosuperiorly the optic nerve, posterior inferiorly the internal carotid artery, and in between them carotico-optic recess. The inferior wall may have the bulging of the maxillary branch of trigeminal nerve. Types of pneumatization. Depending on the pneumatization, the sphenoid bones has three types of pneumatization: salad type, pre-salad type, conchal type. The anterior wall of the sphenoid is situated 7 cm from the anteronasal spine at 30 degrees from the floor of the nose. Here is the three types of pneumatization seen in the schematic picture. This is the type 1, only rudimentary cell is seen, and in pre-salad type, the pneumatization extend up to the anterior wall of the sella turcica or pituitary fossa, and in salad type, the pneumatization extend up to the clivus, and in salad type, the pituitary bulge may be seen in its superior surface. In case of conchal type, the surgery is contraindicated. Here the CT scan shows the three different tier of pneumatization. The sphenoid sinus, the sphenoethmoidal recess, and the other sinuses and recesses are seen in this picture. Surgical importance in functional and endoscopic sinus surgery. Approximately 6% of cases, the bone over the optic nerve may be dehiscent. Approximately 25% of cases, bone over the internal carotid artery may be clinically dehiscent. This may be difficult to visualize on CT scan if sphenoid sinus is full of polyps. Therefore, extreme caution has to be exercised in pulling polyp out from within the sphenoid sinus. 4 lamella encountered on endoscopy from anterior to posterior. This is first lamella is uncinate process. Second is anterior wall of the bulla. Third lamella is ground lamella. Fourth lamella is anterior of the sphenoid. This is the anterior to posterior. Sometimes superiorly the fifth lamella may be the superior turbinate, and sixth lamella may be the supreme turbinate. Here is the picture of these turbinates. Important anatomical landmarks during the endoscopic sinus surgery. This is the constant landmarks. The medial turbinate, uncinate process, bulla ethmoidalis, sphenoidosteum, skull base, maxillary sinus. After removal of anterior and posterior ethmoidal sinus, we can see the lamina papyracea, which is yellowish in color due to fat. Here is the sphenoid sinus seen there, and that is the lacrimal duct. Nasolacrimal duct opens into the roof of the inferior meatus, and its apex is guarded by the bulb called Hessner's bulb. The canal for nasolacrimal duct approximately 5 mm enter to the normal maxillary ostium. And this is the nasolacrimal duct. After dissecting the bone, the medial bone is formed by the lacrimal bone, which is uh, thin, and the lateral one is thick, which is formed by the maxilla, frontonasal process of the maxilla. After removal of the lamina papyracea, we can see the fat, orbital fat. Here the orbital fat, and this is the nasal lacrimal duct. Now come to the anatomical variations. Variations in anatomy are more a rule than an exception. Must be aware of this variation before surgery. CT scan plays a vital role to diagnose the variations. Nasal septal turbinate. This is a fusiform area of the tissue which behaves structurally and functionally like of the turbinates. This is the pneumatized nasal septum. This is the pneumatization of the superior turbinate. This is the concha bullosa. Concha bullosa is over pneumatization of the middle turbinate, and it is in the bullous part of the middle turbinate, which can impair the circulation and causes nasal obstruction, causing chronic rhinosinusitis. Paradoxical middle turbinate, that means it is a convexity towards the lateral wall. Paradoxical bilateral middle turbinate may be seen in the CT scan. Curved uncinate process. When it is medially curved, it looks like two turbinates, and this is also curved uncinate process. Pneumatization uncinate process may also seen. Bifid uncinate process may also found in the CT scan. There is the Agarnase cell. When Agarnase cell is pneumatized, it can obstruct the frontal recess. Here is the CT scan of the frontal ostium, and the Hallard cell is the infarbited cell. Here is the Onodi cell, as I am talked earlier about this. There may be bilateral Onodi cell. Thank you all for patience hearing.
Thank you for very beautiful presentation. From audience, is there any question? Question for it. I have one or two comments. Very beautiful presentation. I enjoyed very much. I think audience also enjoyed. One thing, the Keros type 3, it's not difficult to operate, but there is chance of complications. There are two complications. One is chance of injury to the lamina papyracea, and another is chance of injury to the anterior ethmoidal artery. As there is, we call it hanging inferior turbinate. And presentation was very beautiful. I think you have shown 2 slides for single thing. Like one is description, another is picture. We don't need any description. You will show the picture and you will give the description. তাতে দেখা যাবে তুমি আরো অনেক বেশি প্রেজেন্ট করতে পারতা, আরো অনেক অল্প সময়ে অনেক বেশি প্রেজেন্ট করা যেত। Overall, the presentation was very much beautiful and enjoyable. Thank you.
Thank you, Dr. Khobiruddin Patwari. Now we have the next session on lecture on how does a surgeon read CT scan paranasal sinuses, and this will be presented by Professor Dr. Muhammad Ashikur Rahman Bhuiya. May I now request Professor Dr. Ashikur Rahman Bhuiya to give a lecture on how does a surgeon read CT PNS.
স্যার আমি স্যার একদম অরিজিনাল ফাইলটা নিয়ে আসছি তো স্যার আমার সঙ্গে
আরে আছে তো এখানে দেওয়া আছে, দেওয়া আছে তো হ্যাঁ।
This session will be chaired by Professor Dr. Muhammad Abdullah sir. Professor Sheikh Nurul Fattar Rumi who will be present as chairpersons. And may I request Dr. Muhammad Tawhidul Islam. Dr. Muhammad Tawhidul Islam is here? আসছে তো। And Professor Dr. Kobiruddin Ahmed. May I now request you to chair this session, and this session will be moderated by myself, and rapporteur will be Bipu. Where is Bipu? You also moderate this, you also be the rapporteur of this session. Thank you. May I now request Professor Dr. Ashikur Rahman Bhuiya to start his lecture on how does a surgeon read CT-PNS.
Very good morning to all respected Chairperson Professor Abdullah sir, Professor Khoburuddin sir, and my dear Professor Sheikh Rumi sir. In front of me there are many important delegates and my favorite teacher Professor Babur sir. But before Babur sir, in front of Babur sir, it is very difficult to give a lecture on CT scan. But I need his help. And here is Professor Colonel Dr. Alamin Salak and all the delegates. Now I going to the present my topic. This is the how does a surgeon read CT scan? Actually, CT scan is a subject of radiologist. But in case of our surgeons like endoscopic surgeon and the face surgeon, we need to understand the CT scan. Otherwise, you know, CT scan is your Google map. If you did not understand the CT scan, you will not operate in any way. But you can operate, but you will have to face many complications. So, as a surgeon, we need to understand how to read CT. But today's presentation is totally anatomical presentation, not any disease. To see the each and every cell of the nose and paranasal sinuses. So, for a CT scan, we need to understand when we ask CT, what do you write? We should write CT scan of nose and PNS 1 mm cut or 0.6 mm cut. In earlier time, the CT scan was 2 to 3 mm cut. But if the 2 or 3 mm cut, then the cell may be missed. Very important information may be missed. So, if you ask CT scan, always write HRCT or CT scan nose and PNS 0.6 to 1 mm cut in multiplanar like axial, coronal and sagittal. Because coronal scan, you can read more of the structures and some structures are better seen in axial or some are better seen in sagittal. So, first of all, I take my audience through the coronal CT. What is coronal? To just recapitulate, if you cut the nose, if you cut the slice from anterior to posterior like this, it will be the coronal. So now I describe the coronal CT. What is this? We go from anterior to posterior. Like, so my first cut is the soft tissue over the frontal bone. This is soft tissue and this is the nasal bone. Just glimpse of the nasal bone we can see. And this is the cartilaginous part of nasal septum. So my next cut, just I go 1 millimeter behind. That means the anterior to posterior. So what is this? You see here, the earlier cut was the soft tissue, but now you see the bones. What is this bone? The frontal bone is coming in my picture. And this is the nasal bone. When you read the CT, you should go for cut by cut, not jump. So I just proceed from 1 millimeter from anterior to posterior. So now I see here, what is this? This is the frontal sinus. Why it is frontal sinus? Because you see here, this is the beak. This is the beak. And my job is very easy. I make some easy, my friend Dr. Kubir. He also described several difficult things that will be easy for me to understand you. So it is frontal sinus. Why it is frontal sinus? As you see here the beak, this is the nasal bone and this is the frontonasal processes. And you see here the bony part of the septum is coming in the picture. That is the perpendicular plate of the ethmoid bone and some amount of deviation to the left. And nothing more is seen. And you see here there are two septa in between the sinus. So actually in sphenoidal sinus, one is complete septum and 2 or 3 or more incomplete septa. So it may be incomplete septa. So here is my foreign delegate, and I welcome you, Dr. Medigari and Dr. Tusharkanti Ghosh, and has a big hand for them. So my next card, you see here the earlier card. This is two partition, right? But in 1 millimeter posterior, you see here this septa is digiaperi. That means it is incomplete. And you see here this same this is the nasal bone, this is the frontal sinus, and these two are frontonasal processes, and it is the maxillary crest. And there is no other sinuses appear in this film. So I go far posterior, like, so here you see this is a thick bone, right? This bone is nothing but the beak. You know the frontal sinus drain posteriorly, just posteriorly. So the next picture you see, here you see the beak is disappearing. The thick bone is disappearing. Now, one thing, see here, this is a sinus appearing. It is maxillary sinus. Just glimpse of the maxillary sinus, not the true sinus. Just anterior part of the maxillary sinus. And you see here, what is this? The more anterior part, and it is the lacrimal bone. So, here is a cell. It is the agar cell, not the bulla, because bulla will come far posterior. So the most anterior, when you see the maxillary sinus is just appearing and one cell is in the lacrimal area, this is the agar the most anterior ethmoidal cell. You know, in sinuses, there are many cells, anterior cell, posterior ethmoidal cell, but some cell take their fancy name, like agar like suprapolar cell, like infraorbital cell, frontal cell, Onodi cell. These are nothing. These are the population of ethmoidal cell. When they migrate different area, they take the different name. Like when enteroethmoidal cell migrate and pneumatize the lacrimal bone, then it take the name aganese. Aganese is nothing. It is a population of enteroethmoidal cell. So you see here, this is the last part of the beak, and you see here for my next card. You see here, this is the glimpse of middle turbinate. This is the glimpse of middle turbinate. You see this middle turbinate has got 3 parts. The first part, second part, third part. Now I see only the first part. And you know the first part lies in the sagittal plane. And you see here, this is the maxillary sinus, just anterior part, and it is this soft tissue is the inferior turbinate. So this is a aganese. When we uncover, and you see here, and one more thing is appear here, this is the lacrimal duct. So, if you go in during the face surgery for my junior colleague, you see here we do the frontal sinus surgery and frontal recess. If you want to enter into the frontal sinus, you need to do the proper uncinectomy, then you remove the aganese. After removing the aganese, you will uncover the frontal recess. So it is the frontal recess area. So why it is frontal recess? And another thing, you see here, this is a frontal sinus like thing, like an extension. Is it frontal sinus? No, it is not frontal sinus. It is a supraorbital cell. When enteroethmoidal cell migrate through the maxillary, through the this orbital process, then it takes a name supraorbital cell. So it is also a enteroethmoidal cell. So it is also the aganese, lacrimal duct, and this is the supraorbital cell. And you see here the middle turbinate, just first part is attached to the junction of a horizontal lamella and lateral lamella. Here is one thing you see here. This is the proper maxillary sinus. This is our proper maxillary sinus, and this is middle turbinate, but here middle turbinate is pneumatized. When middle turbinate is pneumatized, then it is called concha bullosa. And it is the inferior turbinate, and here you see this is a cell. But this cell is not like aganese. Why it is not aganese? Here you see it is more posterior cell. Why posterior? You see here one thing more. It is the uncinate. It is the uncinate process. So here this uncinate process, you know the uncinate process, it has three insertion. Like one is in the lamina papyracea most of the time, and sometimes it uncinate goes above and inserted into the skull base, and sometimes it attached into the middle turbinate. So, and this is the cristagalli. You see here it is the cristagalli, and this is the our olfactory fossa, and here you see the beautiful lateral lamella and horizontal lamella. Anything more? One more cell is appear here. It is your infraorbital cell. So this cell is known as Heller cell. This is known as Heller cell. Earlier I told you, when this enteroethmoidal cell pneumatized the lacrimal bone, it is called aganese. When the orbital bone, it is called supraorbital cell. When it pneumatized the infraorbital bone, it is called Heller cell. When it is pneumatized the middle turbinate, then it is called concha bullosa. So enteroethmoidal cell takes fancy name when they pneumatize different parts of the bone. Okay. So if I give this picture only, so just for identification, it is maxilla. It is you see here it is the bulla ethmoidalis. This is supraorbital cell. This is cristagalli, and this is middle turbinate concha bullosa. So here I go more posterior, just cell by cell. Here what you see here? You see here the middle turbinate. It is the middle turbinate, but middle turbinate is turning laterally. You see here, this is the middle turbinate turning laterally. You just correlate earlier. Here is the middle turbinate. Okay, it is the first part. But if go posterior, then you see here this middle turbinate is turning laterally. That means when middle turbinate turning laterally and it attaches or inserted in the lamina papyracea, it is called basal lamella. It is called basal lamella. When you see the basal lamella, you should be careful that you are in the most posterior part of the endorythmoid. You are the most last limit of the endorythmoid. And in this situation, you will see your orbit. In the orbit, you will see there is change. What change? This is the, you see here, this is the conical projection. It is known as the Kennedy nipple, and this canal leads to the endorythmoidal artery. You know the endorythmoidal artery in face surgeon, it is very important to understand the course of endorythmoidal artery. Endorythmoidal artery arises from the orbit. You see here, it is the superior rectus, it is inferior rectus, it is medial rectus, it is lateral rectus, and it is optic nerve. And you see here, it is the superior oblique. So, superior oblique and medial rectus, in between these, there is a confluence or is a gap. Through this gap, the endorythmoidal artery arises from the ophthalmic artery, and it leaps the orbit through this Kennedy canal, open nipple, or this canal, this, and it traverses different compartments like the roof of the ethmoid. So then it pierces the lateral lamella. It pierces the lateral lamella, and it enters into the cranial cavity. And that after entering the cranial cavity, it runs anteriorly and meets the sulcus and gives anterior falcian artery. And it again leaps into the cranial cavity to the nose. Again come to the nose. So endorythmoidal artery has got 4 compartments, right? Number 1 is orbit. Number 2 is the roof of the ethmoid, extracranial. It is also extracranial. Again, intracranial is olfactory fossa, and it comes again in the extracranial. And for my junior surgeons or those who want to do the face surgery, the tips here, the endorythmoidal artery injury is a very dangerous complication, and it is, we are very much scared of the injury to this. So what is the tips? You know, endorythmoidal artery is a 0.9 millimeter thickness artery, very thin artery. So if you injure the endorythmoidal artery near the orbit, then it may retract into the orbital orbit. You know, orbit is a surrounded by a bone. So the orbit cannot accommodate even more than 5 to 7 mm blood. So if it retracts and enter into the orbit, that causes the paralysis or injury to the optic nerve and blindness. So should be careful. What is the tips? You don't work close to the orbit. If you injure, if you always try to keep your instrument in middle. Here is the middle turbinate, here is the your lamina papyracea. You should be keeping middle. If you injure this here, just it's very easy to cauterize, or if put a pack, it will stop. So I go next. What is this? This is my more posterior. So after the removing the basal lamella or ground lamella, I enter into the posterior ethmoid. You know, the endorythmoidal cell is multiple in number, like 5, 7 or 10, 12. But posterior ethmoidal cell number is less, 3 to 4, but they are larger. And why it is posterior ethmoid? You see here, the orbital size is smaller. Earlier orbit is big. Here the maxilla become oval. And you see here, the third part of the middle turbinate is the middle turbinate, and you see earlier the first part, second part, and it is the third part. This is the third part of the middle turbinate. You know, third part is attaches into the perpendicular plate of the palatine bone. And you see here the roof of the ethmoid. This is thick. Earlier the roof is shallow. The roof is shallow and thin, but here the roof is thick. This thick roof is always indicate it is posterior ethmoidal roof. And you see here, this is the big 3 or 4 cell. So with this consideration, it is these cells are posterior ethmoidal cell. Why? This posterior cell, here it is the posterior ethmoidal roof. The maxillary sinus become oval, but I think I reach the most posterior part of the maxillary sinus, and the last part of the posterior, you know, the middle turbinate, third part of the middle turbinate is appearing, and you see here the glimpse of superior turbinate. This is the superior turbinate. So when we do the operation and the sinus work, like sphenoid sinus, তো সেই ক্ষেত্রে আমরা কি করি, যে স্ফেনার সাইনাসে ঢোকার জন্য আমাদের একটা লাইন টানে। দিস ইজ দ্য ম্যাক্সিলারি লাইন। দিস ম্যাক্সিলারি লাইন ইজ ইম্পর্টেন্ট ফর দ্য সার্জন টু এন্টার ইনটু দ্য sphenoid. What is that maxillary line? You see, this is your maxilla. This is your maxilla. This is the roof of the maxilla, okay? If I draw an imaginary line from the roof of the maxilla to the septum like this, just like this, okay? This line corresponds to the maxillary line. And the junction where the maxillary line meet with the septum, this area indicate that your sphenoidal opening is just that level or below, not above, not above. So in case of doing the find out the in life surgery session situation to find out the our ostium of sphenoid, then we need to remove some part of superior turbinate and some part of posterior ethmoid. If you do this and you just follow the septum and you just let your elevator into the fall into the opening. So it is very easy to find out the maxillary sphenoid ostium. One thing here, it is see here, this is a pneumatization. This is called septal pneumatization. This is called septal pneumatization. And one of my resident can ask me, sir, why not it is sphenoid? Why not it is sphenoid sinus? It may be sphenoid, but sphenoid sinus যদি হয় সেই ক্ষেত্রে এই সেপ্টাম থাকবে না। এই দেখেন এখানে টোটাল সেপ্টাম ইজ হিয়ার, টোটাল ফুল সেপ্টাম ইজ হিয়ার, and you see inferior turbinate, middle turbinate and superior turbinate. So it is never ever sphenoid sinus. Hey. Now here it is sphenoid sinus. Why it is sphenoid sinus? You see here, this is the anterior clinoid process or lesser wing of the sphenoid. It is the greater wing of the sphenoid, and these are the processes. And here you see, these are the intersphenoidal septum, and this is your proper sphenoidal sinus, and it is the rostrum, and this is the last part of the inferior turbinate, just last part of the inferior turbinate. So this is our inferior, this is our sphenoid sinus, and you see here there is a pneumatization here, or there is a gap. It is the optic nerve. The impression is optic nerve, and it is the another impression, shallow impression. It is correspond to the carotid artery, and in between optic and carotid there is a gap. It is not so prominent. Here is some prominent. It is called opticocarotid recess. And you see here there are two opening here. It is the V1, it is V2. It is Vedian canal and it is foramina rotundum. So sometimes this in between foramina rotundum and Vedian canal there may be sometimes pneumatization. Later on I will see you. So that's all about our coronal section. One thing I leave here. And now, you know, some structures are better seen in axial. But what is this structure like? The nasopharynx. Nasopharynx is well seen through the axial cut. So you see here, this is the eustachian tube opening. It is the tubal elevation, and here is the fossa of the Rosenmoller. So if you want to see the nasopharynx, you look for axial cut. And orbit is also well seen in axial cut. You see, this is the orbit, and this is your optic nerve, and you can compare both orbit in axial cut. And septum is well seen in axial cut. You see here, there is a good amount of deviation to the right. And sometimes you need to understand the sagittal cut. So in sagittal cut, you can see the full picture of this, all the sinuses here. Okay. So it is the agarnese, it is middle turbinate, and you see this is the this is anterolateral cell, this is the sphenoid sinus. Okay. So now the Caros classification, some important issue. Already my friend told you the Caros classification. Caros classification is very important. You know, what is this? Actually, it is the depth of the olfactory fossa. তো এটা আমার জানার দরকার কি, যেটা বাবর স্যার যেটা বললেন যে টাইপ 1, টাইপ 2, টাইপ 3। টাইপ 3 মানে কি? টাইপ 3 মানে হচ্ছে যখন when the olfactory depth of the olfactory fossa is more than 7 centimeter, like 15 or 16 centimeter, it means that your olfactory brain is low down, and when you work, open the frontal recess, that time what is your boundary? Your boundary is laterally lamina papyracea, medially middle turbinate. So if you understand before your operation that you have the Caros type 3, that means your olfactory fossa is your very close to your operation, so it may injure, and there may be injury to the lateral lamella, and there is a chance of CSF leak. So it is not contraindicated, it is the very conscious operation, and it should be careful, then you will not injure it. So Caros less than 1 to 3 millimeter is type 1, it is very good. 2 is no problem, but when it is 3, then you should be careful when you work in the frontal recess area. Okay. Sometimes this cribriform plate may variable, not the same in both sides. So before operation, if you see here, see this is not the same plate. It is low down and it is up above, and here is this is the this is not variable. This is not same plate. So before operation, we should look for this cribriform plate. Most of the time, we depend on the report of our radiologist. But as a surgeon, you need to understand what is your limitation, what problem you have to face during operation. So anterolateral artery, already I told you. Posterior artery, yes. This is the posterior artery. You see here, why it is posterior? You see this is a flatter roof, thicker roof, and orbit is smaller, and this is your maxillary sinus is oval, and so these are the posterior cell. So it is a posterior artery, and you understand. You should be keep in your mind, posterior artery. It is also the last limit of your posterior cell. Already, my friend Khobiruddin told you the cone cell. What is cone cell? You know, when we would started operation, the frontal recess work. Frontal recess work, first we do the remove the agarnese and we uncover the frontal recess. After removing the agarnese, we do not find the frontal recess. Why? There are some more cell. The junior colleague, I request you to understand the agar nezi. After removing the agar nezi, we find out, look for frontal recess leads to the frontal sinus. But sometimes we cannot find out the frontal recess or frontal sinus. Cannot find out? ওইখানে কতগুলো সেল থাকে, ওই সেলগুলো সম্বন্ধে আমাকে প্রিভেলি বুঝতে হবে জিনিসটা কি। ওইগুলোকে বলা হয় ফ্রন্টো ইথময়েডাল সেল, ওদেরকে বলে ফ্রন্টো ইথময়েডাল সেল। এই ফ্রন্টো ইথময়েডাল সেলগুলোকে এই কোন ক্লাসিফাই করছে? টাইপ 1, টাইপ 2, টাইপ 3, টাইপ 4। সো আমি আগার নিজেকে সরালাম, তারপরে যদি আমার একটা সেল থাকে, ওয়ান মোর সেল ফ্রন্টাল সেল থাকে, আমি যদি ওইটা রিমুভ না করি, আই উইল নট নেভার এন্টার ইনটু দ্য ফ্রন্টাল সাইনাস। সো প্রি অপারেটিভ আমাকে জানতে হবে যে ইজ দেয়ার এনি ফ্রন্টাল সেল। সো ইফ ওয়ান সেল অ্যাবাভ দ্য agar, it is called type 1 frontal. If two or more cell above the agar but not reach the above the 50%, it is called type 2. And if the frontal cell reaches the frontal sinus, not the recess, it goes above the frontal recess and occupying the frontal sinus up to the 15%, 50%, it is called type 3. আর sometimes যদি এরা পুরো ফ্রন্টাল সাইনাস উপরে চলে যায়, পুরোটাকে দখল করে নেয়, তখন থাকবে টাইপ 4। সো আমাদেরকে যদি এই ফ্রন্টাল সাইনাসের টাইপ 1, টাইপ 2, টাইপ 3 দিস এই 4 সেল যদি ইফ ইউ ডু আন্ডারস্ট্যান্ড, তাহলে অপারেশন করতে গেলে আমাদের অনেক সময় আমরা we fall in a trouble. So these are the frontal cell and these are the frontobular cell, suprabular cell, these are the cell, okay. And another classification is, it is international classification, just location অনুযায়ী, যেমন ধরুন agar nezi cell, anterior cell, agar nezi, supra agar, there is frontal cell, supra agar frontal, that is type 4 frontal cell. Another classification, ফ্রন্টো ইথময়েডাল সেলের একটা হচ্ছে ক্লাসিফিকেশন, যেটাকে আমি বললাম যে কোন ক্লাসিফিকেশন, ইট ইজ ইজি টু আন্ডারস্ট্যান্ড, বাট ফর দ্য সেম আন্ডারস্ট্যান্ডিং অফ রেডিওলজিস্ট as well as the surgeon, international classification is applied. It is in the year of 2018 or 16. And why it is adopted? Because it is more precise, as it is a position, and it is named after anterior, posterior and medial. So it is very easy communication, both surgeons and radiologists. But when we call the frontal type 1, frontal type 3, frontal 4, বুঝতে একটু অসুবিধা হয়। বাট আমরা যদি বলি যে এইভাবে বলি যে agar nezi, supra agar frontal, তাহলে বুঝতে সুবিধা হয় যে ইট ইজ আগারের উপরে আছে, agar neziর উপরে আছে, আর একটু উপরে আছে, তাই না? তাই ইট ইজ ইজি আন্ডারস্ট্যান্ডিং ফর আওয়ার জুনিয়র্স। বাট আমি যদি বলি যে ফ্রন্টাল সেল টাইপ 4, তার মাথায় নাও ঢুকতে পারে। বাট আমি যদি বলি যে agar nezi, তার উপরে সুপ্রা agar, তার মানে সুপ্রা agar ফ্রন্টাল মানে কি? মানে হলো এগারের উপর যদি থাকে, এটা হলো আপনার কি বলে টাইপ 1 ফ্রন্টাল, টাইপ 2 ফ্রন্টাল, আর যখন ফ্রন্টালের উপরে চলে যাবে তখন টাইপ 4। এই সময় লাগবে। এই লেকচারটা আমি ফরচুনেট, আই গট মোর টাইম, কারণ এরপরে লাইফ সার্জারি দেরি আছে এবং আমাদের এই হবে স্যাররা আমাদের ইনোগ্রেশন হবে তো। সো আই এম ভেরি মাচ প্রিভিলেজড যে আমি আপনাদের সামনে আরো 10-15 মিনিট থাকতে পারবো, যদি আপনাদের ভালো লাগে, যদি ভালো লাগে, রাইট? আচ্ছা, তাহলে এই যে এটাও একটা ক্লাসিফিকেশন, এটা হচ্ছে অ্যানাটমিক্যাল ক্লাসিফিকেশন, মানে অ্যান্টেরিয়র, পোস্টেরিয়র, ল্যাটারাল, মিডিয়াল, এরকম। পোস্টেরিয়র কি, যেমন ওই যে সুপ্রাবোলার বললাম না, যে অরবিটের উপরে চলে গেল, সুপ্রাবোলার ফ্রন্টাল, সুপ্রাবোলার ইথময়েডাল, ওকে। আচ্ছা, এই যে মিডল টার্মিনেটের যে এটা হচ্ছে আনসিনেট, আনসিনেটের ইনসারশনটা খুব ইম্পর্টেন্ট। যে নর্মাল যেটা আমরা টাইপ 1 আনসিনেট, অর্থাৎ যে 95% ক্ষেত্রে বা 90% ক্ষেত্রে আনসিনেট ইনসার্টেড ইনটু দ্য, এটা কি লেমিনা পেপরিশিয়া, সেই ক্ষেত্রে কি হয়, আমাদের ফ্রন্টাল সাইডের ড্রেন এইদিকে হবে ইন দ্য ইনফান্ডিবুলাম, ওকে। আর যদি আনসিনেটেড সামটাইমস টাইপ 2 ইনসারশন, লাইক যেমন ধরুন আপনার এটা স্কাল বেস বা কিউবিফর্ম প্লেটে চলে গেল, অথবা মিডল টার্মিনেটে গেল, যদি এরকম হয় তখন ফ্রন্টাল সাইনাসের ড্রেনেজটা তখন হয়ে যায় কি এইদিকে আসতে পারে, ডানে আসে, এটা কি হয়, ইট গোজ ইনটু দ্য মেক্সিলারি সাইনাস। তো যদি টাইপ 2 এবং টাইপ 3 আনসিনেট ইনসারশন হয়, তাহলে সেই ক্ষেত্রে আপনার দুইটা প্রবলেম হবে। যখন আপনি অপারেশন করবেন, ইন দ্য টাইম অফ ইউর সার্জারি আপনি দেখবেন আনসিনেট খুঁজে পাচ্ছেন না, আনসিনেট চলে যাচ্ছে মিডিয়ালি, আনসিনেট চলে যাচ্ছে সেপ্টামের দিকে, মিডল টার্মিনেটের দিকে, আনসিনেট চলে যাচ্ছে ব্রেনের দিকে। সো জানতে হবে যে আনসিনেট সব অল দ্য টাইম নট ইনসার্টেড ইন দ্য লেমিনা পেপরিশিয়া। Sometimes 4 or 5% time the uncinate may be inserted in the skull base or in the middle turbinate. That time it is very difficult for surgeons to do the proper uncinectomy. And if the uncinate insertion not the classical, the abnormal insertion like 2 or 3, that time you may find out the coexistent frontal and maxillary sinusitis. That time you may not find the ethmoidal sinusitis. Okay. This is the frontal type 1. You see here, this is the cone, aganesi. It is aganesi, একটা সেল উপরে আছে টাইপ 1 ফ্রন্টাল, যদি দুইটা সেল থাকে তাকে বলে টাইপ 2 ফ্রন্টাল। ওকে, ডিড ইউ ফলো মি? ওকে, তারপর হচ্ছে এই যে যখন এই অ্যাগানেজের উপরে মোর 2 or 3 সেল থাকবে, মোর দেন 2 or 3 সেল, অ্যান্ড দ্যাট এন্টার্স দ্য ফ্রন্টাল সাইনাস আপ টু দ্য 50%, ইট ইজ কল্ড টাইপ 3। আর যখন দখল করে ফেলবে আমেরিকার মতো, এটা হবে কি টাইপ 4, এটা হবে কি টাইপ 4। ভেরি ডিফিকাল্ট। দ্যাট টাইম বাবর সাল লাগবে, তখন ইয়া করা লাগবে, বিগকে ড্রিল করা লাগবে, করা যাবে, নট আনকমন। ওকে, এই যে বললাম না পোস্টেরিয়র সেল, একটু আগে যে বলছিলাম আমি যে অ্যান্টেরিয়র সেল, যেমন এগার, সুপ্রায়াগার ফ্রন্টাল, বাট এটা হলো পোস্টেরিয়র সেল। এই যে পোস্টেরিয়র সেল, এটা হলো ফ্রন্টো বোলার সেল, এটা হচ্ছে ফ্রন্টো বোলার, মানে পিছন দিক থেকে আসতেছে। এখন এই যে সেলগুলো, এই যে হেলার সেল, ধরুন কি বলে এই কনচাবুলুসা, তারপরে ধরুন আপনি অ্যাগারনেজি, ফ্রন্টাল সেল, সুপ্রাবোলার সেল, এইগুলোর কি কাজ কি? এগুলোর কোনো কাজই নাই। এগুলোর কাজ হচ্ছে কি ডিস্টার্ব করা, এগুলোর কাজ হচ্ছে প্যাথোলজি ক্রিয়েট করা, এগুলোর কাজ হচ্ছে এই যে ফ্রন্টাল সাইনাসের যে ড্রেনেজ, এগুলোকে ভেজাল করা। কারণ যখনই কেউ নাম চেঞ্জ করে বুঝতে হবে যে তার মতলব খারাপ, তার মতলব খারাপ, রাইট? আন্ডারস্ট্যান্ড? সো দিস এন্ড্রেথমেন্টাল সেল, এগুলির কোনো কাজই নাই। ওরা করে কি, তারা নাম পাল্টায়া, কেউ হেলার সেল, কেউ সুপ্রাবোলার সেল, কেউ কি কনচাবুলুসা করে, ওরা কি করছে, দে ক্রিয়েট সাম কি প্রবলেম ইন দ্য ড্রেনেজ পাথওয়ে এন্ড ক্রিয়েট সাইনোসাইটিস অর আদার প্যাথোলজিস। ওকে, so now I come to the sphenoid sinus. These are the triggers hidden. See here, এটা হচ্ছে B1, B2 এদিকে, এই যে B2, আর এটা হচ্ছে কি ক্যারোটিড। দেখেন আপনি ক্যারোটিড কিভাবে স্ফেনয়েড সাইনাসকে মানে কভার করে যায়। তারপর হচ্ছে অপটিক নার্ভ। ওকে, এই ছবিটা আমি পছন্দ করলাম কেন, টু আন্ডারস্ট্যান্ড দ্য মাই এন্ডোস্কোপিক সাইনাস এন্ড স্ক্যালপেল সার্জনস, যে ইউ আর ওয়ার্কিং in your close contact with both the triggers like optic and carotid. Okay. So for doing the our sphenoid sinus work, you know the sphenoid sinus depth is around 17 millimeter. Okay, and the important is to do work the sphenoid sinus. The fear is to injure the optic nerve and carotid. Optic nerve and carotid. It is a optic nerve and it is carotid. So this optic nerve যখন এই স্ফেনয়েড সাইনাস দা রান করে, তখন তার কতগুলো সিচুয়েশন তৈরি হয়, অ্যাবনর্মাল সিচুয়েশন। এগুলো কি কি? এই অর্ডিনারি কি বলে ডিলালো এন্ড এটল, দে ক্লাসিফাইড দ্য রিলেশন অফ অপটিক নার্ভ উইথ দ্য স্ফেনয়েড ইন টাইপ 4. টাইপ 1 ইজ হোয়াট? জাস্ট নর্মাল টাইপ, জাস্ট স্ফেনয়েডের উপর থাকবে, কোনো ইমপ্রেশন ক্রিয়েট করবে না। সো টাইপ 1 ইজ ভেরি গুড ফর আস বিকজ অপটিক নার্ভ ইজ অ্যাবাভ দ্য স্ফেনয়েড সাইনাস। অ্যান্ড টাইপ 2 ইজ হোয়াট? টাইপ 2? টাইপ 2 ইজ হোয়েন দ্যার ইজ এ ডিপ্রেশন। যখন এটা ডিপ্রেশনে চলে যাবে, অর্থাৎ আমাদের স্ফেনয়েডের ভিতরে ঢুকবে। টাইপ 3 কি? যখন অপটিক নার্ভ আমাদের কি করবে, স্পেনার সাইনাস দিয়ে রান করবে, টাইপ 3, অ্যান্ড টাইপ 4 যখন এটা পোস্ট উৎপন্ন সেল এবং স্পেনার দিয়ে যাবে তখন টাইপ 4. সো টাইপ 3 and type 4 is more dangerous for the surgeon. So you should be careful during sphenoid work. You have to understand the relation of optic nerve with the sphenoid. These are the 4 types of optic nerve with sphenoid. So what do you look for during surgery? The cribriform plate, the Keros, it is already done, and wait. So this is the normal variation, like halar cell, infororbital cell, concha bullosa, paradoxical key. When the middle tavenate rotate medially, it is called paradoxical rotation. It is also produces some pathology. And this is the nasal septum deviation is a spar. So I want to share some experience. What is this? The ONOD cell. What is ONOD? আমরা এতক্ষণ যেগুলি বললাম যে আমরা হেলার সেল, আগান্নেজি, তারপরে কি সুপ্রাঅরবিটাল, ফ্রন্টাল, সুপ্রাবোলার, ফ্রন্টোবোলার, অল আর দ্য বংশধর অফ এন্ডোরিথমাটাল সেল. ওরা কাদের বংশধর? এন্ডোরিথমাটাল সেল. বাট অনোডি ইজ দ্য অরিজিন ফ্রম পোস্টোরিথময়েড. When post-rhythmal cell occupies the area of sphenoid, তখন তাকে বলে অনোডি. পোস্টেরিয়র সেল যখন স্ফেনয়েডকে দখল করে তখন তার নাম হয় কি? অনোডি. আপনারা এখানে দেখেন, খেয়াল করেন, এই যে এটা স্ফেনয়েড সাইনাস, বাট হওয়ার কথা ছিল কি? এই পুরাটা স্ফেনয়েড, তাই না? পুরাটা কথা ছিল না? এই যে এটা যদি আমরা অপটিক নার্ভ হয়, এটা যদি ক্যারোটিড হয়, এটা V2, এটা V1, তো এইটা এখানে ছিল কি আমাদের স্ফেনয়েড সাইনাস, পুরোটা হওয়ার কথা ছিল. বাট এই স্ফেনয়েড সাইনাসের উপরের অংশটা দখল করছে কে? Post-rhythmal cell. Some of the post-rhythmal cell migrate the sphenoid sinus and occupying this sphenoid area. Then it takes a fancy name. It is called onody. It is called onody. So in onody situation, there is very dangerous for surgeon. He may meet with some complication like optic or carotid. একটা কথা মনে রাখতে হবে, যখনই কেউ কারো জায়গা দখল করে তখন তো এটা শেয়ারিং হয়, তাই না? শেয়ারিং হবে না? যখন ধরুন এই হলে যদি আরো 50 জন ঢুকে, তাহলে মানুষগুলো কি হবে? চাপাচাপি হবে. তো এখন যদি অনোডি যদি স্ফেনয়েড ভিতরে ঢুকে, তাহলে কি হবে? স্ফেনয়েড জায়গা কমে যাবে না? তখন এই বোনগুলো কি হবে? এই বোনগুলো হবে পাতলা হয়ে যাবে. তাদের যে স্ফেনয়েড সাইনাসের যে বোনগুলো ছিল, দে বিকাম থিনার, রাইট? যখন এই থিনার হয়ে যাবে তখন দেয়ার মে বি এ চান্স অফ ডেহিসেস ইন দ্য অপটিক নার্ভ, ডেহিসেস ইন দ্য ক্যারোটিড. সো ইন অনোডি সিচুয়েশন, very dangerous. You may meet with sometimes dear audience, we are welcoming our chief guest, Professor Pangopal Dotto sir. Sir, 2 to 3 minutes, sir. Okay. So when the post-rhythmal cell occupying the area of the sphenoid, then it takes the name, fancy name, the onody. When there is a onody situation, you should keep in your mind there may be a bone dehiscence. There may be bone dehiscence. If there is a dehiscence, then optic nerve or carotid may be dehiscent, and that time during sphenoid work you may meet up with you may face some complications, injury to the optic nerve or injury to the carotid. So sphenoid, when you do the scalpel surgery, sometimes you try to do the pituitary work. When you do the pituitary work, you need to understand the sphenoid pneumatization. Already you told, when there is a consal variety. What is consal? When the sphenoidal pneumatization less amount and there is a bone in between the sphenoid sinus and the sella. This good amount of bone. So before doing operation, if you see the CT, you need to do more bone work to enter into the sella, okay? And when the precellar means when the pneumatization of the sphenoid sinus are very close to the sella. So if this type of pneumatization, it is far easier than this type. You need to less amount of bone to drill to enter into the pituitary. And the cellar means the immunization goes beyond the cellar. So that time it is even not do any type of work. So you just enter into the sphenoid and you just enter the pituitary. So this is important. And I need one more slide, this last slide. So sphenoid pneumatization. You see here, sometimes this is sphenoid sinus and this is V1, this is V2, and here is some pneumatization. In between V1 and V2, the lateral process is pneumatized. This is called the lateral recess of the sphenoid, and it is the keratoco optic recess. It is the optic nerve. It is the carotid. So when there is excessive pneumatization, like lateral recess of the sphenoid sinus or opticocarotid recess pneumatization, that time there may be thinning of the bone, and you may find out the CSF leak in lateral recess of the sphenoid. Here is Babur sir. I do. He agree with me, sir. So in this type of pneumatization, there is a very thin slice of bone, and there may be dehiscence, and you may find out the leak here. So sometimes the leak, CSF leak, is very difficult to identify. So you need to understand that sometimes there may be a lateral recess. So your CT should be you should understand your CT. You go to the CT and you try to understand, is there any lateral recess here. And already I told you the cellar, P-cellar. Okay, thank you, sir. Thank you very much. Thank you, my audience, for giving me this opportunity to half an hour.
Thank you, Professor Ashuguraman Bhuya, for your nice presentation. It is really very much praiseworthy. Thank you very much.
Is there any question?
Any questions from the audience?
It is not question, but some comments. Number one,
Dr. Khobiruddin Patwari, you please come on the dais if the audience has any question.
when there is onodicell and sphenoid, both are coming in the CT finding. Always the superlateral one is onodicell. We have to remember this. And posterior inferior one is sphenoidal cell, sphenoidal sinus. We have to remember this. Number two, Dr. Ashik said, sometimes we have to sacrifice part of middle or posterior turbinate to reach in the sphenoid sinus. This is not the rhinologist surgeon. Rhinologist usually does not sacrifice the turbinates. It is other discipline surgeons can do this. Professor Khobir sir, I think you can remember when I was demonstrating pituitary surgery in Surawadi neurosurgery department. Everybody was telling me, why you are not sacrificing the middle terminate? I said, you wait for a while and you will see why I have not sacrificed the inferior or middle terminate. We rhinologists identify the sphenoidal ostium directly and cauterize surrounding areas and directly open the sphenoid and go into the pituitary fossa. So for the rhinologist, I think we know and we understand the anatomy better. So we have not to sacrifice the terminates. And this is my comment. And another thing, we have to understand CT scan by ourselves. We have not to depend on other disciplines. As in our country, there is no specialized radiologists for scalpage. So we have to understand. I have seen 2 cases of CSF anuria admitted at this moment in institute for demonstration purposes. And I have seen the comments of radiologists. In both of cases, I differ. Because we have to understand our anatomy and our radiology better than anyone. Because I have to operate. I should not depend on other disciplines. Thank you, sir.
Any question from the audience? I have 2 questions for Ashik sir. So first of all, what is the, we know the attachment of the uncinate process is variable. How can we take help from the CT scan in this case? And if there is any hypoplastic maxillary sinus, what is the implication of CT scan in with the attachment of the uncinate process?
Thank you. Actually, this lecture is given for the surgeons.
Sir.
You know, already the Babar sir told the city we depend on the radiologist. You know, radiologists they have some limitation. They need to report all the sites of radiology. But specifically the sinus radiology, it is very difficult and it is very time demanding. So you need to understand yourself. You surgeon, you should understand the radiology and you should look for your specific point that I already told you.
No, sir.
And your question is the uncinate process. And just I go for my presentation here. The uncinate. Wait. You see here, this is
Not sir, picture, CT scan.
picture
Sir.
though.
CT scan.
Okay,
I want to know the
Okay,
CT
okay.
scan and the relation of the
Wait,
uncinate
wait.
process with the maxillary sinus.
Wait. Here you see, this is your maxilla. This is your true maxilla. This is your inferior turbinate. This is the middle turbinate, and this is your bola. It is bola. Okay. So when you see the full-blown maxilla, the bola ethmoidalis, okay, then you look for uncinate, not before. Like you will not find here the uncinate. You will not find here this uncinate. So the tips for my junior students or resident, when you look for uncinate in the city, that question is invited from here. So you see here A. So my full-blown maxilla, okay, my ethmoidal bola, middle turbinate, this is the uncinate, okay. This is your uncinate. And this is uncinate and the bola. In between this space, it is called hiatus semillunaris inferioris. And this leads to three-dimensional area, the infundibulum below, okay. You understand?
second question.
And this uncinate and attaches in the laminar papilla. Sometimes it goes in the skull base or in the middle turbinate, okay.
So thank you, sir. Thank you.
Any more questions?
স্যার ওই মানে আরেকটা কোশ্চেন শুধু ছিল লাস্ট আমরা অ্যান্ট্রোইথময়েড থেকে যে পোস্টোইথময়েড আর পোস্টোইথময়েড থেকে স্ফেনয়েড which landmark can define in the CT scan that antroithmoid has ended and postoethmoid has started? Which landmark?
Already I told you are not you don't follow me. When you see in a CT scan the endothelial artery, that means it is an orbit.
Antroithmoid শেষ হয়ে স্যার
You see here there is a conical projection, not above. So right now we see the conical projection in the orbit, okay. This is conical projection, and you see here the middle turbinate turning laterally to attach into the laminar papilla. When in the CT you see the level of endothelial artery and the laminar and the basal lamella, you keep in your mind you are in the most posterior part of the endothelium, your last limit of the endothelium, okay.
yes then postoethmoid স্যার শুরু হলো
And post-treatment, এক মিনিট, হ্যাঁ এই যে post-treatment কখন পাবা বলবা তুমি? এই দেখো যখন তোমার এই যে ফ্ল্যাটার রুফ, এই যে রুফ দেখছো তুমি, রুফ ইজ ফ্ল্যাটার। এর আগের রুফটা ছিল কি? এর আগের রুফটা ছিল এই যে শ্যালো ছিল, কেমন? ইয়েস, মানে থিকার, ফ্ল্যাটার, এবং তুমি দেখবা যে maxillary sinus is becoming oval, and orbit, right, see here, orbit become smaller, okay, and you can find out the three turbinate, like superior turbinate, middle turbinate, third part, and the interturbinate. Then you see there are 2 or 3 cell here, okay.
Yes.
So it is nothing but the post-treatmental cell.
yes thank you
Okay,
sir.
thank you.
Thank you sir.
Thank you very much. We have completed our 2 topics. The first topics on lecture on the bones, lecture on the anatomy, and the second topic was CT scan on surgical point of view. So we will proceed out to our next session. It will be an inaugural session. Our chief guest, Professor Pran Gopal Dotto, MP sir, is present here. before proceeding to the inaugural session, we like to present the memento to the chairpersons and to the presenters. I request Professor Zakaria Sarkar, director of this institute, to come on the dais and present the memento to the chairpersons and to the presenters. So first, the junior most rapporteur here, Dr. Khaled Jahan Bipu, is presented with a memento by Professor Dr. Zakaria Sarkar. May I now request Professor Sheikh Hasanur Rahman Babur, who was chairperson on the previous session, please come on the dais and take his memento. Next, Professor Sheikh Hasanur Rahman Babur, chairperson of this session. Oh, Shahjahan Batpuri ji sir. Dr. Shahjahan Sarkar was rapporteur of the previous session. Professor Sheikh Nurul Fattah Rumi. Next, Professor Khobiruddin Ahmed sir. Professor Khobiruddin Ahmed sir was the first president of our society, Bangladesh Endoscopic Sinus and Skull Base Surgery Society, was inaugurated by Professor Khobiruddin Ahmed sir back in 2015. Professor Khobiruddin Ahmed sir was the chairperson of this session, and Professor Dr. Zakaria Sarkar is presenting the memento to Professor Khobiruddin Ahmed sir. And last, our teacher and founder director of National Institute of ENT, Professor Muhammad Abdullah sir, is presented a memento by Professor Dr. Sarkar. Now the presenter, nice oration by Dr. Khobiruddin Patwari. I request Dr. Khobiruddin Patwari to take his memento from Professor Dr. Zakaria Sarkar. And the last person to take the memento is our very known face, Professor Dr. Muhammad Ashikur Rahman Bhuiya. He is presented with a memento by Professor Dr. Zakaria Sarkar. After the inaugural session, there will be live surgery session by Dr. Gaurav Medikari. But before that, we will have our inaugural session, and today's chief guest is Professor Prangopal Datta MP sir, who is present with us. So I like to request the chairpersons and the presenters to take their seats on the stage, on the audience. আরেকটা নোটিশ একটু বলে দেই, আমাদের উপরেও কিন্তু বসার ব্যবস্থা আছে। যদি এখানে কেউ কমফোর্টেবল ফিল না করেন, যদি অডিয়েন্স ফুল হয়ে যায়, they can go to the upstairs and can take their seats. Good morning and welcome to the 8th National Live Endoscopic Sinus and Skull Base Surgery Conference. This conference is organized by Bangladesh Endoscopic Sinus and Skull Base Society in collaboration with Medical Education and Health Manpower Development Division of DGME, Director General of Medical Education. And the conference venue is this auditorium of National Institute of ENT, and the cadaveric dissection will be performed in the morgue of Shohid Sohrawardi Medical College Hospital, which will be live telecast in this auditorium. It is our immense pleasure to have among us our teacher, our mentor, guardian of ENT family, and Member of the Parliament, Professor Pran Gopal Dotto MP sir, as our chief guest in this inaugural ceremony. Dr. Mohammad Mosharraf Hossain Khandokar, Line Director DGME, will present as special guest. Founder Secretary Professor Alamgir Choudhury sir is also present among us, whose visionary leadership and opened a recent avenue on ENT and head neck surgery and exposed our ENT surgeon and his organization organizing this 8th workshop in consecutive years has given us the scope to expertise in the field of endoscopic sinus surgery. May I now request Professor Dr. Zakaria Sarkar, who will preside this inaugural session, to accompany the honorable guests and form the dais. May I also request Professor Muhammad Abdullah sir to come on the dais and form the dais. He is the founder. May I request Professor Ashikur Rahman Bhuiya to deliver his welcome speech on this 8th conference, 8th Endoscopic Sinus and Skull-Based Surgery Conference. Professor Ashikur Rahman Bhuiya.
Bismillahirrahmanirrahim. Honorable Chief Guest of this today's conference, my teacher, Professor Pran Gopal Dotto sir, Member of this Parliament, Kumilla 7, former Vice Chancellor, Bangabandhu Sheikh Mujib Medical University, and the icon of otolaryngologists and head and neck surgeons of Bangladesh. Here is Professor Abdullah sir, the former director of this institute, and also here is Professor Alamgir Choudhury sir, the advisor of Bangladesh Endoscopic and Skull-Based Surgery. Here is Dr. Khandokar Mosharraf Hossain sir, the line director of this DGMEA, and the chairperson is our respected Professor Dr. Zakaria Sarkar sir. He is the course director and general secretary of the Endoscopic and Skull-Based Society and also the director of this institute. Assalamu alaikum and good morning. Welcome you all to this 8th International Endoscopic and Skull-Based Surgery 2024, and I also respect them, the foreign delegates from home and abroad, and also my senior teachers in front of me, Professor Ashraf sir, Professor Kamul Hossain Tarafdar sir, Professor Babur sir, Professor Khobiruddin sir, Professor Yusuf Fakir sir, and my dear colleagues. It is my proud honor to open this illustrious gathering, which brings together the world's foremost experts in the fields of otolaryngology and skull-based surgery. We are privileged to host such an array of talented professionals here, including our native delegates and especially our esteemed foreign delegates who have traveled a great distance to join us. This conference will serve as a vibrant forum for discussing the latest surgical technologies, breakthroughs in medical treatments, and cutting-edge research. It aims to bridge the gap in our current methodologies and explore integrated approaches that enhances patient care and surgical outcome. Through the keynote presentations, panel discussions, and master cadaver live dissections, we will be able to deal the complexities and the challenges of sinus and skull surgeries. We are immensely thankful for the participation of each and every of you, as your contributions are vital to the success of this conference and to the progress of our field. Let us make the most of our time together, ensuring a fruitful and rewarding experience for all. Thank you for your attention, and once again welcome to the 8th International Endoscopic and Skull Base Surgery Conference. Let us embark on the journey of discovery and advancement together. Thank you again.
আমাদের ফরেন ফ্যাকাল্টিরা আমাদের মাঝে উপস্থিত আছেন। আই লাইক টু টেক দ্য প্রিভিলেজ টু ইন্ট্রোডিউস আওয়ার ফরেন ফ্যাকাল্টি। Dr. Gaurav Medikari, he is a very known face on this skull-based surgery field in Bangladesh, and he has come many times to Bangladesh. Dr. Gaurav Medikari, please stand up, and ladies and gentlemen, please give him a big hand. Dr. Tushar Kanti Ghosh, he is also very familiar among us, and he has visited many of our conferences. Please give him a big hand. And Dr. Sanjoy Kumar Gupta. Dr. Sanjoy Kumar Gupta is also among us. He is an endoscopic and a skull-based surgeon. He is among us. Thank you very much for your taking all the hassles of coming to the Bangladesh. আমাদের মাঝে আমাদের বাংলাদেশের অনেক আমাদের শিক্ষকরা উপস্থিত আছেন। সবার নাম হয়তো আমি বলতে পারবো না। প্লিজ টেক মাই প্রিভিলেজ অ্যান্ড বাংলাদেশ আমার ন্যাশনাল ইএনটি ইনস্টিটিউটের পক্ষ থেকে তাদের এখানে স্বাগতম। প্রফেসর আবু ইউসুফ ফকির স্যার এখানে উপস্থিত আছেন। প্রফেসর আবু ইউসুফ ফকির স্যার, প্লিজ স্ট্যান্ড আপ অ্যান্ড give their blessing. Professor Khobiruddin Ahmed sir, he is my personal mentor, and I am his direct student. Professor Kamrul Hasan Tarafdar sir is here, and very known face on skull-based surgery and endoscopic sinus surgery, Professor Alamgir Chaudhary sir, to come on the dais to podium and deliver his speech.
My dear teacher, Professor Pran Gopal Datta sir, ex-president of NIENT Society Bangladesh, MP, and ex-BC of Bangabandhu Sheikh Mujibur Rahman, Sheikh Mujib University, and then Professor Abdullah sir, founder of this institute, and also he was president of Bangladesh NIENT Society. Dr. Mosharraf Hussain, line director, medical education, Dr. Zakaria, Professor Zakaria, in front, our many dignitaries. You already know from the Mamun Murshid and Ashikur Rahman. I don't want to elaborate my speeches. This Endoscopic Sinus and Skull Base Society, established in 2015, every year we organized conferences, especially the living legend of this subcontinent, Korea, Singapore, Malaysia, and one in online conference, Zoom conference during Corona from USA, joined with our conferences. It is 10 years now, but we were organizing 8 conferences. For Corona, we left 2. We missed 2. I see there are a lot of interested junior colleagues, those who are interested in sinus and skull base society. I am very happy. And now many junior ENT surgeons are doing surgery in Bangladesh. I hope more and more juniors are coming up. And in Bangladesh, patient will not go to abroad for sinus and skull base society. I wish success of this conference, and thank you very much everybody for joining this conference. Thank you all.
Thank you, sir. Thank you, Professor Alamgir Chaudhary sir. আমাদের পরবর্তীতে আমি স্টেজে পোডিয়ামে ডেকে নিতে চাই লিজেন্ডারি প্রফেসর এম আবদুল্লাহ স্যারকে, যার হাত ধরে আমাদের এই ইনস্টিটিউটের যাত্রা শুরু, এবং উনি ছিলেন আমাদের এই ইনস্টিটিউটের স্বপ্নদ্রষ্টা এবং ফাউন্ডার ডাইরেক্টর অফ দিস ন্যাশনাল ইএনটি ইনস্টিটিউট। মে আই রিকোয়েস্ট প্রফেসর এম আবদুল্লাহ স্যার টু কাম অন দ্য podium and deliver his speech.
Thank you very much. Respected Chief Guest, Professor Pran Gopal Datta, Sir, Special Guest, Dr. Mosharraf Hussain Khandekar, Professor Alamgir, Professor Zacharias, sitting in the dais, respected professors, teachers, and resident colleagues sitting in front of me. I am very delighted to be here in this morning to see the people are organizing super speciality conference in this country. I hope this conference or meeting will help our junior friends to acquire knowledge and come in contact with the super specialists, and they will be future super specialists of our country. They will extend their services to the community. I congratulate and thanks the organizers for organizing this beautiful meeting today morning. Thank you everybody. Thank you again.
থ্যাংক ইউ স্যার। আমাদের মাঝে আরও উপস্থিত আছেন প্রফেসর আশরাফুল ইসলাম স্যার। স্যার, উইল ইউ প্লিজ স্ট্যান্ড আপ? ডিয়ার অডিয়েন্স, প্লিজ গিভ হিম এ বিগ অ্যাপ্লজ। আমাদের মাঝে আরও উপস্থিত আছেন ঢাকা মেডিকেল কলেজের বিভাগীয় প্রধান প্রফেসর ডাক্তার শেখ নুরুল ফাত্তার রুমি। মে আই রিকোয়েস্ট প্রফেসর ডাক্তার শেখ নুরুল ফাত্তার রুমি টু স্ট্যান্ড আপ অ্যান্ড গিভ হিম এ বিগ হ্যান্ড। এ পর্যায়ে বক্তৃতা দেওয়ার জন্য আমি অনুরোধ করব আজকের অনুষ্ঠানের স্পেশাল গেস্ট, আমাদের ডাইরেক্টর ডিজি এমই থেকে আগত লাইন ডাইরেক্টর ডক্টর মোশাররফ হোসেন খন্দকার স্যারকে। ডক্টর মোশাররফ হোসেন খন্দকার স্যার, লাইন ডাইরেক্টর মেডিকেল এডুকেশন, স্পেশাল গেস্ট অফ টুডেজ সেশন, প্লিজ কাম অন দ্য পোডিয়াম অ্যান্ড ডেলিভার ইউর স্পিচ।
Assalamu alaikum. Honorable Chairperson of this hands-on training program, Professor Dr. Muhammad Zakaria Sarkar, Director, National Institute of ENT, and our beloved Chief Guest, Professor Pran Gopal Sir, our ex-VC and present Member of Parliament, and sitting in the chair, Abdullah Sir, and other dignitaries, and all the legend of ENT and skull-based surgery of the country, and the participant and foreign expert from India, Mr. Gaurav, Mr. Shankar, and others from India, and all the participants. I am very much delighted because this program is actually organized by our DGMA, the medical education, and you know that our operational plan, that is medical education health manpower development, is the only operational plan in our directorate. And this directorate has a new directorate and beginning from 2020 in the corona, and after that we are working very slowly. But in the development and quality and standard of medical education, we are working hard, and we have a DG and 11 director. I'm only the line director working in this scope. Actually, we are working so many ways for the improvement of and quality and standard of medical education, and we supply according to the demand of the medical college, dental college, and all maths IST, as for furniture, computer, books, for the renovation of library, and also so many training program for principals, vice principal, training of research methodology, training on teaching methodology. And this hands-on training, which is organized today, actually we are only 10 or 12 program in a year, last few years. But in this year, after my taking the charge, I have made 4 times. That is nowadays we are doing in 48 programs. And in the coming month, you have also another program. And through actually this hands-on training program is very, very important because the knowledge comes, it retains in the brain. And we know that as a brain of a surgeon, you know that when we do any learning, hands-on training has been doing right and left lobe because sometimes we have some retention in right lobe during our speaking and our seeing, we do it also right lobe. So I think this hands-on training program on endoscopic, sinus, and skull-based surgery was very interesting with the discussion on emerging new concept in endo and sinus and skull-based surgery. And we know actually that the endoscopy is a great advancement in sinus and skull-based. And nowadays it is a really great achievement. Not only that, this endosinus and skull-based evolutionary story, and we have come out a long way from a traditional treatment modalities as on disease. And as a dental surgeon, we are very, very scared about doing the oriental fistula, doing cardiac surgery. That's a very old procedure. So nowadays, this endoscopic surgery has imaginary visionary, and it will go a very, very, very long way in some decades, so that all the treatment very easily. And through this hands-on training, our main aim is to help our local participants so that they can refine their knowledge, achieve improved treatment outcomes, and more effective management of the patient. And I like to give thanks. Our foreign faculty came from India, and our local participant, local resource person. I think through their actual support, our local people update latest technique and technology so that in future they can save the time, and in their application they will be very helpful. So I like to thanks again the organizer of the program, Bangladesh Endodontic Sinus Skull-Based Society, and National Institute of ENT for their arrangement. I think our Chief Guest Pran Gopal sir is here, and also the legend here. This will be very interesting, and I hope this will continue. And next month, inshallah, we'll do another program. So I would like to ask some thing that all other persons came from institute. They can also arrange this program in outside of Dhaka. Not in Dhaka, we are trying to encourage the program should be outside of Dhaka also, so that the participant outside cannot come and we go with there. Thank you very much giving the floor. Assalamu alaikum.
ধন্যবাদ ডক্টর মোশাররফ হোসেন খন্দকার স্যারকে। আমরা ধন্যবাদ দিতে চাই আমাদের ডিজিএমই, ডাইরেক্টর জেনারেল মেডিকেল এডুকেশন ডিপার্টমেন্টের মেডিকেল এডুকেশন অ্যান্ড হেলথ ম্যান পাওয়ার ডেভেলপমেন্ট লাইন ডাইরেক্টর প্রফেসর ডক্টর মোশাররফ হোসেন খন্দকার স্যারকে এই প্রথমবারের মতন জাতীয় নাক কান গলা ইনস্টিটিউটে এবং আমাদের এই সোসাইটিকে তারা সাপোর্ট দিয়েছেন, বোথ ফাইন্যান্সিয়াল অ্যান্ড লজিস্টিক সাপোর্ট, এবং এটার জন্যই আমরা আজকে এরকম একটি সুপার স্পেশালিটি সাবজেক্টের একটা ট্রেনিং প্রোগ্রাম এই কনফারেন্সের মাধ্যমে করে আমরা স্কাল-বেস সার্জারিকে জনগণের দোরগোড়ায় পৌঁছে দেওয়ার জন্য এই প্রোগ্রামটি করতে পেরেছি। লেডিজ অ্যান্ড জেন্টলম্যান, প্লিজ গিভ এ বিগ হ্যান্ড টু দ্য মেডিকেল এডুকেশন অ্যান্ড হেলথ ম্যান পাওয়ার ডেভেলপমেন্ট ডিপার্টমেন্ট। এ পর্যায়ে বক্তৃতা দেওয়ার জন্য আমাদের আজকের অনুষ্ঠানের সভাপতি, ডাইরেক্টর জাতীয় নাক কান গলা ইনস্টিটিউট প্রফেসর জাকারিয়া সরকারকে অনুরোধ করব পোডিয়ামে এসে তার বক্তব্য প্রেরণের জন্য। প্রফেসর ডক্টর জাকারিয়া সরকার, ডাইরেক্টর জাতীয় নাক কান গলা ইনস্টিটিউট।
Assalamu alaikum. Welcome you all at the International Endoscopic and Skull-Based কনফারেন্স 2024। আজকের অনুষ্ঠানে আমাদের প্রধান অতিথি উপস্থিত আছেন আমাদের শ্রদ্ধেয় শিক্ষক, কিংবদন্তি তুল্য ENT সার্জন এবং আমাদের অভিভাবক, বঙ্গবন্ধু মেডিকেল ইউনিভার্সিটির প্রাক্তন ভাইস চ্যান্সেলর এবং কুমিল্লা 7 আসনের বর্তমান মাননীয় সংসদ সদস্য অধ্যাপক পানুগোপাল দত্ত স্যার। বিশেষ অতিথি উপস্থিত আছেন ডাক্তার MD মোশাররফ হোসেন খন্দকার, লাইন ডিরেক্টর জেনারেল অফ মেডিকেল এডুকেশন, ডিজি হেলথ, এবং বিশেষ উপস্থিত আরও উপস্থিত আছেন অধ্যাপক ডাক্তার আলমগীর চৌধুরী, মানে এই সোসাইটির স্বপ্নদ্রষ্টা এবং ফাউন্ডার সেক্রেটারি, এবং আরও উপস্থিত আছেন আমাদের শ্রদ্ধেয় শিক্ষক এবং এই অত্র ইনস্টিটিউটের স্বপ্নদ্রষ্টা পরিচালক, ফাউন্ডার ডিরেক্টর অধ্যাপক প্রাণগোপাল দত্ত এবং সুধীমণ্ডলী, আপনাদের সকলকে আজকের অনুষ্ঠানের সুস্বাগতম। I like to welcome our foreign faculties, Dr. Gaurav Shankar Madhukiri and Dr. Tushar Kanti Ghosh and Dr. Sanjay Kumar Gupta. আপনারা সকলেই জানেন 2013 সালে মাননীয় প্রধানমন্ত্রী জননেত্রী শেখ হাসিনার হাত ধরে অত্র প্রতিষ্ঠানটি প্রতিষ্ঠিত হয়। তারপর থেকে আমরা এই 10 বছরের যাত্রায় মানুষের সর্বোচ্চ সেবা দেওয়ার পাশাপাশি স্কিল ম্যানপাওয়ার ডেভেলপমেন্টের জন্য সর্বোচ্চ চেষ্টা চালিয়ে যাচ্ছি এবং নিয়মিতভাবে আমরা বিভিন্ন সিম্পোজিয়াম, ওয়ার্কশপ এবং বিভিন্ন সায়েন্টিফিক প্রোগ্রামের আয়োজন করে যাচ্ছি। তারই ধারাবাহিকতায় আজকের এই এন্ডোস্কোপিক সার্জারি সোসাইটির ব্যানারে আজকের এই আয়োজন। আমাদের এই প্রোগ্রামের অর্গানাইজার হচ্ছে বাংলাদেশ এন্ডোস্কোপিক সাইনাস অ্যান্ড স্কাল বেস সোসাইটি এবং সাপোর্টেড বাই দ্য ENT ইনস্টিটিউট এবং DGME, ডিজি হেলথ। আমি ইনস্টিটিউটের পক্ষ থেকে পরিচালক হিসাবে এন্ডোস্কোপিক স্কাল বেস সোসাইটি এবং DGME-কে ধন্যবাদ জানাচ্ছি আমাদের প্রতিষ্ঠানকে এরকম একটি অনুষ্ঠান আয়োজন করার সুযোগ দেওয়ার জন্য। এই সুযোগে আমি দু একটি কথা বলতে চাই। ENT সোসাইটির জন্য মাননীয় প্রধানমন্ত্রীর সবচেয়ে বড় ঈদ উপহার ছিল একসাথে 10 জন অধ্যাপকের পদোন্নতি প্রদান এবং 23 জন সহযোগী অধ্যাপককে পদোন্নতি প্রদান। মাননীয় প্রধানমন্ত্রীর সদিচ্ছা এবং ENT বিষয়ে পদ সৃষ্টির ফলে এই যুগান্তকারী কার্যক্রম সম্ভব হয়েছে। আজ থেকে 1 যুগ আগে কিছুটা না বুঝে যে পদসৃষ্টির কাজ শুরু করেছিলাম, দীর্ঘ 10 বছরের চেষ্টায় সমিতির সদস্যদের অক্লান্ত পরিশ্রম উৎসাহে 375টি পদ সৃজন সম্ভব হয়েছে, যা সোসাইটির ইতিহাসে সবচেয়ে বড় অর্জন বলে বিবেচিত। সেই জন্য সোসাইটির সকল সদস্যের পক্ষ থেকে আজকের প্রধানমন্ত্রী মাননীয় জননেত্রী শেখ হাসিনার প্রতি কৃতজ্ঞতা প্রকাশ করছি। ENT সোসাইটির সকল সদস্যের অন্যতম গর্বের জায়গা হচ্ছে জাতীয় নাক কান গলা ইনস্টিটিউট। দীর্ঘ 10 বছরের সফল যাত্রার এই প্রতিষ্ঠানটি ইতিমধ্যেই সারা দেশের নাক কান গলা রোগীদের অন্যতম বরষ্টার স্থল হিসেবে বিবেচিত হতে পেরেছে। কিন্তু বাস্তবতা হচ্ছে মাত্র 2 বিঘা জায়গার প্রতিষ্ঠিত প্রতিষ্ঠানটি সারা দেশ থেকে আগত বিপুল সংখ্যক রোগীদের মানসম্মত সার্ভিস নিশ্চিত করতে হিমশিম খাচ্ছে। এই বাস্তবতায় আমাদের প্রস্তাবিত নতুন আউটডোর কর্টার ইমপ্ল্যান্ট গ্রহীতাদের জন্য রিহ্যাবিলিটেশন সেন্টার, জরুরি চিকিৎসাতে সংশ্লিষ্ট চিকিৎসক এবং স্টাফদের জন্য ডরমেটরি সহ বেশ কিছু প্রস্তাবনা স্বাস্থ্য অধিদপ্তরের প্ল্যানিং বিভাগ কর্তৃক গৃহীত হয়েছে। স্থান নির্দিষ্টকরণ সহ বিভিন্ন বিভাগে অনুমতি পেলে PWD কর্তৃক সহযোগিতা বাস্তবায়ন সম্ভব। এ ব্যাপারে সংশ্লিষ্ট সকলের সহযোগিতা কামনা করছি। আরেকটি বিষয়ে আমি সেগুলো দৃষ্টি আকর্ষণ করতে চাই। নাক কান গলা বিভাগের মতো অন্যান্য নন কমিউনিকেবল ডিজিজ সংশ্লিষ্ট সংস্থা স্বাস্থ্য অধিদপ্তর NCDC বিভাগের আওতায় হাজার হাজার কোটি টাকা বরাদ্দ হলেও ENT বিষয়ে সোসাইটির প্রাপ্তি প্রায় শূন্য। অথচ অবকাঠামোগত উন্নয়ন এবং নাক কান গলা সার্ভিসকে সকল পর্যায়ে দিয়ে যাওয়ার জন্য তার কোনো বিকল্প নেই। তাই আশার বিষয় হচ্ছে NCDC এবং হসপিটাল ম্যানেজমেন্ট সার্ভিসের মাধ্যমে আগামী জুলাই থেকে শুরু হওয়া পঞ্চবার্ষিক পরিকল্পনায় নাক কান গলা বিষয় হিসাবে অবকাঠামোগত উন্নয়ন, উপজেলা পর্যায়ে ইয়ার কেয়ার সার্ভিস নিশ্চিতকরণের লক্ষ্যে প্রায় 200 কোটি টাকার 2টি প্রস্তাবনা করা হয়েছে, যা বাস্তবায়নের পথে। তাছাড়া অন্যান্য বিষয়ের মতো ন্যাশনাল ইনস্টিটিউট অফ এর গাইডলাইন ফর ইয়ার কেয়ার প্রতিষ্ঠার দাবি ছিল দীর্ঘদিনের। সকলের সহযোগিতা এবং স্বাস্থ্য অধিদপ্তরের NCDC বিভাগের আন্তরিকতার ফলে তা প্রায় চূড়ান্ত পর্যায়ে। এই সার্বিক বিষয়গুলো বাস্তবায়ন ও নিশ্চিতকরণের জন্য আজকে অনুষ্ঠানের প্রধান অতিথি সহ সকলের সহযোগিতা কামনা করছি। সুধীমণ্ডলী, আজকের আপনাদের সকলের উপস্থিতিতে আমাদের 2 দিন ব্যাপী যেই কর্মযজ্ঞ শুরু হয়েছে, আমি আশা করি আপনার এই 2 দিনের একটা আনন্দময় কাটবে এবং আপনারা যেই আশ্বাস ও উৎসাহী অংশগ্রহণ করেছেন তা সফলভাবে বাস্তবায়ন হয়ে আশা নিয়ে বাড়ি ফিরে যাবেন এবং আপনাদের উপস্থিতি ভবিষ্যতে আমাদেরকে এই ধরনের কার্যক্রম পরিচালনা সহযোগিতা করবে। ধন্যবাদ জানাচ্ছি সবাইকে, ধন্যবাদ জানাচ্ছি আজকে মঞ্চে উপস্থিত আমাদের অতিথিবৃন্দকে এবং ধন্যবাদ জানাচ্ছি আমাদের সহযোগী প্রতিষ্ঠান ডিজিএমএ স্বাস্থ্য অধিদপ্তরকে। আবারও সবাইকে ধন্যবাদ জানাই। জয় বাংলা, জয় বঙ্গবন্ধু, বাংলাদেশ চিরজীবী হোক।
Now is the time to present the memento to the guest in the podium. May I now request Professor Dr. Zakaria Sarkar, Director of this institute, to present the memento to our chief guest, special guest, and other guests in the podium. ইনঅগ্রাল সেশনের সমাপ্তিতে আমরা লাইভ সার্জারিতে চলে যাব। ডক্টর গৌরব মেদিকারি উইল বি দ্য ডেমনস্ট্রেটর অফ বেসিক ফেস অন নাসাল পলিপোসিস। আমরা না দিব। Now the memento is being presented to Dr. Mosharraf Hossain Khandokar from DGME. পড়ে গেল। Professor M. Abdullah sir, founder director of this institute. Listen. Professor Alamgir Chaudhary sir. Thank you. Now is the time to hear from our chief guest, from our teacher, from our guide. May I now Now, may I request Professor Prangopal Datta MP sir to come on the podium and deliver his speech as chief guest. Professor Prangopal Datta MP sir.
Very good morning. I am delighted here to say something. But before I discuss anything about ENT, I must address Mr. President Sarkar Zakaria Professor and Professor Abdullah, Founder Director. Possibly he lost a few liters of sweat only to build this institute. I have seen in him the ministry. And Khandokar Mosharraf Hossain, representative of DG Medical Education, and he is also a line director. And Alamgir Chaudhary, one of the pioneer of this subject, and my beloved teachers, senior, junior, and the ENT specialist. Again, very good morning to you. The first thing what I want to say, what Zakaria told just a few minutes back, that DG Medical Education did not allocate any research project for ENT subject. Is it? You have said. So, my question is that for last 11 years, I am the chairman of Ministry of Science and Technology to offer the research project in medical sciences and biomedical sciences. Unfortunately, for last 4 or 5 years, there is not a single research proposal submitted from the ENT specialist to the Ministry of Science and Technology. That is also not a very bad donation. That is up to 15 lakhs for one research we can give. So, who will answer it? Why not? So, secondly, we have got foreign delegates. They are expert in their own field. But I must say that I am the most experienced and expert surgeon in this field. There is no end of learning. So our junior ENT specialist, they should think that what should they will do. They should concentrate in one topic. I'm really happy to say something about Babur and Kanu. So Kanu has concentrated only on the ear. Even he does not do any tonsillectomy. So in that case, the perfection will be near to the expectation. And here is lot of my junior friends. What I want to say, that after completion of my medical graduation and training under a giant professor, Professor Nurul Amin, and qualifying as a MCPS from the BCPS, when we would used to go through the journals, British Journal of Otolaryngology or American Journal, there's a lot of innovation they have done which we have never seen, only we have gone through the textbooks. What I decided, to go to somebody to learn something, and spent 4 years in Soviet Union for doing my MS and PhD. Came back. I was associate professor, IPGM&R. I have been awarded the Commonwealth Scholarship for doing my MSc in audiological medicine. Everybody from IPGMR and my well-wisher told me not to leave Bangladesh for this source of degree. Why? Because if I go from IPGMR to somewhere else, this post will never remain vacant. So I put this recommendation to my wife, that everybody is saying like this, if I leave IPGMR and go to Manchester, and when I will come back, I will not have a posting in Dhaka. She said, where you will get the posting? Rangpur you have already served. That is not a bad place. You may be posted in Borishal. So possibly the people of Borishal has got ear, nose and throat, and the ear, nose and throat diseases. So only on her inspiration, I went to Manchester. Came back home in 1996, went to Tübingen, Professor Jenner, to see cochlear implant. But unfortunately, after coming back, I could not do any cochlear implant. There was no provision. And finally, the provision is also created by me in Bangabandhu Sheikh Mujib Medical University, with the donation of Ministry of Social Welfare, and where the minister was a great man, Anamul Haq Mustafa Shahid. And when we reached to him in his official house with Professor Kamrul also, I found really they are the dedicated politician like that of Johur Ahmed Chaudhary, M.A. Aziz, Captain Mansur Ali, etc. So my request to my younger colleagues, concentrate to one topic. That is enough. I believe that if Babur concentrate only on CSF leakage, he can survive in a glorious way. So everybody of us should not go for tonsillectomy. Number 2, throughout the whole world, the operation tonsillectomy is declining like anything. When I was in Germany, by my 6 months' time, I have seen only one tonsillectomy in that hospital. So this is also true. After removal of the tonsil, to some extent, local immunity of the pharynx is lost. And to my foreign delegates from Calcutta, India, I will request, there are a lot of people as a medical tourist that travel to the neighboring countries like India, Thailand, Singapore, etc. So when somebody visits you in India, if you think that he or she needs tonsillectomy, please send back that patient to Bangladesh and say there are a lot of ENT specialists who can do this tonsillectomy. A few days back, a tonsillectomy patient came to me with massive bleeding, and it has been done in an expert hand in India. So who will take the responsibility? I should not, as an ENT specialist, but as a human being, I will take the responsibility to save the life of a person. So in that case, my earnest request to all foreign delegates, please advise that patient. Your consultation opinion is the main one. Possibly I have asked somebody for tonsillectomy. He went to you and you have said, yes, it is essential, or you should not do it. But if it is essential, let the patient come back to Bangladesh and get the operation done in Bangladesh by anybody he likes. So we are facing a lot of difficulties with the surgery done, even in Singapore, Thailand. The post-operative follow-up is only on our shoulder. And the details of the operation note is also not put forward. So we are in great trouble. So with these few words, I will ask Zakaria Sorkar, go to the website of Ministry of Science and Technology. I don't know whether I will be the chairperson this year or not, but for last 2 years when I was an MP, I was the chairperson. So I have got definitely a fascination for the ENT subject. And this is my parent subject. So apply for some research project, you will get it. So with these few words, let me conclude here, again with my deep respect, regards and thanks to everybody. Last but not least, I pray to the God so that everybody of us live a healthy and fruitful life. Thank you, ladies and gentlemen. Thank you all.
Thank you, sir. With this, we conclude this inaugural session. So, thank you. With this, we conclude our inaugural session. Now, I request the guests to take their seats on the audience panel. We will go to our next session. It will be a live surgery session. Nasal polyposis will soon be connected with the operation theatre, and there is a 10 minutes time. 10 minute break for tea.
Yeah, this one is fine.
হ্যালো আলমগীর ভাই আলমগীর ভাই
আপনাদের কাছে স্বনির্বদ্ধ অনুরোধ, অডিয়েন্স ছাড়া কোনো লাইভ সার্জারি হবে না। সো প্লিজ টেক 10 minutes time maximum and please come back to the auditorium so that we can start live surgery at scheduled time.
আলমগীর ভাই রেডি?
Nothing. I'll be fine.
দীপঙ্কর আসো।
রাজ্জাক আলমগীর ভাই,
হ্যাঁ শোনা যাচ্ছে ভাই।
আচ্ছা ওই যে এখন শুরু হবে, হ্যাঁ 10 মিনিট ব্রেক দিছে, 10 মিনিট পরেই অটি চলবে।
ঠিক আছে সবকিছু রেডি আছে,
আমরা চেক দেই।
হ্যাঁ আমি তো
কেস 1 আসছে লেখা।
হ্যাঁ এটা হচ্ছে এটা স্টার্ট হবে।
আচ্ছা আচ্ছা
ঠিক আছে সবকিছু সমস্যা
ঠিক আছে।
থ্যাংক ইউ।
আচ্ছা ঠিক আছে।
Yeah, okay. We'll do the left side first.
এখান থেকে যাবে?
হ্যাঁ ভাই।
কাকো লাগবে?
The deviation on the right side. এখান থেকে এখন লাগবে না, কিন্তু রনি চলে গেলে একজন পাঠা দেন। আর ওই ক্যামেরাটা অডিয়েন্স ধরে রাখতে বলেন এখন।
ঠিক আছে।
Why open side first?
ঠিক আছে।
You can do the septoplasty first also if you want.
Sir, Zakaria sir. Hello, anybody in the auditorium?
The flap will come in your way, but actually I do it on the same side of the deviation. So
স্যারেরা বের হয়ে গেছে স্যার, কেউ নাই।
it's pretty much gonna be
জাকারিয়া
okay.
স্যারেরা
Not such a big deal.
নাই স্যার।
After you do so many cases, you'll be like, yeah, it's okay, it's not a problem.
কেউ নেই?
Otherwise, I'll have to start with a septum first. If you want, I can do that also. There's no problem.
ফুলগুলা খুলে ফেলেন আপনার।
Just show me this thing, nasal passage. I think this is good. This is a better nasal passage. Can you remove that merocell on top? Yeah. Yeah, I think we'll do this side first. We'll do this side first. Wider side, yeah. 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 Yeah, that's enough.
We have also cottles.
Yeah, that's okay. Yeah, that's cottles. Yeah. Manage. You have digital images of this patient?
Yeah.
Digital, is it like DICOM? DICOM you don't have?
No.
DICOM. Because this is soft tissue cut. The bone is looking very thick here. So it's possible that there is osteogenesis, but may not be. But anyway, here in the frontal, you can see that there's a lot of osteogenic focus. So this will bleed a lot. That segment will bleed a lot. This is prepared with steroids? You've given steroids. Okay. Hopefully that should reduce the bleeding a little bit. But yeah, but that's the problem is the inflammatory sinus disease. That bone will not take up the steroid. So this along the skull, this segment we might have to drill. If the bone is very hard,
Fine.
we'll just drill it out.
You can use the drill of
Yeah. I'll use the same drill. That's okay. Yeah. I'll use the same drill.
Okay. So you'd expected BP?
What is the patient's resting blood pressure? 30% below that.
Observe.
I got it.
Resting blood pressure of
I took it.
patient.
I took it. Thank you.
Resting.
No, before anesthesia.
Before anesthesia.
Only thing is we need some hypotensive anesthesia. So 30% less than whatever was the resting blood pressure before anesthesia. That's about it. I think this is fantastic. This is superb. His heart rate is now 63, 71. Okay, yeah. That's perfect. I think we are 1 hour late.
Yeah. Not 1 hour. It is about 1.5 hours.
Late?
Yeah. So it will be started at the 9:30, but it is now about 11.
We should start fast.
Okay. So in the first session we should do the one case, and CSF will shift it to in the second half.
Yeah.
Because of there is a time shortage. It will take about 1.5 hours or
1.5 hours.
1.5 hours.
But actually the scheduled time is 1 hour.
Yeah, scheduled time is
1 hour.
Okay.
If you want me to finish in 1 hour, I can finish.
Okay. If you have.
But I'll have to go a little fast.
Okay.
That's the only thing.
So if you have the time, then we will finish the two cases first.
Yeah.
If you will need there is some little bit bleeding or it may be
Delayed.
long time.
Yeah. If you want me to spend more time on the basic stuff, I'm happy to do that. What we can do is one side I'll show nicely, other side I'll be a little fast.
But this is our main requirement surgery.
Yeah, first. So then let us spend time. Not many people will do CSF leak or angiofibroma, but a lot of people will do sinus. People will do this. Then I'll spend time here.
You should take more time in this case.
Okay, cool.
To delineate in every step.
Yeah, sure. We'll do that. So if we're doing the left side first, in a way it's a good thing because left side is where the osteogenesis is more.
Yeah.
So this is a case which is more realistic.
Yeah.
So normally what happens, we choose a very beautiful case for demo, and when surgeon goes back to do the surgery, bleeds a lot.
Yeah.
This is a case where it's actually going to bleed in the demo only.
Yeah.
So we'll show you how to manage this bleed, so that you're also aware in a difficult case how to do it.
Yeah.
Otherwise,
in this session we choose some little bit difficult.
I want challenge. I want challenging case. I don't want easy case. You give easy case to anybody. I want difficult case. I want to do difficult case. I like it. If it's challenging, I like it.
We have tried to arrange the one pituitary, one the squamous cell carcinoma T1, T2, but we have lost because it goes only 10 days back.
That's okay. Don't worry. Whatever we have, we'll make the best of it.
Okay.
That's okay. There's always we can go into more detail.
Yeah, more detail.
Instead of doing more cases, even if we do less cases, let us do details. Yeah.
It is very
Essential.
essential for our juniors and our
Absolutely.
seniors also.
Because not everybody, even if I show a squamous cell carcinoma or angiofibroma, not many people will do it. But the sinus, everybody will do. CSF leak, they will do.
It.
Yeah. And even if they create CSF leak while doing, they should know how to repair it.
Yeah.
So CSF leak also will do it nicely. Will take time and do it.
In just 2 or 3 years back, CSF will do only in 1 or 2 institutes. But in now at this time,
everybody
many
is
institute
they are doing CSF
try to
leak.
do it.
I liked how you are saying try to do it.
Yeah. No.
Because not everybody might be successful.
No, inshallah.
But
we will succeed.
it will come. It's the first couple of surgeries may not work, but afterwards it will eventually happen.
দেখি দাও তো অডিটোরিয়ামে কেউ নাই আমরা তো 1.5 ঘন্টা আসা কোথায় পৌঁছলাম আমাদের 1.5 ঘন্টা পার হয়ে গেছে অডিটোরিয়ামে কেউ আসছে অডিটোরিয়ামে তো পার্টিসিপেন্ট লাগবে তো শুরু কাকে দিয়ে করব তোমরা অডিটোরিয়াম ম্যানেজ করতে হবে না দেখো অডিটোরিয়ামে কি কেউ আছেন আমাদের ও আছে
Light is gone.
হ্যালো আরিফ এটা কি আরিফিন না মশিউর ছবি তুলতেছে কে মশিউর তোমরা কি কেউ শুনতে পাচ্ছ আরিফিন মশিউর কেউ আছো
আসসালামু আলাইকুম হানিফ ভাই আমরা শুনতে পাচ্ছি
আচ্ছা তোমার পার্টিসিপেন্টের কি অবস্থা আমরা কি শুরু করে দিব কিনা
পার্টিসিপেন্টস সব বেশিরভাগই টি ব্রেকে আছে 5 মিনিট পরে মনে হয়
না আমরা অলরেডি অনেক লেট 1.5 ঘন্টা লেট আমরা
শুরু করে দেন
We'll start?
Please start.
Okay,
we can start.
Okay.
Now our first case is nasal polyposis and the case summary is described by our Dr. Ripon Kumar Sarkar.
Thank you, sir. Welcome to all of you in our institute in Endoscopic Sinus and Skull Base Surgery Conference 2024. Organized by Bangladesh Endoscopic Sinus and Skull Base Society. In our first case will demonstrated by our foreign faculty, Dr. Gaurav Shankar Medikari sir, and he will be assisted by Dr. Shoful Akram and Dr. Gautam Buddhapal and our senior staff nurse Afroza. And on anesthesia is supervised by Mazharul Anwar sir, Dr. Afzal sir, Dr. Mamun sir. Now I would like to go through the case. In our first case, Mr. Abdul Rahman, 47 years male, businessman hailing from Mirpur, Dhaka, with the complaint of bilateral nasal obstruction for last 5 years. On endoscopic examination, we found multiple grape-like polypoidal structure in both nasal cavity arising from roof and the lateral wall, which are pale, non-sensitive, and not bleed on touch, and septum deviated to right side. Here the endoscopic finding. We found the polypoidal structure here, also in the left nasal cavity. On CT scan, nose and paranasal sinuses, in coronal, axial, and the sagittal view, we see the inhomogeneous intensity lesion found in the ethmoid region and the maxillary regions, and also find the osteogenic change in the ethmoid region. CT scan report reveals bilateral sinonasal polyposis obstructing osteometal complex and septum deviated to right side with septal spur. So our final diagnosis is bilateral nasal polyposis with deviated nasal septum right. Our plan is functional endoscopic sinus surgery under general anesthesia, demonstrated by our foreign faculty Gautam Shankar Medhikari sir. Thank you.
So now I request Dr. Gaurav Shankar Medhikari to demonstrate the CT scan of this patient.
Yeah, hi, thank you so much for having me here. First of all, big thanks to Dr. Zakaria Sarkar sir and Dr. Alam Gir Chaudhary sir for inviting me over. Am I audible to the audience? Hello?
Yes, please.
Okay, okay.
We can hear. Yes.
Yeah. So thank you so much for inviting me over. And the first case that we are doing is a case of inflammatory sinus disease. So this is the scan that we have here. Unfortunately, what we have here is actually a soft tissue cut. So you can actually see that the bone is, we don't have a lot of detail in the bone. So that makes it a little challenging, because then you will assume that these are all osteotic changes, which may as well be. So the first cut that we are seeing here is going through the frontal sinus. We can see the eyes. This is the premaxillary segment of maxilla, which we are seeing here. Posteriorly, as we go, we can actually see the frontal sinuses on both sides, the frontonasal beak. We are not seeing an opening in the frontal sinus yet. So in the next cut, and we can start to see some of the bony septum, that is the maxillary crest, what it assumes to be. That is the ascending process of maxilla. And as we go posteriorly, you can actually start to see the appearance of the middle turbinate here. Okay. Actually, I'm not going to take a lot of time on the CT scan, because we've had a wonderful lecture on CT scan already. So what I'll probably do is just discuss with you what are the key findings that we have, and what are the things that we should probably expect. So this is going to be a little challenging case, because there is probably, especially in the left ethmoid, we have a lot of osteotic bone along the skull base also. If you see this sagittal section, you'll see along the frontal sinus, there is significant amount of osteotic bone that we see here. And we might have to drill this bone down in order to have a very good opening of the frontal sinus. You can see a prominent frontonasal beak as well, here and here. And there is a osteotic focus which is actually blocking the frontal sinus ostium. That is one of the challenges that we have. The second challenge that we're going to have is, as you go posteriorly in the posterior ethmoidal group of cells, you can see that the cells are actually very small. The bone is actually quite thick and osteotic. So again here, in order to open up this whole space, and the sphenoid sinus is also again quite small, dominant only on the right side. Left side sphenoid sinus is actually very small, or probably even non-existent, we can say. The other issue is that you have on the right side, you just compare the right side maxillary sinus. When you compare it to the left side, you can see that the pneumatization is much better on the left side when compared to the right side. So this looks to me like a hypoplastic maxilla on the right side. So what we need to do is, you have to stay low down. Because if you open this orbit higher, you open this sinus high up, you are probably going to enter into the orbit. Okay, so you have to be careful on the right side maxilla. The pneumatization is not much. Why? Because there is a septal deviation which is towards the right. And that has probably made it difficult for the sinus to get pneumatized, because there has been restricted air entry. Okay, so this looks like there has been an issue since childhood actually, but it's probably gotten worse in the last 5 years, because the degree of inflammation is very, very significant in this case. So I'm going to love demonstrating this case, because this is going to be a very realistic case for you. What happens is, whenever we do a demo, we choose a very nice case with very little inflammation, and we demonstrate a beautiful surgery. But this one, we are going to have quite a lot of bleeding in this case actually, because of the degree of inflammation. It's got nothing to do with the blood pressure, it's got nothing to do with the surgeon also, but it's got to do with the degree of inflammation in the patient's sinus itself. And that inflammation is going to give us bleeding. But what you'll observe is, after we drill out, or after we remove all this osteotic bone and clear out all the sinuses, you'll see that the bleeding will actually stop. Okay, this is one thing that you will have to pay attention to. So without any further ado, probably we can go to the case now, because like I said before, I don't want to waste too much time discussing scan, because that's already been discussed by the previous speaker. So I just wanted to discuss the pathological part of this patient. You have some sterilium? That's okay.
Hello.
Yeah, you have any queries? I'm happy to answer them.
Yes. One of my question is there is osteotic changes, also the massive inflammation.
Yes.
What was the preoperative preparation of this patient, particularly to reduce the bleeding, perioperative bleeding?
Yeah, so you can give the patient steroids preoperatively, oral steroids, which usually should last for about 3 weeks. 3 weeks prior to surgery, you can give steroids. It all depends on your experience. Like if you are happy to pull off this case, in spite of the bleeding, you are happy to open up all the cells, then you will not really have such a big problem. You can also use some intraoperative techniques. It's actually 7.5, so next case we'll use 7.5. That's okay. From next case we'll use 7. This is very tight. You can also use some intraoperative techniques to sort of reduce the amount of bleeding that we have.
What is that?
Sorry?
What is that intraoperative technique?
So we can actually raise the head end of the patient by 15 degrees. So that actually allows us to prevent venous congestion in the upper airway. Can we have, I don't use this, I'll have a straight Blixley. You can keep this that side, I won't use it actually. The second one is we are going to use Merocel, which is soaked in adrenaline and normal saline in a ratio of 1:10. So here you can see that they have done a wonderful preoperative preparation. You can see that the polyps are almost non-existent here, especially after decongestion. If the patient had not been prepared, I would usually take a biopsy of this polyp. The reason being that you want to identify what is the inflammatory load in this patient. Can I have a septal elevator please? So you can see that this patient's turbinate is a little prominent. So what I would like to do before we proceed is I'm going to go into the inferior meatus high up, and I'm just going to infracture this turbinate to sort of create some space here and then outfracture it. So when we do this, we usually prefer to use the whole shaft of the instrument to sort of outfracture the turbinate. Okay. So now you have a lot more space. So this allows for blood suction, please. So this will allow for the blood to actually trickle into the nasopharynx. So you can see there is a lot of thick mucus. So this is basically mucus which is supersaturated. What happens in these cases is that patient will have mucus which is actually supersaturated with inflammatory cells. So because of that, the mucus is usually very thick in consistency. This thick mucus combined with the fact that patient has had a long-standing history of inflammatory sinus disease, which makes the mucociliary movement almost non-existent in these patients, that causes sinus stasis. And this thick mucus will actually trap all the allergens that this patient has. So there are some markers here which are telling me that this patient has got history of allergic rhinitis. The most important marker that you need to see, before I talk about the marker, let me just orientate you. I'm in the left nasal cavity of the patient. Can I get some feedback from the audience in the sense that can you see what I'm trying to show you, the endoscopic image here?
Yes, yes.
Yeah. So this is the left nasal cavity, this is the nasal septum, this is the inferior turbinate, this is the middle turbinate. Here we are probably seeing the uncinate here and the bulla epidermoidalis. So if you just trace, this is a small polyp. If you trace the middle turbinate backwards, you can see there is so much edema in the middle turbinate. Can you see this whitish stuff here? That is not mucus. This is actually edema of the middle turbinate. So when you find middle turbinate is edematous, right? This is called as a diffuse edema of the middle turbinate. If you find small spots like this, which are not continuous like this, right? If you have intervening islands of normal tissue like this, okay, then that is called as focal edema of the middle turbinate. That is actually grade 1. Okay, this is probably a grade 3 edema of the middle turbinate. Okay, so what is the significance of finding this edema is that when you see edema of the middle turbinate, the diagnosis goes in favor of allergic rhinosinusitis. Okay, so if you do an Ig level for this patient, or if you do an absolute eosinophil count for this patient, is going to be very much on the higher side. And when you find this sort of edema of the middle turbinate, what should you do? You should do a skin prick test for this patient. That is what is very, very important to sort of figure out. This is one of the most consistent endoscopic findings that you have to look for, whether or not that this patient could have an allergic etiology. Why is this important? Again, because even if you operate on this patient, you are not going to be able to change the DNA of this patient. Okay, you have to understand that. Allergy is a genetic disorder. So there are two chromosomes which are normally involved in allergy, number 5 and number 11. Okay, now there is a mutation in both of these genes, and that is the reason why whenever this patient comes in contact with dust, fume, smoke, pollen or whatever it is, he will develop an allergic reaction. And the fact that he has so much osteitis in the bones is proof that this patient has got an allergic etiology. Okay, so we need to address this allergy in the later days also, after the surgery as well. If you don't do that, what is going to happen? His disease is going to come back and the surgery will get a bad name. So you have to counsel this patient beforehand, before you take him up for surgery, that you have an allergic problem. What is the surgery going to do for you? Surgery is going to allow you to rinse your sinus with steroid, because he's had this disease for a very long time. So he's in the phase 2 of the inflammatory reaction now. In phase 1, which is driven by histamine, your antihistamines will work. But in phase 2, okay, where we have predominantly a lot of inflammatory markers which are released, like leukotrienes, interleukin 3, 11, 5. So when these markers are released, antihistamines are not going to work here. What is going to work is steroids. So that is the reason why when the doctors here have given him steroids, you can see that he must have had a significant improvement in his problems also. So when we do surgery now, it is only to open up the sinus, allow the mucus to drain, reduce the inflammatory burden. What are you meaning by reducing inflammatory burden? You are taking this reaction from a Th2 predominant type of reaction to a Th1 predominant reaction, and you are reducing the amount of inflammatory tissue in the sinus. And the most important reason for doing surgery would be to allow the patient to wash with steroid. So when he washes with steroid, you are doing two things. One, whatever dust, pollen, fume, smoke is there inside, that gets washed out. So you are not allowing that to sit inside and create a reaction. And the second thing that does is that the steroid which is contained inside the wash, without giving him any side effects, it will actually reduce the inflammation. These are the two important things that you are doing. Let us say your argument might be, why don't I just keep him on oral steroids? Let us say he doesn't want to get surgery done. I can keep him on oral steroids if it's a young patient, if he's not diabetic or anything. Why should I not do that? Yes, you can do that. But the problem is, you're not removing the trigger here. So you give steroid, it will work for 8 hours, but from the 9th hour, the dust which is sitting inside the sinus will get reactivated. So what are you achieving? It becomes a vicious cycle. So the patient is bound to take more and more and more steroids. Mind you, why steroids? Why not antihistamines? Because patient is already having this issue for at least 5 years. That means that he is already in phase 2 of the reaction. So antihistamines will not help him much. So it is our job to explain this to the patient and convince them that he requires a good surgery, that is mainly to allow him to wash with steroids. Okay. So that being the pathophysiology of the problem, now we are just going to proceed with the surgery. If you have any doubts, please feel free to ask me. Debrider is working.
Is it the type 1 inflammation or type 2 inflammation?
This is a type, this is a Th2 inflammatory predominance.
Type 2 inflammation who is really reacts with the steroid.
Suction. So there is no type 1 or type 2. This is phase 1 or phase 2. Phase 1 is where it is driven by by histamine, which lasts for a couple of minutes to couple of hours. After that, it comes into phase 2, where you have predominantly interleukin 3, 5, 11 and leukotrienes, which are playing an important part. Can we have the AC on, please? Wait. See, when I'm inside, suction is not working.
Hello, Dr. Gaurav. Can you hear me?
Yeah.
Yes. Please, can you show the my audience the unsinate process and
I'll
before
show
you debride?
Yeah.
You debride, you just give us a view of the unsinate process, where the unsinate process is attached.
Absolutely.
And
So
yes,
here,
please.
actually, the uncinate process is continuous with the lateral wall of the nose. Can you see this?
How our juniors can identify the unsinate in operative field?
Yeah.
Just you give
So
some
see,
tips.
this is the uncinate process here, but you are finding a gap here. Can you see this? So whatever is lateral to this gap here is actually the uncinate process, and this is the mobile part. You can see that this is moving, but if I try to move this segment here, this is not moving. Okay, so this is actually the lacrimal bone. Uncinate process is attached to that here. Can you see that?
Yes.
Okay, so this is the uncinate process, but unfortunately because of fibrosis, long-standing inflammatory disease, superiorly the uncinate process has become polypoid. Can you see that?
Right.
Yeah, and it has also attached to the middle turbinate here. Can you see?
Yes, some part of the
uncinate is attached to the middle turbinate as well.
Superiorly.
Yes. So that is because of the sinus inflammatory disease that he's had for such a long time. And here also you can see this is bulla ethmoidalis below here, this part. The uncinate is attached to that also. Okay. So the uncinate has got three parts.
Yes.
So this is the upper part. So this is called as the vertical part of the uncinate process. Okay. The second part is called the intermediate part. So from the vertical part, that is usually at the lower margin of the middle turbinate, it turns down and becomes the intermediate segment. So this is the intermediate segment. And the third part, which runs along the middle turbinate, is actually called as the horizontal part.
But the third part.
Yeah. So normally when we do an uncinectomy, we should do it at the junction between this intermediate segment and the horizontal segment. So somewhere here, we should do the uncinectomy actually. Okay. Debrider is working now? Okay. So what I would like to do is, I am just going to debride all of these polyps which we have. Okay. I am not going to remove any of the bone. So I have been advised that I should take some time to discuss the basic stuff, because a lot of youngsters would want to do more and more basic work. So see what, can I have a ball probe? So what have I done now? You can see very clearly that I have actually released the uncinate process from the bulla. Can you see this gap which has been created? So there was an attachment here. Agreed? So that gap I have now created by just removing the polyp. Okay. So now see, you can now very clearly say this is the intermediate segment
of the uncinate.
Yeah, there looks like there is an anterior fontanella here. Can you see this? Okay, this is an anterior fontanella here. This is the uncinate process, intermediate segment, and this is the horizontal. Now give me a backbiter. Now I'll show you why we should open exactly at this junction, that is between the intermediate and the horizontal segment. Why we should open here? That is because the ethmoidal infundibulum actually opens into this segment. Okay. So without even doing anything, I'll just show you. Give me a J curette, please. The minute you open into this area, you have a straight J curette. Or give me a ball probe. Ball probe, yeah. Just hold the sister, please. So see, now without doing anything, just if I push this horizontal segment down, you will be able to see that we are inside the maxillary sinus. See, this is the bone of the uncinate horizontal segment. Okay, this is very hard. Normally, uncinate will not be this hard. Okay, why it is hard? It is because of the osteitic bone. This is very osteitic actually. Upturn Blakesley, please. So it is our job. So how do you know that the previous surgeon has done a good job or not? If you just see whether they have done a good uncinectomy or not, you can actually tell whether the previous surgeon has done a complete job or not, just by looking at how well they have done the uncinectomy. Why? Because that is the most basic step.
Uncinectomy is the prime.
Yeah.
An important step for doing
so
the further
what I want you to observe is, I did not pull any of the mucosa out. Okay, that is very, very important. Try to preserve as much mucosa as you can. Can you see I am already inside the maxilla there? See that?
Yes.
So that is the opening of the maxillary sinus into the ethmoidal infundibulum. See that?
Yeah.
You can see there is a lot of mucus there. See this?
Yeah, yeah.
So that is the reason why. See, this is the horizontal part. I have not removed the bone. I have preserved it just to show you that this is the horizontal. See, this is the horizontal part. This is the vertical part. In between, I have removed the intermediate part. And where did I come? I came straight away into the maxillary sinus. Can you appreciate that?
Thank you. Just
Yeah.
oval.
Yeah. So can I have a straight Blakesley, please?
No, no.
So now what I'm going to do is, one second. Let us just. So see, now what I'm going to do is I'm going to remove this bone, that is the horizontal part of the uncinate process. Okay, we're just going to try to tease this bone out. See that? Only the bone. Okay, and next we will just use a debrider. Go in and observe how the blade is actually closed when I go in, so that I don't create any injury anywhere. Okay, and I'm going to remove the whole of the uncinate process. Vertical segment, horizontal segment, intermediate segment. All three segments I'm going to remove.
Dr. Shaurav. Hello, can
Gaurav,
you hear me?
yeah.
Gaurav.
Yeah.
Can you hear me?
Yes, sir.
Here is a different level of students and resident or junior doctors here.
Yes, sir.
And when you do the debrider, use debrider in uncinate,
Yes,
doing
sir.
the uncinatomy,
Yes, sir.
is there any advice or is even tips?
Yeah.
How can he do
Backbiter?
it without injuring the lamina papricia?
Absolutely, sir. So that's a very important point what you've mentioned.
If you give some tips here,
Yeah.
how they hold the instrument, how they do it, it will be helpful for my resident.
Absolutely. So just before I did the debridement, if you observed, I actually fractured the upper part of the uncinate. Could you appreciate that? Before I did the debridement, I actually fractured the upper part of the uncinate. So what that I did is, along the lateral wall of nose, I actually went, you have to stick close to the lateral wall of nose and fracture it. Okay. So when you do that, then you don't need to actually, give me a Maricel, just keep 2-3 Maricels here. So you don't need to actually touch the lateral wall or touch the tissue. If you just allow the tissue to come into the debrider and get sucked and then debride it, then you will not have a problem. The other thing that you need to do is, you have to appreciate on the scan whether or not, I like a straight suction. Curved suction is only when we use a 70-degree scope. So I'd like for you to appreciate on the scan whether the uncinate is actually medialized, intermediate, or if it is lateralized. So if you have a lateralized uncinate process, then you need to be very careful. Preferably if you are a beginner, don't use a debrider to remove a lateralized uncinate process. If it's a medialized uncinate process, then you can just use a sickle knife and go antegrade. So I just want to explain what is antegrade and what is retrograde uncinectomy. Okay, antegrade uncinectomy is when you go from front to back. That is, you open the uncinate process using a sickle knife from here. Retrograde is when you use a backbiter to open into the uncinate. That is, you identify a gap between the bulla ethmoidalis and the uncinate process, and then you go into that space, which is actually the ethmoidal infundibulum, and then you break the bone backwards. So that is called as retrograde uncinectomy. If you have a lateralized uncinate, then it's always preferable to do a retrograde uncinectomy because it's much safer. Whereas if you have a medialized uncinate process, then it is more convenient to do a antegrade uncinectomy because retrograde will be very tough, because you might injure the middle turbinate in such a case. Okay. What I want you to observe is one of the tactics that I use when I am doing surgery to reduce bleeding. If you observe, I am not going to suck on mucosa which is already opened up. Okay. On this mucosa, if you suction, there is nothing that is going to happen because the blood vessels are not exposed. So the capillary pressure will be the same. But when mucosa is open, like in this case, if you keep suctioning here, if you observe, it will keep bleeding more. See that? Because you are actually increasing the capillary pressure by the negative suction. So what do you do instead is, you use a Maricel piece to actually suction on it so that you don't injure the mucosa with your suction. Now if you just see, after removing this Maricel, what is going to happen is, you will see that the field will be much less vascular. Okay. So this is one of the tactics that I actually use. Do you have a 40 rad blade? So now you can appreciate that the uncinate is out. There is a little bit uncinate, intermediate segment, backbiter you have, which I might take it out with a backbiter. So the other important point that you need to remember is the relationship of the nasolacrimal duct with the uncinate. Okay? Give me a wash, please. Yeah, just keep wash ready. Where's the suction? Let the suction be towards me. Okay? Yeah. 1 second. Can you just take that? Yeah, please wash. No, it didn't come out. Yeah, okay. Now wash, please. So whenever you feel that the field is a little bloody or blood stained, just take a wash. What this wash will do is it will clear off all this blood clot and debris. And remember, when you're suctioning in the nose or the nasal cavity like what we are doing now, suction from posterior to anterior. Don't suction like this. If you try to suction from here, you will actually injure the mucosa. Whereas if you come backwards, see this? This gentle motion will not make any injury to the mucosa. Okay, so that way you can actually reduce the blood in your field. Already you are expecting that this is going to bleed. So you should not actually create more number of bleeding points here. Okay, that is one of the important things to remember. Now we are going to use an angle debrider. And you will see that we can actually remove this segment of the uncinate also. So can you appreciate that is the natural loss? See this posterior wall of the ostium. Can you appreciate that? Okay, I am not injured. Can you see that? That is intact. Okay. Now at this horizontal segment of the uncinate, you will get a vessel. See this. Okay, this is one of the branches of the inferior turbinate. This is the uncinate process branch of the inferior turbinate branch, which is coming again from the phenopalatine. Actually, a blade is not sitting properly. So see, when I'm trying to suck tissue, are you getting any tissue into the debrider? You are not. So that means that uncinectomy is complete here. Okay, you have not left much of uncinate behind. That is what it means. Okay. So if the disease is not much, then try to preserve this. Okay, but if you need to open it up, then do it from the inside. Okay, like this. And then you can actually take down this tissue. The suction is not good enough actually. Very weak suction actually. After this step, we are just going to place one small Meracel here to reduce this kind of ooze. This oozing happens, like I said, when we do the uncinectomy on the other side also, I'll show you. Exactly at this horizontal part of the uncinate, you will have a vessel actually. So that usually will bleed, but it will stop. There is nothing to worry. It's not like it's a very big artery. Patient is not gonna die because of that vessel or anything. It's just that you need to control that ooze to make sure that you don't have any kind of blood stained field. The more blood you have in field, the more light that it absorbs. So that is why your picture will start to look darker in color. Okay?
Dr. Medicari, do you hear me? I have a question that you are making the enlargement of the osseum, maxillary osseum. What is the optimum diameter you will make it enlarged?
So that depends on the pathology that you are dealing with. If you are dealing with an inflammatory sinus disease where you want to have the widest ostium because that will allow more amount of saline and steroid to go in, then you should make a as wide as possible, is what I would say. From the nasolacrimal duct up to the posterior wall. So now I'm just, if you observe, I'm just trying to put pressure on the lacrimal sac here, but we are not seeing any ballotment. Okay. So that means we are still in the safe zone. Okay.
For enlargement, do you
anteriorly?
Do you debride the whole of the surface opening from superior, inferior, anterior, posterior?
Whole of the surface of what, sir?
Opening, ostium.
Ostium.
Margins. Okay.
Yeah, so the posterior wall I would usually like to preserve if I can. Why? Because the mucociliary motility is more towards the posterior wall of the maxillary sinus. Posteromedial wall has the highest amount of mucociliary motility.
So that we should avoid to debride the posterior margin.
If possible, yes. But if you are talking about a case like allergic fungal sinusitis where the mucociliary movement is already gone, then there is no point. You might as well make a big opening, because that will help you to allow more washing to be done.
But too large opening will produce a empty sinus syndrome.
Sorry?
Too large opening will make an empty sinus.
Not really. It doesn't matter. If we are talking about the nitric oxide theory, that has already been disproven now by a meta-analysis. So that will not really change much for you. So if you are dealing with AFRS, then please go ahead and make a big opening, because that will really help the patient to drain out all of that mucus on his own. The problem with AFRS patients is that, give me a J curate, is that they don't have good mucociliary
You are
clearance.
out of view. Will you please look at it? We are not in view of it is dark. I mean off is white.
Yeah.
Audio visual, please. Precautions do you take before in preoperative period to reduce the bleeding perioperatively? How do you combat the bleeding, hemorrhage in surgery? What precautions do you take prior to the surgery in preoperative period and during the surgery also?
So prior to surgery, if you are seeing a lot of osteitis like we did on this scan, then I would not be in a hurry to do the surgery. I would probably put the patient on some steroids like what they have done. So because
how many days?
Ideally, this should be 3 weeks. Why 3 weeks?
Oral only or
oral.
with local steroid spray?
Local steroid spray also can be given. There is no harm, but oral is a must, because there will not be any penetration into the bone with a local steroid spray. That's not going to penetrate the bone.
What systemic steroid do you use?
We can use prednisolone. So why 3 weeks? Because the lifespan of a eosinophil is actually 3 weeks.
What is your dose?
So the dose, ideally it should be 0.5 mg per kg body weight at least. So if the patient
single dose or in divided
no, in
dose?
divided doses, sir. So if the patient
because single or a divided dose, there is so many controversy.
So the problem with single dose will be that it will create a lot of gastritis for the patient. That is the only problem that we have, especially some patients might even develop an ulcer also. If you give this in a divided dose, it's always better. So for a 70 kilo person, you need about 35 milligrams of steroid per day. What you can do is you can divide this into, we get 16 milligrams of prednisolone back in India, so we can do this as 16 mg twice a day to begin with for about a week. Then we taper it down to 16 mg once a day, and then we make it 8 mg once a day. That way we can taper this down, and then we can give it to the patient.
So what about the wash with the steroid? Will you please
at this point, before the surgery, washing with steroid is not going to really change anything, because the sinus is already blocked off by the polyp. So it is not going to really push the steroid inside the nasal cavity. And we know that polyps don't have a very good blood supply. It is actually the underlying bone which has actually got a lot of blood supply. But the issue is that because the polyp is sitting on top and it is relatively avascular, it will not take up the steroid wash. So that is why we prefer to give oral steroid here. Give me a J curate. So that is pre-operatively. The other thing, not this one straight. The other thing that we can do is we can give the patient some tranexamic acid. So there is now evidence that if you give 500 mg of tranexamic acid per day for about a week before surgery, that will help you reduce intraoperative bleeding. You can also do this intraoperatively also. You can give about 1 gram of tranexamic acid during surgery. That will help to reduce the bleeding.
And preoperative for 7 days?
Preoperatively for 7 days, yeah.
Thrice a day? 500 milligram?
No. Once a day or twice a day should be good enough.
Okay.
The other thing that you can do intraoperatively is you can reduce the blood pressure and heart rate of the patient. Now if you ask me which one of these two is actually more important, then it's the heart rate that is actually more important. Give me one more mirror, sir. Why is heart rate more important? Because if you look at the cardiac output is basically heart rate multiplied by stroke volume. Okay. So if you reduce the heart rate, then the cardiac output will actually come down. But if the heart rate goes up, so how do you increase heart rate? One, if the patient is not gone deeper into anesthesia or is not relaxed or is not having enough pain management, then the heart rate will go up. The second thing is if you drop the blood pressure too much, then as a compensation, the patient's heart rate will go up.
What is your preferred blood pressure during the operation?
So if you are talking about hypotensive anesthesia, then there is no one fixed blood pressure for every patient. The definition of hypotensive anesthesia is that it should be 30% maximum by 30% less than the resting blood pressure of the patient. So if your patient's blood pressure, resting blood pressure itself is 200 by 110, then you cannot expect the anesthetist to take it down to 90 by 60. Am I right, sir? Anesthetist.
Right.
So if you do that, what is going to happen is that there is going to be severe cerebral hypoperfusion because the patient's brain is used to a blood pressure of 200 by 110. So when the patient wakes up, he is going to wake up with a stroke. So that is the problem that you are going to have. So you cannot afford to do that to a patient, especially for a simple surgery like sinus surgery. You have to manage by other techniques. So the heart rate, ideally, again it is 30% less than the resting heart rate. Then this has to be measured not once but 3 times. So you measure blood pressure and heart rate at 3 different occasions, and then we can assess whether what is going to be the ideal hypotensive anesthesia for this patient. So some of the common drugs that we use, at least in my OT, we use dexmedetomidine to sort of we put a patient on an infusion, and that gives us very good controlled bradycardia. Actually, the bradycardia is much better when compared to the hypotension there. And that is exactly what we want. You want a lower heart rate but a near normal blood pressure for these patients. Okay. So that actually helps us a lot. But the only issue with dexmedetomidine is that it's very expensive to be used as an infusion, but it gives us a very wonderful feel. The other thing that you can do intraoperatively is that you raise the head end of the patient's bed, operating table, by about 15 degrees. This is called as reverse Trendelenburg position. What this will do is it will actually cause venous pooling in the legs. That way the venous return or the blood which is coming back to the heart, that is called as the preload. So if you reduce the preload, then automatically the cardiac output will actually come down. That way capillary pressure will be less and mucosal bleed will actually come down.
So do you prefer GA in your maximum cases?
Absolutely, sir. So I don't do a surgery without GA. Reason being that we cannot do a very good complete job in these cases because most of the cases that I get are actually very complicated. So like in Bangladesh, a lot of people are doing sinus surgery now, in India as well. So normally all these entry level cases sort of get filtered out, and I usually get most of the complex cases only. So coming back to the surgery here, so you can see now after the uncinate has been removed, you can see the bulla ethmoidalis in its entirety. Okay. So bulla is actually the most constant ethmoidal air cell. It is not the most anterior ethmoidal air cell. The anterior most ethmoidal air cell is actually the agar nazi, which is sitting here. You can see this is agar nazi. This bulge which you are seeing is actually the agar nazi, and it is much more anterior to the bulla ethmoidalis. But this is the most constant air cell that we see. Agar nazi is a pneumatization of the anterethmoid into the lacrimal bone, like was explained on the CT scan lecture. So you may or may not see it. It's not always mandatory to see it. So what I'm doing is I'm going between the middle turbinate and the bulla ethmoidalis. I'm reaching the space which is hiatus semilunaris inferioris, and I'm fracturing it anteriorly. And what we need to do now is just remove these bone chips. So you remove this bone, and you should be able to open into the anterethmoidal group of cells. Okay, debrider please. So again we are switching back to the straight debrider. Observe that the blade is closed. And what I need to now identify, after I remove the bulla ethmoidalis, the next thing that I need to identify is my lateral limit, that is the lamina papyracea. You can see here the bone, like I discussed with you, is very hard, so I am not able to remove it so easily. Can I have a straight through cut please? We are going to try to avoid using the drill as much as possible because it's a little more difficult to spare mucosa when we use a drill. But push comes to shove, if we are not able to use any cold steel instruments to remove all of these partitions, then we will be forced to use a drill. So again see, I am now removing the floor of the bulla ethmoidalis. So I am only trying to tug on the bone. Try to leave as much soft tissue behind. Can I get a straight punch please? Harrison's punch. So I am just going to try and define my lateral margin here. So the other thing that I forgot to tell you about giving oral steroids before surgery is that I don't wait for 3 weeks before surgery. What I do is I put the patient on 16 mg prednisolone twice a day, Predmet twice a day, and 1 week later I take the patient for surgery. Why do I do this? Because totally I need to give the patient 3 weeks of steroid, Blakeslee. So after surgery also, during the healing process, when the patient, if the patient is on some steroid, then the healing is actually much faster and much better. So you have to understand that after 1 week, you have reduced the inflammatory burden significantly now, just with the surgery. So in the healing phase, the patient will be stepped down to 16 mg once a day for a week and then 8 mg once a day for a week. That will be good enough to reduce the remaining inflammatory burden.
In case of diabetic patient, how will you maintain the dose?
So in case of diabetic patients, we will, if the patient has very strong osteotic signs, then I will still put the patient on oral steroids, but we will ask the diabetologist to sort of manage the dose of their medication. Can I have a straight? Yeah. So that way we can prevent a glucose spike when the patient is on steroids for a short time. And we would want to continue the same dose of medication probably for about 2 weeks after surgery also, because we are continuing steroids for 2 weeks after surgery. So this is 1 week before surgery and 2 weeks after surgery. The other advantage of doing this is that if you leave the patient with steroids for 3 weeks before your surgery, patient may not come back for surgery. Okay, they will think that, okay, I'm a lot better now, so let me see, maybe next time when I really need surgery, I'll go. But it's just a matter of time before they again start having inflammatory sinus disease. And the other problem, at least in India, is that we get steroids over the counter. So the patient himself might decide to take steroid the next time. He may not even come to you. He might decide to take steroids on his own, and that might land him into other complications like Cushing syndrome.
What you are using for the in the local, I mean, you are using with this Merocell to reduce the hemorrhage.
Yeah, so the I use plain adrenaline with saline. So the dilution ratio is 1:10. So 1 ampule of adrenaline, if you are using, you have to use 10 cc saline. So here we are using 5 ampules adrenaline with 50 cc of saline. The advantage of using adrenaline is that because it's an intense vasoconstrictor, it works on both alpha 1 and alpha 2 receptors. That way it reduces its own absorption. So you will not have a very big spike in the heart rate when you use adrenaline. So because it is causing vasoconstriction and because it is reducing its own absorption, so the chance of it causing a spike in heart rate because of absorption, punch please, will be actually on the lower side.
Do you use steroid during the nasal douche in the postoperative period?
Yes.
What is the concentration? What drug do you use?
The only approved drug for now is actually budesonide.
Budesonide, that is the inhaler cozy cap
Yes,
or
yes.
solution?
So what we use is actually, can I have a upturn punch, cobra punch?
No injection is available for the.
No, it is
budesonide.
actually what we use for the inhaler itself that is used here. So the dose is available as 0.5 mg per ml. So you can use 2 respules. So 1 milligram is what you want to use.
In each douching, in
Yes.
half liter of saline.
Yeah. So I use normal saline only. I don't allow the patient to use water because they may not boil it correctly, and if they're using borewell water, then the bacteria will be thermostable because it comes from much deeper. Upton Blakesley, please. It comes from much deeper from the earth's core, so they will not die when you heat the water up. So at least in the post-operative period, until there is mucosal healing, I would prefer for the patient to use actual normal saline. Debrider. So we are still opening up the entire bulla here, as you can see. And like we rightly predicted on the scan, you can see that the amount of osteotic bone is actually quite significant. Can I have an angled blade, 40 blade, please? Upton Blakesley if possible. So it is important that you open up this wall, that is the bulla is actually overshadowing onto the maxillary ostium. You can see that here. Can you see?
Sir, how many days will you use the nasal douche and how to prevent the recurrence?
So see, if the patient has got a temporary problem like a fungal ball, then it's going to be only until the mucosa heals. But this is a case of allergic rhinitis or allergic rhinosinusitis. So this is going to be for a lifetime. This has to be explained to the patient actually. It is similar to having diabetes. You have diabetes once, then you are not going to stop taking medicine, no? Because what are you doing? Like I said in the beginning itself, what are you achieving by doing surgery is only you are opening the sinuses to such an extent that there should not be any blockage for him to do the wash. The whole idea of doing surgery is to make him do the wash easily. Okay.
For this particular case, it looks like that it is an allergic rhinitis
Yeah, so
case.
he will require for a lifetime. There is no doubt about the fact. So very few people, there is now some evidence with Upton Blakeslee that some patients actually, can I have a wet gauze? Just wet this and keep it here. So some patients now we have proof that their immune system sort of burns out after a couple of years. If it burns out, then they can stop douching. But we don't have sort of any markers as to who is going to burn out and who is going to continue to have inflammatory sinus disease. We don't have those markers to predict them right now, but we are working on it.
Thank you, sir. So the point is, whenever any surgeon is claiming that if you do the surgery, things will be okay, will definitely backfire.
Yeah, absolutely. Because we see, I have seen surgeons who make claims that if you cut off the middle turbinate, you will have recurrence. I can show you hundreds of videos where middle turbinate is already cut off and there is thousands of polyps coming out of the nose. So that is not the correct way to, counsel, or even for that matter, if you are ever demonstrating surgery, don't ever make the blunder of saying that if I remove middle turbinate, you will not have a recurrence. Okay, so that used to be a concept, very old concept, wash please, which is called as the ethmoturbinal concept, which was initially, it was a hypothesis which was given by David Kennedy, but later he himself actually accepted that it's a wrong hypothesis. But unfortunately, people who have read that paper long ago have not bothered to follow up and see that he has discredited that hypothesis now. Exactly. He himself has discredited it. So the problem here is that it is similar to having asthma. You have a genetic problem, okay, where you have inflammation, inherent inflammation in your sinuses. In the case of allergy, the trigger is from outside. Okay, so it is dust, fumes, smoke, pollen, dog hair, cat hair, animal dander, ragweed, all these things which can cause inflammation in the nose and the sinuses. So how does this disease progress? Initially you will see the middle turbinate will be edematous. Why? Because maximum deposition or the highest air current or the eddy current is along the inferior surface of the middle turbinate, correct? So that is the reason why you see inflammation along the middle turbinate first. In such cases, the sinuses will not yet be involved in the stage 1. As time goes by, what is next to the middle turbinate? It is the ethmoid. Okay, ethmoid and uncinate will start getting involved. So this is the second phase. So in second stage or stage 2, this is called as central compartment atopic disease or CCAD. Okay, in CCAD, the peripheral sinuses are not involved. That is, whatever sinuses are lateral to the lateral wall of nose or above this middle turbinate area will not be involved. That means maxillary, sphenoid and frontal will not be involved in CCAD. It's only ethmoid and middle turbinate and inferior turbinate which will be involved in central compartment atopic disease. Now if you leave the patient at this segment, this inflammation is going to keep on increasing to involve the sinuses. In that case, you go on to develop something called as eosinophilic chronic rhinosinusitis, wherein you have involvement of the middle turbinate, ethmoid, maxillary sinus, frontal sinus. Sphenoid usually gets involved in the end. Okay, it is not something which gets involved early on. If you have sphenoid sinus involvement in a case of allergic sinusitis, that means that the disease has been very much long standing.
Yeah.
Okay, so this is the way the disease progresses actually.
So patient counseling has ever been the key.
Absolutely. So see, the problem in my practice is that I see about 40 to 50 patients per day. In private practice, that is quite a number. I don't have the time to sit and explain everything to every patient. So what I have done is, I have got another person basically who does allergy and immunology work. she sits down with the patient, shows them videos, and she actually counsels them entirely.
And there is another option, sir, that you can load some videos on YouTube and say that you just see my videos and you can understand everything.
But the problem is that they may or may not see the video.
Yeah, that's it.
Okay, if you leave it to them, they will not do it. Especially in countries like India and Bangladesh, the patient is least bothered.
Yeah.
What they want to do is, they want to blame the doctor.
Yeah.
So what I do is, I make sure that somebody explains this to them, and we take a signature also that this has been explained to them, and I also make sure that they write in that the patient will require lifelong douching, failing which the problem is going to come back. So this has to be taken in writing.
Yeah.
Give me a J curate, straight J curate. Here. So if you do that, then your chance of landing up with medico-legal litigation will become very less. Can you see the quality of this bone? See, it's actually immature bone.
Yeah.
Okay, mature bone will not have these pits here. Can you see?
Yeah.
So this is immature woven bone. This actually happens in two conditions. That is, one is it happens in inflammatory sinus disease like this. Actually, I am putting a lot of effort to break this bone. So this is very, very thick osteotic bone. The second condition that it happens in is inverted papilloma. Where does it happen? At the site of attachment of the inverted papilloma. Why? Because there is increased blood supply. So there will be increased amount of osteoblastic activity there. So these are the two areas where you will see very thick. And when I say inflammatory sinus disease, it could be anything from allergic, eosinophilic, AFRS, all these conditions you will see this bone. Okay. So now you have to break all of this bone step by step. Make sure in the meantime you attach, you manage to get some hemostasis. Don't be in a hurry to sort of, we can do this faster also, but you're going to have quite a lot of bleeding if you did. So try to control as much blood as possible in the field, especially since we are doing a demonstration. It's not that I want to show you that I'm really good at what I do, but I want you to see all the structures properly, that's all. So if you can see the structures well, then you will actually understand the concept a lot better. Rather than I can just, put my debrider in and debride everything and say that, okay, we are done with surgery, but it may not help you as much. So, can I get a punch, please? Yeah. So what you want to define here is, now I am trying to define. So the other thing is that you have to go wide before you go deep. Okay. Don't be in a hurry to open this area. I want you to clear out all the cells here before you can actually go deep inside. Why? Because if you have a bleeder inside, then you will not have enough space to manage it. So just like in mastectomy, we say don't make a well. You want to have more space. You want to make it wider first. The outer table has to be drilled nicely before you can go inside. Same way here, you want to create as much space as possible before you go deep inside. So I think now we are close to the lamina. So how do we know we are close to lamina? One, the bone has gotten thinned out along the lamina. Second thing is, I'm going to do some ballotment. Can you see this? Can you see this? Yes. So I am balloting the eye, so I am now on the lamina. So that is my lateral limit of dissection. Why the bone usually, when you have extensive osteitis, why this bone gets thinned out, I'll tell you. The lamina will usually be thinned out in cases of extensive osteitis. One, because it's a very thin piece of bone. That is why it's called paparesia. Paparesia means like paper. Okay. The second thing is, such a thin bone, you cannot expect that it is going to have a good blood supply. So what happens, because of the inflammation adjacent to the bone, you will have osteoclastosis. That means it will take away bone. But because there is no new blood supply coming into the bone, there will not be osteoblastosis. That is, new bone formation usually does not happen along the lamina paparesia. Except the exception to this rule would be that if you have an inverted papilloma or a malignancy, where the tumor itself brings in a lot more blood supply, in such cases you can have increased bone deposition on the lamina. So since this is the lateral limit now I am actually going to go more posteriorly and superiorly also. So the first thing, like I said, after removing the bulla, see now we have removed bulla in its entirety. Can you see any remnant except here superiorly we have some small remnant, but otherwise along the lateral wall it is completely removed. The other thing that I want you to remember is if you by mistake have opened into the orbit, that is if you have injured the periorbita, okay, then do not use a adrenaline pack. Why? Because if that adrenaline pack goes or adrenaline goes into the orbit, you can cause vasoconstriction of the retinal artery. In that case, the fundus actually will have very little blood supply. That can lead to blindness also. It has happened to some people as well. Okay, so be careful when you are using the adrenaline pack, especially if the periorbita is open. If lamina is open, that is not a problem, but periorbita should not be open. Can I get a urate? Yeah. Okay, so everybody is oriented now?
Right orient.
Yeah.
Dr. Gaurav, we are enjoying your surgery and at the same time you are speaking very nice way.
Thank you, sir.
Your scientific language is encouraging and enriching the knowledge of us and our students.
Thank you, sir.
Now,
Thank you so
at
much.
this point, can you please say there is a rule of 6, 12 and 24, how to ascertain the position of the anterior ethmoid artery and posterior ethmoid artery at the optical canal position?
Yeah, so the rule of 6, 12, 24 is basically from the lacrimal crest is what we talk about. It's actually from here. So from the, this is more to do with the, the scan rather than on a live patient. So the anterior ethmoid artery will be 6 millimeters behind the
anterolacrimal
crest, and the posterior ethmoid will be 12 millimeters. The anterior ethmoid will be 24 millimeters from the lacrimal crest.
No, it is 6.
The posterior, one second.
6, 12 and 24.
No, it's actually 24, 12, 6. I'll tell you. The anterior ethmoid is 24 millimeters posterior to the anterolacrimal crest. The posterior ethmoid is 12 millimeter posterior to the anterior ethmoid artery, and the optic nerve is 6 millimeter behind the posterior ethmoid artery. So that is how it goes.
Okay, okay.
So now we are getting a glimpse of the agar nazi here. Can you see this? So this is actually the agar nazi. How do we know it's the agar nazi? Because it is just behind the axilla of the, or just superior to the axilla of the middle turbinate. Okay. So now we know we have a medial limit. Medial limit is what? Middle turbinate. We have a lateral limit. Lateral limit is the lamina papyracea. Okay. So if you want to clear any tissue along the lamina, don't do this. If you do that, if you actually press along the lamina, you will go into the orbit very quickly. So if you want to do a clearance along the lamina, let us say with a debrider, first thing is you ensure that you have good control of the debrider. So what I am doing is I am using an angled blade. Can you see this? Why I am using an angled blade? If I use a straight blade, I will have to stick to the lamina. But when I am using an angled blade, I can stay away from it and just stay about a millimeter away, allow the tissue to come into the debrider. Okay, don't do this. If you are going along doing this, then the chance of you entering into the orbit is going to be very high. In fact, PJ Wormald, he did a study to identify how quickly the debrider can cause injury to the medial rectus muscle. It is actually a fraction of a second. It is less than 1 second is required for the debrider. Once it is intraorbital, less than 1 second is required for the debrider to actually cause injury. So can we get a straight debrider now? And I need some Merocell, please. So now where have we reached? We have reached the, what is this bone called? The second. You can actually do one thing. You can squeeze out some Savlon from this. It's too much. Squeeze out some Savlon. Squeeze it out. We have too much Savlon there. We don't want more. We want less. Squeeze it, sister. Squeeze it. So this is actually the second lamella which we have. The first lamella what we had was actually the, third lamella which we have. First lamella which we had was the uncinate process. Okay. Second lamella which we had was the bulla ethmoidalis. Now we have the third lamella, that is the basal lamella or the true lamella. What is the function of basal lamella? It actually separates the two group of cells, that is the anterior ethmoidal group of cells, which are smaller and more in number compared to the posterior ethmoidal group of cells, which are lesser and larger in size. Okay. So how do you identify basal lamella intraoperatively? So basal lamella is actually part of the middle turbinate. So if you observe here, you can see, so the part of the middle turbinate which actually attaches to the lateral wall is called as the basal lamella. You can see this is actually continuous with the middle turbinate. So this is middle turbinate, agreed, and this is the part of middle turbinate which is attaching to the lateral wall. So this has to be the basal lamella. So why did I actually, if you observed, I wanted to remove this bulla overhanging into the ethmoidal infundibulum. Why I wanted to do that is, you want to identify the maxillary line, which is the highest point of the maxillary sinus. Okay, can you see that? That is the highest point of the maxillary sinus. So if you draw a line from there and you come medially, the point where it attaches to the middle turbinate is called as the maxillary line. Now if you enter the ground lamella or basal lamella at this segment, then your chance of injuring any critical structures becomes very less. So what I do is, I will actually enter it at this point. So this bone is very hard, so you have to be careful, and you have to fracture this bone laterally. So once you do that, you will enter into the posterior ethmoidal group of cells safely. So why we fear when we are entering is because you don't want to injure the skull base. So this looks like it could be the skull base, but once we open the sphenoid, we'll actually be more sure about it. So when you open this, right, you can experience that there will be a lot more bleeding than you had in the anterior ethmoidal group of cells. So this is expected. Why? Because you are getting closer to the sphenopalatine artery. So the caliber of the vessel as you go posteriorly will be much larger than when you come anteriorly. The caliber of the vessel will become much smaller. So you are going to have a lot more bleeding as you go posteriorly. That is the reason why skull base surgery is so difficult, because majority of your work happens behind the anterior ethmoid, that is in the sphenoid or along the skull base is where majority of the work happens. Okay. So don't be afraid if you have a lot of bleeding, just pack and wait for the bleeding to stop and then you can proceed again. So what is this structure that we are seeing? This is actually part of the superior turbinate. Okay. You can see this bone is also very much osteotic. Now it is not prudent to leave such osteotic bone, especially in the olfactory fossa, because this will cause anosmia for the patient. Okay. So you want to remove this inflammation. If you don't remove this inflammatory load, then what will happen is the patient will say that your sinuses will look all beautiful, but still the patient will say that I don't have a good sense of smell. So that is the reason why you don't want to leave this bone. If you want, you can leave the soft tissue behind, but this bone you don't want to leave it behind because it's extremely osteotic. Okay. So what am I trying to do? I am actually just trying to grasp the bone alone. I don't want to injure the mucosa if I can help it. Let me try my best. Okay. So that was good. So we have removed that osteotic bone. So you can see that this part of the bone is also quite flimsy. There is a cell here. So this partition has to be opened up. This is called as a retromaxillary cell. Can you see that? This is behind the maxilla. So it's called as a retromaxillary cell. Straight Blakesley. So this horizontal partition we have to remove. So we are going to try to make as big of an opening as possible. Can I get an upturn through cut, please? So you can see here that there is a party wall between the ethmoidal infundibulum and the posterior ethmoidal group of cells. So this party wall, I am actually going to take it down. Okay, because if this party wall is there, then one, it will not allow the wash to go into the maxillary sinus. Second, if the wash goes in, it may not allow it to come out. The patient will feel some form of pressure in the maxillary sinus at all times because of that. Okay, because it will keep stimulating the branches of the infraorbital nerve. So they will say, I have some pressure in my maxilla. That is what they might tell you. So is this the sphenoid sinus, what we are looking at? I think on the scan we had discussed which side is the sphenoid dominant. It's actually dominant on the other side. So here we may not find a sphenoid sinus actually. I don't think there is a sphenoid sinus on the left side. Yeah, so here we don't have a sphenoid sinus actually. So this is the end of the dissection as far as sphenoid is concerned, because this side we don't have a sphenoid sinus. It's only present on the right side. So that is something that you need to make note of. I have actually seen one of the surgeons, not in a demonstration, but when they were operating. So the patient did not have a sphenoid sinus and they kept poking into this space and they landed up creating a carotid bleed. Okay, so you have to be very careful when you are reading your scan. If you are in doubt, it's better you leave that sphenoid sinus unopened rather than create a complication, because carotid bleed in a sinus case is not really acceptable. No court of law will be able to protect you actually. No lawyer can protect you also, because it is so it is a very gross error to have. Especially if the CT scan is showing that there is no sphenoid sinus and you opened into that space trying to find the sphenoid sinus, that means you don't know how to read a scan, and that will be used against you by the defense lawyer, sorry, by the offense lawyer. Of sphenopalatine artery, you will have to remove this mucosa. You will not be able to see it without removing that mucosa. Yeah, I can show. Can I have a wash, please? Suction. So can you appreciate the fact that now the ethmoidal cavity is nicely opening up?
Exactly, we can appreciate the different sinuses.
So this is the remnant of the superior turbinate. Can you appreciate? That is the nasal septum there. This is the third or the final attachment of the middle turbinate to the lateral wall. So I have a question here, how to identify. If you want to do a sphenopalatine artery ligation, where do we go? So this point of attachment that you see, if you come
posterior attachment of the
middle turbinate, if you come anterior by about a centimeter or so, you can make a L-shaped incision here. You make an L-shaped incision like this and you raise this mucosa. When you raise this, you will actually identify a projection of bone which is called as the ethmoidal crest. That ethmoidal crest is the most consistent landmark for identifying the sphenopalatine foramen. So if you remove the ethmoidal crest with a punch, then you will actually enter into the sphenopalatine foramen. Can I have a J curate, please? Not this, the straight J curate. Yeah. You can take that elevator. So you want to sort of open up these cells. Yeah, there is a lot of osteitis here. Not able to fracture this bone.
So you are fighting.
Can I have a punch, please? Yeah, straight punch. So let's try using a punch here. If we are not able to, then we will have to probably drill it out, but yeah. So luckily we got away with the punch. I would try my best not to use a drill for an inflammatory sinus case, but push comes to shove and I'm not able to even remove this with a punch, then I won't have a lot of choice left. In that case, I will have to drill down this bone. Just clean this. Okay, so now we are just going to remove this posterior ethmoidal group of cells. What do we need to identify now? The next landmark that we need to have, we have identified lamina here. Okay, we need to identify this as the skull base. Just give me a straight Blakeslee.
So you have reached up to the posterior limit of this side.
Sorry?
Posterior limit in this left side.
Yeah, pretty much. Just give me a upturn punch, please. We are actually now exposing the skull base. We are coming from behind forwards. So we are trying to remove the bone along the ethmoidal roof now. Roof of the ethmoid sinus. Okay. Can I have a angled debrider now? Give me a Maricel pack. Upturn Blakeslee. Here it's here. That's a through cut, I think. That's not a Blakeslee. Oh, that is a through cut. What you just showed is a through cut. No, we're not. Frontal will come here actually. Accurate. So we're just clearing all the cells along the skull base. Okay. We're just doing this along the roof of the ethmoid sinus. We're trying to identify the cribriform skull base. I'll just give me a wash in my hand. Can you hold a suction? One more wash. So one of the things that we need to understand is when we say chronic sinusitis with polyps, without polyps, right? When you say with polyp, you are not really doing much benefit by just classifying it as with polyp. Okay. So this is like saying patient has got fever for evaluation. Okay. Or pyrexia of unknown origin. Because this could be dengue, it could be malaria, it could be anything, right? So when you say polyp, what is a polyp? It's a marker of inflammation, that's all. Okay, you can have polyps in allergy, you can have polyp in chronic sinusitis which is inflammatory, you can have it in allergic fungal sinusitis, even you can have it as a secondary problem in tumors, right? So you have to define what is the etiology of the polyp. Or a better example would be saying patient has vertigo. Are you happy with the diagnosis that patient has got vertigo? Don't you want to know if it's Meniere's disease, or if it is BPPV, or if it is central vertigo, or it is psychogenic vertigo, migraine associated vertigo? You want to know what the cause for this vertigo is, right? So here also you would want to know what is the cause for the patient's polyp. That polyp is just a representation of inflammation, that's about it. Okay, so you would want to classify this further. You have to identify, that is why it is essential that you do a biopsy. If you do a biopsy, then you will get to know what is the predominant inflammatory burden there. If you identify the predominant inflammatory burden, then life is easier for you as well as for the patient, because then you know whether this patient has to wash for a lifetime, how frequently they should come. If it is allergy related, then it depends on whether the patient has got a perennial allergy or a seasonal allergy. If it's a seasonal allergy, then it could be something like pollen. If it's a perennial allergy problem, then usually what happens is it is usually dust mite or a pollen which is present throughout the year. Upturned Blake slip, please. It's actually very hard. We are very close to the posterior ethmoid. Can I get a drill, please? Because this is not going to come with a punch or. Yeah, that will be okay. So when you are drilling here, you have to be very careful, because you see here the periorbita is exposed in this area. Okay, and I want to clear out this bone. I want to clear out this bone. Okay, and this whole segment of bone which is actually causing a sort of horizontal ridge. Okay, so I want to clear out all of this. So you have to be very careful not to go intra-orbital. Okay, so what we are going to do is, you don't have a diamond burr? You have a diamond burr? Show me, show me. Show me. You have one more diamond burr? Bigger one? That's cutting. That is diamond. Okay, let's just see. We'll just try and see if this works. This is actually quite blunt, so. You have to have a very firm hold of your debrider. You don't want this drill bit to jump. And if you observe, I am drilling only on the ridge. Okay. The only problem with using the burr is, because it rotates at a higher speed, it is going to pull some of the mucosa off. But since the patient is going to be on steroid post surgery, it is not such a big problem. This mucosa will come back. But if you leave all this bone, see, I am drilling it and still it is like not budging. If you leave all this inflammatory load or bone behind, patient is going to have definitely a lot more disease left behind than just clearing out some of the mucosa. Just give me a debrider now. Or give me an upturn through cut. Through cut, yeah. Not 90, you don't have a 45-degree through cut. So I'm just going to go and try using a through cut here to sort of clear out all of this that we have, sort of broken down the bone with a drill. Blake slip. Any doubts in the audience? I'm happy to answer them while I'm operating. Hello?
No, it's fine. It's fine. I will request the juniors, if you have any question, please come up.
Anterior ethmoidal artery. Yeah, I'll show you. When it comes, I'll show you.
Dr. Gaurav, can
Yes,
you hear
sir.
me?
Yes, sir. Yes, sir.
Actually, for your kind information, the house is full. There is no one seat more for seat anymore audience. Okay.
Yeah, thank you.
So you will
Thank
be happy. Everybody of our audience is enjoying your operation.
upturn
But
flex, please.
I have a question here.
Yes, sir. Yes, sir.
Can I ask you?
Yes, sir. Please, sir.
Actually, the practice
Yeah.
is to do the sinus surgery.
Yeah.
Usually, we do practice the frontal sinus first.
Yes, sir.
But-
That is called as intact bulla technique.
Yeah, yeah. But did you practice it or not?
I did. Like, so for me,
But this case, you did not follow it, right?
No, I didn't. So the thing is, for me right now, I would want to identify the skull base before I go into the frontal sinus, because if I just trace the skull base backwards, then I will enter into the frontal sinus itself. There is nowhere else that I can go. So that is one thing. Second thing is, I have very little space to work with such heavy osteitis, and the lamina is actually eroded here. Can you see? So having these sort of issues, if I try to do an intact bulla technique, then the problem is going to be that I think the BP monitor is not working. Then the problem is going to be that I'm going to probably cause more amount of damage in the frontal recess than I can do good. So you can see there is a very small sphenoid sinus ostium here. Let me just try to open that up. Straight through cut, please. Straight through cut. Straight through cut.
Actually, for our juniors
Yeah.
who started right now to the face surgery earlier, okay? That's
Sorry?
beginner.
Yes, sir. Yes,
For
sir.
beginner, as
Yeah.
you're expert in face and skull base surgery,
Yes, sir.
what is your advice them to early the intact bulla technique or what you are doing now? this
So
technique?
intact bulla
Which one will be
technique to
better?
me, it makes sense if you are really worried about the anterior ethmoid artery, then yeah, intact bulla technique will make sense. But it is more about your comfort. Are you more comfortable with less space? If you are happy to do it with lesser amount of space, then yeah, intact bulla technique will work for you. I would like to have more space when I am actually operating in the frontal recess.
Okay.
So for me, to me, this is not that it's a generalized statement, but at least to me, when you're doing intact bulla technique, you are actually compromising a lot on the space that you have, and your instrumentability will be much less. And in this case, if you observe, this was not a good case for intact bulla. Why? Because the bulla was so prominent.
Yeah, yeah.
Yeah?
Yeah, right.
The bulla was so prominent that it was coming into the ethmoidal infundibulum also.
Yeah.
In such a case, what are you going to achieve? You are actually just going to compromise your access to the frontal recess. And in that process, what will you do? You will create more cicatrization. Okay, so you are going to create more cicatrization in the frontal recess and create iatrogenic frontal sinusitis. I would not do that rather.
Okay, thank you.
So there is a very rudimentary sphenoid on this side, almost as good as non-existent. You can see that. Okay, so that is a very small rudimentary sphenoid that we have.
Yeah, yeah.
This one. This is actually the rudimentary sphenoid. You can see that. And this is an onodi here. You can see the optic nerve shadow there.
Yeah, yeah.
Yeah. So this is a rudimentary sphenoid. So let me just use a punch to open this up.
Which sphenoid is good for surgeon, rudimentary or huge pneumatization?
A big pneumatized sphenoid is something that I like because
Yes.
it makes my skull base surgery easy for me, especially if you are doing
Yeah.
a pituitary case.
Okay.
If you have a small sphenoid, you will have to do more drilling.
More drilling, right?
Yeah.
It is a conservative of.
Absolutely.
Yeah. So you need to drill more bone to reach the
Skull base.
Sella.
Yeah.
Okay.
I prefer a well pneumatized sphenoid.
But
So now you have identified the skull base. Can you see that?
Yeah, yeah.
You have identified the skull base positively. Give me a straight through cut. So what am I going to do? I'm going to join this rudimentary sphenoid with this onodi here. So I'm using a straight through cut, and I'm going to make this onodi itself as the new sphenoid. Okay, because you don't want any mucus stasis to happen in that sphenoid. That sphenoid is of no use to have such a small sphenoid. It's not going to benefit anyone. So might as well open this party ball and make this into one sinus.
Yeah.
See that?
Onodi and sphenoid.
Absolutely.
Yeah,
See that?
yeah.
See that?
Okay.
Okay, so just make it into one sinus, because if there is mucus which is collecting here, that will create more problem for you. Can I have a drill, please? Straight drill. Drill. Cutting diamond, whatever you give, I'll take. Give me a punch. So because see, there is a partition here. Can you see this partition? This is not a this thing, septum, incomplete septa or anything. This is actually a proper partition, and if you see the scan, you will see that there is hardly a sphenoid sinus on this side. There is barely a sphenoid sinus on this side. Opposite side has got all the sphenoid actually. So that is the reason why this is actually an onodi cell here. And if you see, the pneumatization is posterior superior. See, sphenoid is ending here, but onodi is going much behind the sphenoid. Can you see? And what is the position? This is posterior superior, this is antero inferior. So this has to be sphenoid, this has to be onodi. Okay. What am I going to do now? I'm going to drill this inferior wall. Okay. To sort of make a nice wide extension. Okay, debrider please. So this is good because, see, I would want to rather show you a more challenging case than show you something which is, what we call as lollipop cases. Lollipop cases will not do any good for anyone. The more challenging case that I that I demonstrate to you, the better understanding that you will have how to handle complex cases, right? Because what happens is, when the demonstrator demonstrates here, everything looks very nice and hunky-dory because because of the choice of the case. You choose a easy case and you demonstrate, and then everybody feels like, okay, I can do this, and go back and try to do it. And then they realize that, oh God, this is like, there is so much bleeding happening in this case. I would rather show you a case which is, tough, and how to manage
actually,
it.
sir, you are doing fantastic surgery, okay? Every one of us enjoying your surgery. It's a very difficult case and you make it easy. So easy.
Actually, it is easy. I am not making it easy. The thing is, people have made it difficult. Let us put it that way.
Yes.
Punch, please. So there has been so much fear which has been created around sinus surgery that most people are very scared to take it up. But at the same time, I want to say that, as a beginner, you should know some amount of your limitation.
Yeah.
I'm not trying to dissuade anyone from doing sinus surgery, but I've had a experience just 2 weeks back where one of the youngsters actually has completely eaten away the medial rectus muscle of one of the patients. So if you are not very well versed with your anatomy, again, see, surgery without reading is definitely not going to work for you. The first step to anything is you need to read. If you are going to be able to read well, only then you will be able to know where I am. And mind you, I want to point out that navigation cannot be an excuse for your lack of anatomical knowledge. If you think that I have navigation and that I'm going to use navigation and manage and I don't want to read,
No.
even though you keep the navigation probe, you're not going to know where you are. So how can you interpret where you are? So at least to know that, you should have a very good anatomical knowledge. There is absolutely no excuse for not having anatomical knowledge. Now there is one very nice thing that I want to show you here. Okay, what I want you to appreciate is, if you observe the kind of bone that we were taking out, the superior turbinate, the the cells and everything. Did you observe? I showed you it's very immature woven bone, correct? See this bone. See this bone? This is not healthy looking bone. But at the same time, I want you to appreciate this bone. See, this is very healthy looking bone. You understand?
Yes, sir. Yes.
So this will not cause any problem. This bone will not give you any trouble at all, because there is no inflammation in that bone. But you look at this bone, it is so uneven, jagged. This is all neoastigenic, immature bone. This bone, you try not to leave it if you can. If you don't have a drill, you don't have a choice. But if you have a drill, then you would rather use that. Because if you think that, okay, I'm going to focus more on mucosal preservation, and you leave this osteotic bone, the mucosa will respond to even nasal douching with steroid, but this bone will not respond to nasal douching. Okay, you will have to put the patient on prolonged oral steroids to get a good result there. So you would rather drill out all this unhealthy bone and leave the patient with healthy bone. Can you imagine such thick bone along the lamina? So where we are working is on the lamina only right now. So now can you see this is healthy bone? Agreed? This is much healthier than what we were seeing back there. One second. So don't try to replicate what I am doing. Okay, I'm actually very close to the periorbita here. Yeah, no pressure, absolutely. So it's important, if you are drilling along the lamina, don't put any kind of pressure on the drill. Yeah. So see, there is not a single partition on the lamina now. Can you appreciate that? All the way up to the neosphenoid. I would like that drill still. Except for there is a ridge of bone here. So this ridge of bone, what is the problem? Is that it would create a pocket behind it. See that? So I would rather want to remove this ridge of bone.
Do you think that this ridge of bone lies over the carotid canal?
By the vertical?
Carotid artery.
No. Carotid will come behind the sphenoid wall. I am in front of the sphenoid. So this is actually part of the pterygoid process. One second. So just to clarify, see, you can see this is the optic nerve there. Can you see this opticokerotic recess here? See, it is not a very prominent OCR, but can you see this?
Right.
This is called as the medial OCR. Okay.
Right.
So the opticokerotic recess, below that will be this blue shadow. Can you see this blue shadow here?
Right, sir.
That is the cavernous segment of the carotid. Okay, I am drilling here. Can you see this bone which was here? Right. I am far away, about a centimeter away from the carotid. Okay.
Right.
So this is good enough. Now it is open to the nasal cavity, this area. Give me a Marocel sponge, please. So now you've identified that that is the skull base above there. So there is a ridge of bone here which needs to be smoothened out, right? So I'm going to place this sponge here to reduce this bleeding in the sphenoid. We have the second OT also, no? We have access to second OT? Okay.
Because of you have another question for the mid expert. There are a bunch of questions.
Okay.
Asked to you.
Okay. I was thinking that when I'm demonstrating the second slide, we should probably start meet the expert, so we can save time, and we can keep this as picture in picture. I will answer the questions from here only. Yeah, that will be easier to save time, no? Okay. Agreed. Okay, I'll manage both, don't worry. Let's not waste people's time. What we want to do is we want to give them maximum knowledge in these 2 days. Instead of only me, let everybody get a chance to. Give me the punch, please. You can, but what I usually, like I said, the mucosa is looking very nice. So I don't want to damage the mucosa if I can help it. With the drill, because it rotates, it usually will pull some of the mucosa. Like if you see here, see, it will pull some of the mucosa. You can't really help it. But if you can avoid using the drill, then you should.
But this mucosa is very healthy. It is very much required to remove this bony hanging hair.
Yeah. So without damaging the mucosa, if you can remove and make a smooth wall, like you want this whole space to be like a waterfall. It should just, the frontal should just drain like a waterfall all the way back. You don't want to leave any partitions. What happens if you leave partitions is that mucosalization will not happen sooner. If it's a flatter surface, it's easy for the mucosa to grow over and above this. Upturn through cut. Okay. So now what I'll do is I'll switch over to a 70-degree scope. We'll try to open into the frontal recess. One more Marocel, please. So everybody is happy with the dissection so far?
Oh,
Any
fine,
doubts?
fine. Thank you.
Any doubts? Now we are going to the frontal sinus. So what I want you to appreciate is the fact that, see, now we have so much space to work with angled instruments. Can you see that?
Sure.
So I'll show you where the agar starts and how much space you would have genuinely had if the bulla was still intact. This was a very prominent bulla. So this was not a good case actually to do.
Intact bulla.
Yeah, it was not a good case, because if the bulla is so prominent, you're going to land up compromising your access. And the number one rule in any surgery in ENT is access has to be very good. So can you appreciate now? I'm using a 70-degree scope. I'm rotating it. You're looking into the maxillary sinus. Can I get a backbiter? So this would be a good opportunity for you to actually fine tune your maxillary sinus surgery. You can see there are a few bone chips sitting there. What I would want to do is just remove those bone chips. Okay. So now you can see that is the infraorbital nerve shadow. Can you see that?
Right, sir.
Yeah. So I've got a question saying how to handle the 70-degree scope. So there are two ways of doing it. So if you're working in the frontal sinus, if you're not very comfortable, this is the technique I would advise. So identify, you come in looking upwards. Identify the middle turbinate and the axilla and go into this. So when you're going here with my left hand, can you see on the external camera what I'm doing?
Yeah, we can
Yeah,
see.
so you can see now that is I'm at the junction of the middle turbinate. So when I come here, I slightly rotate the scope, go in and then rotate back. If you go straight, you are actually soiling your scope. Can you see?
Right.
You will soil the scope. What you do, either there are two maneuvers which you can do. One is you will have to go lateral and then go like this. Okay, that is
right.
one maneuver. Other one maneuver is you just tilt the scope like this and then come back. Now if you want to work in the maxilla, you can just tilt the scope at 90 degrees and you will be able to look inside the maxillary sinus.
Right.
If you want to go straight looking like this only rather than look up and go, identify the inferior turbinate. See, this is the inferior turbinate. Come above the inferior turbinate and then just go along the inferior turbinate roof and you will reach the maxillary sinus. So these are the two ways you can work here. Okay. So now can I have an upturned Blake sleeve please? So now we have identified this is the axilla of the middle turbinate. Can you upturn please? Here, it's here. It's here. Okay, so you have identified the axilla of the middle turbinate, correct?
Correct.
So now the cell which we were seeing here, this bulge what I was telling you is called as the agar nazi, correct?
Correct.
So give me a J curate. Now what is the boundary of the frontal recess? Straight would be better. Okay, it's okay, I'll use this. So the boundary of frontal recess is actually the posterior wall of the agar.
Agar-nazi.
Yeah, so this is where the bulla was attached actually. Can you see? We still have little bit of attachment left here. Can you see?
Right. You can see.
Yeah, so this is how much space I would have, if I would have done intact bulla, I would have had to work within this much space. Now I have space all the way here, so I have space for angled instrument. Imagine this bulla was coming from here and it is attaching here. Can you see this remnant here?
Yes. You can see.
So I would have had like only this much space to work. Is it really worth it? Is the question that you have to ask yourself. If you are happy working within that space, absolutely it's your call. Nobody is going to judge you or nobody is going to judge me also. Ultimately the goal has to be only one thing, that you have to open the frontal sinus properly without causing curved suction please. Without causing any injury in the frontal recess. If you can open the frontal sinus, then fantastic. Go ahead and open. Whether it is intact bulla or not intact bulla, nobody will ask you once the frontal is open. Correct? So now what we need to do, we have identified this is the anterior most ethmoidal air cell, which is actually the agar nazi. Okay? You can see this is the agar nazi cell because I can identify a roof here. But there is a communication between agar nazi and the frontal also. Can you see that?
Yes.
So there is two ways of doing this. Let me just take a look at the scan. The frontal sinus on this side is, it is a little narrow. Okay. So give me a J curate or a curved punch. So there are two ways of doing this when you are opening into the frontal recess. One, either you can come from behind forward, wherein you just punch out all this bone. That is nothing but the posterior wall of the agar nazi, and you can see this bone is not looking healthy again. Can you appreciate it?
Yes.
See this? It's got like this ragged
Spongy
edges.
type.
Yeah.
Spongy.
Yeah. You can see, appreciate that this is all osteotic bone. That is why there is so much polypoid inflammation that is happening here. And when you are doing any punching of a horizontal, ridge of bone in this area, do it along the middle turbinate first. Why along the middle turbinate? Just in case, if the anterior ethmoid is in a mesentery here, then you want it to bleed inside the nasal cavity here. You don't want to remove this bone and it retracts into the orbit. Correct?
Correct.
So you want to see, this was the agar. I just want to show you the anatomy very beautifully. I can show you now. So I told you that the boundary of the frontal recess is posterior wall of the agar, anterior wall of bulla. See, this is anterior wall of bulla, this is posterior wall of agar. In between that, if you go, you will reach the frontal sinus. Can you appreciate that?
Yes, you can appreciate nicely.
So can I have a curved debrider plate? So what I need to do now is I am going to remove all of this bone. All of the mucosa, and take you straight inside the frontal. You can appreciate here there is some bone that is actually, there is some bone that is actually very osteotic. And where up to what limit should you take this opening? So you can see very nicely, this is the skull base here. This is the lamina.
Right.
This is the middle turbinate. So I
Right.
have to remove this ridge of bone here. It's blocked, I think. So can you see that is the frontal sinus?
Yes.
This
you
is
can
the
see.
agar. See, there are two separate cells. See this?
Right, you can see.
Okay, J. Curate, please.
Nicely it is censored.
So what happens is when it comes to frontal, nobody will usually take the time to identify these landmarks nicely. They just start poking around and then they create either a CSF leak or excessive bleeding. You know, these are the problems. If you identify the anatomy so clearly, then there will not be any confusion, and this you have to do from the first day of your sinus surgery. Don't think that when I become an expert I'll do this. To become an expert you have to do this. If you really love what you do, then you will actually enjoy the process more than the end result. Okay? So see, now again I am actually opening a horizontal ridge. So where should my opening be? It should be along the middle turbinate, not along the lateral wall. J. Curate once more. So what I would want to do is I want to check if I can extend this opening still more anterior. Okay, I am just checking what is the bone. Okay, how hard is the bone? So you want to remove this agar completely and try and make it into one opening. Absolutely, I completely agree with you that it is a little difficult to do instrumentation with an angled scope and an angled debrider, but that is something that comes with practice. So the other good thing that we have when we use an M4 is, can you see I am rotating the blade of the tip of the blade. Can you see that?
Right, you can see. It's
Yeah.
very, very important to keep the
Blade
side,
in view.
blade
Yeah.
side,
So
right,
see this?
in control.
Now if I want to remove tissue along the posterior wall, I can always do that here by looking at the cutting edge of the blade.
You have turned the cutting edge.
Yeah. So can I have a drill, please? You can see that on the lamina here, there is still a little bit of osteotic bone. Can you see that?
Right, you can see.
Yeah, I mean the frontal sinus is open.
Yes,
Okay,
sir.
there is no doubt about it. Frontal sinus is open, but what will happen now is, if this osteotic bone is left behind, this osteotic bone, can you appreciate this?
Yes, you can.
Irregular jagged bone, if it is left behind, yeah, this we will remove. Let me just drill this out, or you can give me the debrider if it's already there. Oh, drill is in. Okay, no problem. So what is the landmark for anterior ethmoid? It is usually one cell below the frontal. So this is frontal sinus, this is the rudimentary supraorbital cell, and this is the anterior ethmoid artery here. See this?
Yes. you
Okay,
can
so
see.
this is the anterior ethmoid artery. Okay. So let me just try if I can drill out the opening is very narrow. Can I have a diamond drill? I don't want to use a cutting burr here because the space is very, very narrow. A small diamond will be nice. Ah, yeah, give me that one. So normally what I use is I use a stylus handpiece with a transnasal burr because the shaft is very thin and narrow. Okay, but here we don't have a matching handpiece for the drill that we have. So we are using this debrider blade, debrider burr. We'll do with whatever we have. Try to be as safe as possible. Drill out all of this bone to sort of create a nice wide opening. Yeah, the important structure is the orbit. So here you can enter into the orbital fat very fast. So the stroke should not be like this. It should be longitudinal. Okay, you don't want to drill at one point very long, because then you will dip into the orbit. Give me a wash, please. Can you switch that to a debrider, an angle debrider, 90 degree or 60 degree debrider, preferably 90 if you have. Dr. Martin has not come today.
No, I've not seen him, sir. Tomorrow he will come, inshallah.
Okay, okay. I'm so used to having him ask all the questions. So, he has a very dynamic personality. Debrider? I'm done. I'm done now. I'm done. This is the last bit. Once we remove the polyp, this side fest is over.
But what would you do if the whole frontal sinus would be blocked with the or filled up with the polyp?
Sorry, sir?
What would you do when the whole frontal sinus will be filled up with polyp?
We still go in and debride. There is no problem with that.
But the lateral margins cannot be seen by your scope.
Yeah, so if that is the case, see, the polyp is not the problem, right? The problem is the fact that the sinus is not open. So you just open the sinus and put the patient on oral steroid if you feel that it's not safe. The other option is, if you want to do, like let us say for polyp I would not do this, but let us say there is a CSF leak far lateral in the posterior table. Then you can do something called as an orbital transposition. Okay, can you see that? That is the frontal sinus. How do I know? There is a concavity there, convexity along the posterior table. Can you appreciate?
Right, we can appreciate.
Yeah, and see the bone. The color of the bone is yellow. Whereas if you see the bone here, it is more whitish. So that tells you that it is dense bone. So that dense bone is nothing but, that is the frontal sinus. So you can see the whole skull base like a waterfall. It is draining down. That is the maxillary sinus that is nicely open. All the way up to the roof we have opened. All the way up to the posterior wall we have opened. That is the inferior turbinate. Up to the nasolacrimal duct. Just give me a straight Blakesley. And posteriorly our limit would be the skull base and the sphenoid sinus. Suction please. And see, we have preserved as much mucosa as possible. And we have not left any of that inflammatory dirty looking bone. Have you just observe? We have not left any unhealthy looking bone anywhere. Okay?
Okay, it's an excellent job done.
Yeah. So this is what you want to have as an end result. So I can even rotate this 70 scope. There is a small piece of Merocell here. Straight Blakesley please. So I can use this like a 0 actually. And I'm going to remove this Merocell. So if you really want to get good at sinus surgery, start using the 70 scope more and more often. See, this is a rudimentary sphenoid. Can you appreciate?
Right, we can
There
appreciate.
is barely anything there. If I had a straight transnasal burr, I would have drilled this even more. The problem is that burr is a little thick. I will end up damaging a lot more mucosa than doing good. But this is a rudimentary sphenoid, so I'm not going to really touch it. That blue shadow what you're seeing there, that is the carotid. Okay. Can you appreciate?
Yes.
That is the carotid, and that is the optic nerve. Okay. So now we have completed this side. I think due to lack of time, we would want to proceed with meet the experts. Okay.
Thank you, sir. Thank you very much.
Yeah, thank you. Yeah, somebody will do the other side. Yeah, that's okay.
Hey, yeah. ওনাকে নিয়ে যাও আশরাফ এই কই হ্যাঁ আমি
We observe the very excellent surgery from Gaurav medical. Now the session is here. Meet the expert. So don't go outside. This session will take 45 minutes. So after the meet the expert, then we will the prayer and lunch break. No. Now this is the time for the meet the expert. This session is moderated by Professor Dr. Zakaria Sarkar, and it is chaired by Professor Dr. Alamgir Chaudhuri sir, Professor Dr. S.M. Khurshid Alam Mujumdar sir, Professor Dr. Shahjahan Kobir, and our panelists is, our experts are Professor Dr. Sheikh Hassanur Rahman Babur, Dr. Tushar Kanti Ghosh, and Dr. Gaurav Shankar Medikari. And here is the reporter, Dr. S.M. Azizur Rahman. So now I request Professor Dr. Zakaria Sarkar sir to come on the dais with the chairs.
Assalamu alaikum. Welcome you all the very much exciting session. Meet the expert. World class expert panel is coming to give the answer of your question. All questions are collected from our audience. When without edit, it will deliver to the panelist and they will give the answer. Our panel of experts are Professor S.K. Hassanur Rahman, Gaurav Shankar Medikari, and Dr. Tushar Kanti Ghosh. And session will be going to chair by our honorable teachers, Professor Dr. M. Alamgir Chaudhuri, Professor S.M. Khurshid Alam Majumdar, and Professor Dr. Shahjahan Kobir. এবারে ল্যাপটপ থেকে দেন। Our first question from the audience. Usually we don't always identify anterior and posterior ethmoidal artery to stay at safe zone. Should we always identify the arteries? Dr. Babur sir, in your practice, you always identify the arteries? Mike, please.
In endoscopic sinus surgery, actually, what surgery we are doing depends on that. If we have to do ethmoidectomy, in that cases, it usually comes in the field. But again, it depends on the Keros typing. If this Keros type 3, there may be mesenteric artery. We have to be very much careful in that cases. But in Keros type 1, it may be in the skull base. So we have not to expose, but we can see the that bulging of the artery, that is ridge-like structures. In that cases, we have not to expose the artery. If it is not, it is mesenteric type. In that case, it may be common field. So we voluntarily we should not have to expose the artery in all cases.
Dr. Tushar, what is your experience?
My experience is totally different type. We should not expose, but we should know the anterior artery. Where is the anterior artery? Here, this case, same. I always prefer different mixed system. Bulla ethmoidalis, definitely inferior part I always open with 0 degree, but with 70 I only open the frontal and upper part of the bulla. So I always, when I use the 70, I always down with curve instrument, curve sucker. Then I always teach my junior, this will be the anterior. Sometimes anterior will be exposed, sometimes not. But I should know, and all ENT surgeon, when you are encounter, you should know the anterior artery, where will be the anterior artery, but should not expose. You should know, and also posterior artery. But sometimes it's very easily identify the anterior artery, but not easily posterior artery. Sometimes within the bony layer will be there.
Gaurav, would you like to add something?
If we are doing some skull-based procedure, like if you're doing a transcribriform approach, then you have to expose the anterior and posterior ethmoid artery because you have to ligate it, because you're going to remove the whole of the cribriform. But if you're talking about a routine sinus surgery like a FES, then you don't need to expose both arteries actually, but you should know the landmarks. Posterior ethmoid is very tough to expose. In fact, you have to drill a lot of bone to reach the posterior ethmoid because posterior ethmoidal skull base is much more thicker than when compared to the anterior ethmoidal skull base. Anterior ethmoidal skull base, when you're talking about the anterior ethmoid artery per se, if you have a supraorbital pneumatization, then always, as a rule, the anterior ethmoid is going to be in a mesentery. Now, there is going to be some piece of bone between the skull base and the artery. If you are confident of clearing that, then you should. But if you're not, then leaving that ridge of bone is not going to alter your disease or your surgery in any way whatsoever. You might as well just leave it behind and rather not try to put a probe behind the anterior ethmoid artery or so. But if the anterior ethmoid artery is exposed, then you have to make note of this. Why? Because when the patient comes for a cleaning of the sinus in the post-operative period, if you're using a curved sucker and your sucker goes behind the anterior ethmoid and you pull it, the artery is going to get ruptured in the and this is going to happen in the OPD. So you have to make note that you've actually exposed the anterior ethmoid artery, and that has to be probably in like bold letters on the file or something. You have to write it so that when you're because in my OPD I don't do the cleaning. My colleagues do the cleaning, so they have to be aware of this fact that if you have exposed it.
Actually, there is some different practice, but thing is that you should clear-cut idea regarding the landmark. You may exposed or not, but you should clear-cut idea regarding the position of the anterior ethmoid artery especially. And another important thing is added by the Gaurav, that if we deliberately or accidentally expose the anterior ethmoid artery or other ethmoid artery, you should always mention this in your note. So anybody in follow-up interfered for suction or other things, he will be more care about the injury of the external artery. It is very much important. Our second question is, during functional endoscopic sinus surgery, anterior posterior ethmoidal artery injured and goes to orbital cavity, then how to ligate this through medial canthus approach? Injury to the anterior posterior ethmoidal artery is not uncommon in our endoscopic surgery. And it can manage by various approaches. But questioner specifically wants to know how to ligate this through the medial canthus approach?
Actually, if we do the surgery carefully, know the landmark, usually injury is not common. Posterior ethmoid artery is very uncommon, and as it is thick within the bone, it is very, very unusual to do injury in the posterior ethmoid artery. But anterior ethmoid artery can be injured in some cases. In that case, in maximum cases, only packing is enough. Or if we can identify, cautery may be done. If it goes within the orbit, and how much bleeding occurs, it depends on that. And if it is peroperative case, we can see that there is swelling of the orbit, gradual swelling of the orbit. In some cases, very progressive, rapidly progressing swelling may occur. In that case, we very simply we can manage it by removing the lamina papyracea, incising the periorbita, and in some cases maybe we have to remove some fats to remove the intraorbital, to release intraorbital pressure.
Endoscopically
and peroperatively. And endoscopically it is better and easier than the medial canthus approach. And because everything is in front of our eyes, in front of our vision, so we have not to go to by another way, doing another approach, doing another injury or incision in the medial canthal region. It is not practiced, I think, by the endoscopic surgeons. So that is the better way and easier way to approach, not by medial canthus approach. I don't know what is.
Totally agree with Bahur sir. Basically, how to ligate? Ligate, no way, not possible. If injured, if you want to ligate, then mid portion is the best, not laterally, not medially. And if any injury, then orbital decomposition is the best way. And we are ENT surgeon, not habituated to do the lateral canthotomy, basically. I think medial canthotomy or lateral canthotomy.
Which you prefer, medial or lateral?
Lateral canthotomy is the more preferable and easy way. So, but we are not doing regularly. If you want to involve the eye surgeon, then definitely lateral canthotomy. But we are the endoscopic surgeon, so for endoscopic surgeon, orbital decomposition is the most easiest way. Simple.
If it is a complication develop at the first postoperative days, how will you manage this? Lateral canthotomy or endoscopically?
So if the patient is still admitted in the hospital and you find that when you're doing rounds, patient's eye is swelling or the vision is coming down, then you have to suspect that there has been a bleed and it has gone intraorbital. First thing that you need to do is you'll have to put some pressure on the eye and do a gentle massage, because you don't want to allow the blood to collect inside the orbit. You would rather push that blood outside into the nasal cavity. That's the first
How much
thing.
long?
This is just until you can do a lateral canthotomy. Okay, so the easiest step to do is a lateral canthotomy, because if we are talking about a medial canthus approach, then this has to be done by a ophthalmologist. It is not something that we do, because you have to go a transconjunctival approach, and mind you that the vessel has actually already retracted into the periorbita. So when you do a transconjunctival approach, we actually land up outside the periorbita. That is, you are along the inside the lamina papyracea but outside the periorbita. So you're in that junction. If you look at it, like what sir was saying, is that it is easier to remove the lamina papyracea endoscopically for us. We can do it immediately rather than wait for an ophthalmologist to come and do it. So that doesn't give us any technical advantage over what we already have. But even the oculoplastic surgeons that I have worked with, they do not prefer to do a medial canthus approach when you have an anterior ethmoid bleed or a posterior ethmoid bleed, because you have to go intraconal. That means you have to cross the periorbita and go inside the orbit that is next to the medial rectus muscle, or even medial to the lateral to the medial rectus muscle, and you have to search for the vessel and then you have to ligate it. There is no genuine sense in doing that, because this is a very tiny branch of the internal carotid branch, which is the ophthalmic artery. Patient is not going to die because of it, but the problem is that the patient can lose vision. So if you can manage to reduce the intraocular pressure by any other method, then it is good enough. So you can do, if it is in the ward, you can do a lateral canthotomy first. because you will not have access to do a medial orbital decompression there. So put pressure gently and press and document that you have informed the ophthalmologist. Whether they come, don't come, or whether you need their help, don't need their help, that is secondary. But if the patient loses vision and this case goes to court, then the judge or the opposition lawyer is always going to question you, why did you not involve an ophthalmologist right from the beginning? And that amounts to criminal negligence on your part. So just document that you've informed the ophthalmologist and you would want their help. Okay. Then put pressure and put some massage. You can even give a tablet or a IV dose of acetazolamide, because that will reduce the intraocular pressure, and inform the OT that you would like to shift the patient. This is if it is happening in the ward. And if you can do a lateral canthotomy in the ward itself, just give local infiltration in the upper and lower eyelid. Make with a 15 number blade, make a horizontal incision. When you lift with the forceps, you will see the inferior canthal tendon. Snip it. That will give you about 15 mm of Hg of pressure release. Okay, so because the canthal tendon is released, the eyeball can actually come little more anteriorly now. Now, beyond this, you cannot do anything in the ward. Okay, if still you are seeing that the pupillary reflex is sluggish, then you need to shift the patient to OT and do a medial orbital decompression. But only with the lateral canthotomy, if the pupillary reflex is becoming better, then you don't need to do anything further. Okay, but knowing me, I do not want to sit with the patient and check the pressure every hour or so. So I would rather just shift the patient to OT, do a medial orbital decompression and drain out all the blood. That is probably what I would do if I was having this problem in the ward. Now if you are having this problem in the OT, then there is no need to go and do a lateral canthotomy. You can straight away do a medial orbital decompression because you're already there, and cut the periorbita, release the blood, finished.
You self do the medial canthotomy or by the help of the ophthalmologist? Lateral
canthotomy?
No, medial.
Medial canthotomy I don't do. Because I've never had to do it. To be very frank, I've never had to do it. I've had anterethmoid bleeds because we have tumors which go 360 degree around the anterethmoid artery. They would have eaten the whole of the skull base and they would be rotating encircling the anterethmoid 360 degrees. So when we remove, sometimes it does bleed and retract. But I've never had to do a medial canthotomy. I've done a lateral canthotomy on my own.
Actually, medial canthotomy is of no use here, I think. Number one. And number two, when the patient is in the ward, post-operative ward or in the cabin, in that case, if PAC is there, first of all, we have to remove the PAC.
Okay, hope the questioner got the answer. Actually, medial canthotomy is not in our practice. It is done by ophthalmologist, but we can manage perioperatively easily with our experience endoscopically. And if it is post-operative day, lateral canthotomy is easier for us. Our next question is how to identify and ligate the sphenoid palatine artery. Dr. Sir?
Could have also mentioned during surgery, but my opinion to junior is very simple way. If you extend posterior, goes to the ostium, maxillary ostia, and go to the posteriorly, and just identify the inferior turbinate end and middle turbinate attachment, that portion just L separated or in orthochondra kedri, just U separated, you just create the space and you will see the sphenopalatine artery.
I think Dr. Gaurav has shown beautifully how to identify the sphenopalatine artery. And I want to add something to Dr. Tushar's comment. That is, when we give the incision, as Gaurav has shown, and we elevate the mucosa or mucopericardium in one place, we will find the ethmoidal crest. That is very important landmark. And another thing is, when the artery comes, the flap will not be elevated. There will be some restriction. There is some restriction. Then that is the indication that I have reached the artery. And of course, the lacrimal crest is a very important landmark. Thank you.
Tomorrow there is the opportunity. It observed the cadaver dissection, which will be performed by Gaurav from Sorardi Medical College. Then we got the opportunity to clear our any kind of confusion.
Yeah, I'll demonstrate. You can probably also remind me tomorrow. I will definitely show all the branches of the sphenopalatine artery, and also when we expose the pterygopalatine fossa, we will also see how from the IMAX through the pterygomaxillary fissure the artery becomes the sphenopalatine artery, at what junction it becomes, and everything. We'll discuss this in detail. Actually, this is a very important procedure because especially in summer we get a lot of patients who have intractable epistaxis, and if their hemoglobin is dropping significantly in spite of us doing cautery or whatever along the littles area, then this becomes a sort of a escalated procedure for those patients. So it's important we know this. I will discuss this surely, sir.
Actually, sphenoid artery is the main branch of the supply of the mucus of the nose, and it is the important cause of torrential epistaxis. So, as an ENT specialist,
artery of epistaxis.
Artery of epistaxis. So as an ENT specialist, we should have an idea to manage such kind of problem by ligation of the sphenoid artery. And everybody like to request to observe the cadaver dissection from tomorrow evening from Surwardi Medical College, which will be arranged by the team of Professor Dr. Shahjahan Kabir. Our next question is gross question from a questioner. How to approach sphenoidal sinus? Babu sir.
Yes, there are three approaches to sphenoidal sinus. One is medial approach, one is median approach, and another is lateral approach. Median approach is transseptal approach, midline approach. We rhinologists usually don't follow this approach. And then is medial approach through the natural ostium. We know the landmark of the sphenoid sinus, and I mentioned in the morning that in one workshop I demonstrated endoscopic pituitary surgery, and some people are asking me why you don't sacrifice the posterior part of the middle turbinate. I told that we are the rhinologists. We usually don't like to sacrifice middle turbinate. We go directly to the sphenoidal ostium, punch around the ostium, we widen the ostium, and go into the sphenoid sinus to identify the pituitary ciliatus. And another approach is lateral approach. That is the trans-ethmoidal approach. Usually we do it when we go for surgery for sinusitis or polyps like this. But during pituitary, we do usually medial approach, but median approach may be done as well.
Okay, this is a basic question. Dr. Shah.
All knows basically to open the sphenoid sinus. For junior, just one point I want to add. If transethmoid, definitely you know, but I always prefer for juniors, just identify the superior turbinate, just medial to the superior turbinate, just natural ostium is there, and just open the natural ostium and put the one just neuropathy and corroborate from the inframedial aspect of this transethmoid and to open the otherwise there is a chance of injury if you are not so expert. So simple way for juniors, and learning curve is very less. Just open the natural ostium, then corroborate the towards through ethmoid. So it will be easy to, if scope is there, I will show how it is simple to open the sphenoid sinus.
In the next session and today and tomorrow, we got the opportunity to observe the live surgery by our expert panelist, and at the time we can got opportunity to clear the our explanation regarding the confusion. Our next question is, what are the pre-operative preparation for a patient of endoscopic sinus surgery, and do you prefer any treatment before doing any CT scan, MRI? Dr. Tushar? The basic question.
Basic question, but sometimes some tricks is there. Always, if you treat the CT scan, always we do straight the CT scan. Sometimes my junior, sir, it is a simple case of maxillary entrant polyp doing, but do endoscopy. And if you think that is the different way and different, sometimes fibrotic is there, then require definitely MRI. Sometimes MRI also required. Definitely during before phase we do routinely CT scan, but do endoscopy, not we treat the CT scan only. Do endoscopy, and if you think there is slight bit abnormality and some fibrotic, maybe angiography, maybe tumor, so at that case definitely you should do MRI also. Definitely Gaurav will ultimate.
Gaurav, what is the basic protocol in your center as a preparation of the patient before doing to any endoscopy surgery?
So if I see that the patient has got polyps on my endoscopy, I don't really bother to now do give the patient steroid and reduce it and then do a CT scan. I don't really bother to do that. The reason being that a lot of my patients, because I live in Bangalore and we have a huge IT based population. So if most of our patients have insurance. So if after giving steroids, if the disease is not there or not much, then the disease gets understaged and the insurance will not come through. So they will say you don't need surgery for this sort of a case. But in reality, if you understand the pathology that is happening here, the polyps have gone, but this is only temporary. This patient has got an inherent inflammatory sinus disease. When you take him off steroids or after about a month or two, these polyps are going to come back. So have you really done justice to the patient? No, not really. So if you want to identify, if you have got a really bad sinus where you're not able to understand the anatomy at all and you want to shrink the polyps and then do the scan, just for the sake of understanding anatomy better, then definitely you can prepare the patient. But I, as a rule, now I don't give steroids for two reasons. One is, I don't want to understage the disease. That is first thing. Second thing is, I do a biopsy intraoperatively of the polyp because I want to strategize as to what is going to be the prognosis of this patient. If the patient has got high number of eosinophils per high power field, which is usually more than 10 per high power field, then the patient has got a poor prognosis in terms of recurrence. So this is how I strategize, prognosticate my patient. So I don't give steroids now anymore before preparing or whatever. But after doing the scan, if I see that the patient has got significant osteitis and lot of disease, then yeah, I will give the patient some amount of steroids to reduce intraoperative bleeding. But having said that, today's case also you saw that there was so much osteitis on the scan, but we did not have troublesome bleeding. It was not like, okay, I'm going to stop here and I'm going to stop the case. That is not the amount of bleeding that I had today. So you can actually, if you can use some intraoperative tricks, you can still manage and go ahead even without steroid, I would say.
Very smart answer by Gaurav. Protocol is not only depends on the patient, also depend by the insurance policy.
Thank you, sir. Thank you for your nice session, other. But I think for the students and other, you should prepare the patient. You should give the steroid for a course and no need of your income tax or other. And you should go for at least one CT scan. Otherwise, you are an expert. Without seeing, you can do it. But patient should be prepared. Thank you, sir.
Thank you, sir.
We know that if you shrink the polyp by using pre-op steroid, either topically or systematically, is there any chance of reducing bleeding during surgery, especially in case of recurrent cases where there is too much fibrosis, there is a chance of more bleeding. If you use pre-op steroid, either topical and systemic, the polyp regresses, then I think the chance of bleeding is less. Do you agree with me or not?
Actually, Professor Dharabdar sir and Kobir sir already said, it is our practice to prepare the patient for visualization, proper visualization, and actually for control the bleeding, and for the beginner and basic surgeon. Your advanced surgeon, it is possible for you, but in our practice, we always prepare the patient.
If the insurance covers, we will have to do the same practice like him. No insurance coverage for the patient.
You agree with our senior professors? Now, you are a special protocol for your patient.
Sometimes I actually practice sometimes if there is minimum polyposis, but symptoms of allergic rhinitis there. During endoscopy, I see some minimal polyps there. I usually give conservative treatment for long time, at least 6 weeks before doing CT scan. And in some of the cases of early polyposis, we see the significant reduction of the polyps there. So in that case, we can continue the conservative treatment. By this way, we can avoid some number of surgeries.
Yes, in case of early polyposis, especially in ethmoidal and middle trabinate, early polyposis, there is a chance of significant control of the disease if you give steroid. Steroid and long-term antihistamine. It is written in the book and literature as well. Oral and topical long-term antihistamine.
It is important, already explained by Babur sir. Conservative treatment not only essential for preparation of the patient, and also it is practicing before imaging also. It is also important.
কবির ভাইকে এটা জিজ্ঞেস করতে চাচ্ছিলাম যে আপনি এর সাথে কি কোনো অ্যান্টিফাঙ্গাল ইউজ করেন কিনা?
Secretion. There is a sticky secretion, and clinically, if you think that there is maybe fungal polyposis or there is maybe eosinophilic polyposis, fungal mucin. If you clinically suspect that, you can try antifungal as well, systemic antifungal, but not routine. It is used on clinical basis.
Okay, our time is short. Our next question is, when we will do functional endoscopic sinus surgery in case of rhinosinusitis without polyposis? And Dr. Gaurav, you practice when you
we do get a lot of cases. So if the patient actually qualifies for the definition of chronic rhinosinusitis, like if the patient has had the problem for more than a year, and if the SNOT 22 score is more than 44, then we would take the patient up for surgery. Because if a score of more than 44 means the patient has got a moderate to severe disease. Whether you find polyps or don't find polyps, the patient has some amount of inflammation. It could even be bacterial also. Or the patient might be having a biofilm inside of the sinus which is not able to reach with a douche. So what here, the role of medical management becomes more important than if you have polyps. See, polyps is a genetic disorder. So there is some level of inherent mucosal inflammation.
Without polyp, when you interfere the rhinosinusitis?
When we would operate. Like I said, if the patient has had the problem for more than a year, and if the SNOT 22 is more than 44, that clearly indicates that the patient is not going to improve. And if the patient has taken clarithromycin for about 15 to 20 days or 3 weeks, then I think if he has failed all of this.
Or recurrent acute attack.
Acute attack, I would not want to operate. Acute attack is something.
Recurrent history of recurrent acute attack.
That is called as recurrent acute rhinosinusitis. Yes. That is a different entity. So what is the? I'll just clarify one point. What is the difference between RARS, that is recurrent acute rhinosinusitis, and CRS, that is chronic rhinosinusitis? In recurrent acute rhinosinusitis, what happens is that in between 2 episodes, the patient's symptom score will come down to 0. So if this is happening, then it is a case of RARS. So in RARS, there is no role for extensive surgery. You might want to do whatever is the trigger, like there might be a concha bullosa blocking the maxillary ostium, or there might be a gross septal spur which is blocking the ostium. That thing you can correct and then come out. That's pretty much what you're required to do. But in a patient who's got chronic rhinosinusitis, where the symptoms don't come down to 0 between 2 episodes, then there is role for extensive surgery like a full house fess or an anterior fess or whatever we would like to call it. That becomes an indication.
Thank you. There is a last question. If a patient of bilateral ethmoidal polyp involving medial aspect of the middle trabinate with confluence of anosmia, what should be the position of the middle trabinate after removal of polyp? I mean, what should I do? Medialization of middle trabinate or lateralization of the middle trabinate? Polyp is situated at the middle of the middle trabinate bilaterally and with anosmia. After polypectomy, what is the position of the middle trabinate? Is it lateralized or medialized? Gaurav?
I would always like to leave it medialized. So the anosmia is not because of the position of the middle turbinate. It's because of the fact that there is inflammation in the olfactory recess. In fact, almost every case that I do, I actually put a middle turbinate suture to actually widen that the sinonasal corridor. We have to understand one thing, that the whole surgery is being done because you want to have a widely open sinus corridor. If you actually lateralize the middle turbinate after doing it, then the whole purpose of surgery itself gets defeated. Because you are closing off the sinonasal corridor, and when the patient washes with steroid, it's not going to go inside the sinus. So I usually put a stitch between the middle turbinate and septum, go through the opposite middle turbinate, and I stitch the two middle turbinates medially. I always do a SNOT 22 before and after surgery in all my patients, and actually the SNOT 22 gets sent. I have a software where we send the SNOT 22 every couple of months, and we get the values and we get a graph also. I have not had a patient complain of anosmia because I have medialized the middle turbinate in any of our cases actually. We have data to prove this also. So the smell receptors are actually quite good, and whatever chemicals which are going in, they are microscopic. So I don't think unless you have created complete cicatrization of the middle turbinate with the septum. So there is a technique which is called as Bolgerization. I don't like that technique personally because you're creating raw surface area in the olfactory recess. So that is not a healthy thing to do because you're damaging the olfactory receptors there. Rather, you leave the two mucosal surfaces intact and put a stitch. That is a much better way of medializing the middle turbinate.
Experience development side
Between middle turbinate and lateral wall? Yeah, we've had, especially when we are doing tumor surgeries and we have to drill extensive amounts of bone, you can have, but it's not a very big deal. When the patient comes back for follow-up, you just release it.
Okay.
Just one point. Add one point.
Yes.
Actually, the endoscopic picture we see, there is a concha bullosa, and for concha bullosa we remove the lateral segment, lateral lamina of that concha, because we have to give air space in the osteometal complex, and if polyp is, whether polyp is in the medial to the middle turbinate or lateral to the middle turbinate, the aim is to remove the polyp. Actually, if olfaction, hyposmia or anosmia if occurs due to polyposis, we have to remove the polyp. It is not the factor whether the middle turbinate is laterally placed or medially placed. But in practice, we usually, as Gaurav said, we place it medially and we give our pack or splint lateral to the middle turbinate.
Just one point I would add. Definitely we prefer main failure of the face surgery is the lateralization of the middle turbinate. So we want to medialize the middle turbinate. That is the main. But bulgarization, yes, you may do the bulgarization. Stitching sometimes difficult. Lower part of the middle turbinate, if you attach, then air will be there. Sir mentioned the cicatrization. When all full middle turbinate will be adhesive type, then is the problem. Otherwise, lower part, if you attached with the septum, there is no problem at all. If you bulgarize the lower part of the middle turbinate.
Yes. You use any splint, and what is the position will be the splint? There is another question. After removal of the polyp tissue, we plan to keep splint. What should be the location of splint? It is means lateral to the medial turbinate or medial?
Now this is the silastic seat. If you definitely lateral, and also the one stent is there. Smith and Nephew, one stent is there. That is also fantastic. If you if you put that area osteometer complex area, then it will maintain the middle turbinate position. Yes, and also stent. But there is the I think it is the too tough silastic one stent is there. I am using that is also is very smooth and good. Yes, and also place the proper position.
Another question is recurrence nasal polyp. During follow-up of the endoscopy after endoscopic surgery in ethmoidal polyp, if we found early recurrence of polyp, what our plan of management? Gaurav, how we manage the recurrent?
So in this case, if you have already done a proper full house fest, that is all the bone work is complete, and this is only a soft tissue swelling, then you don't have to worry. You have three options. One is you can either give the patient some oral steroids, this will disappear on its own. Second thing is either you can just excise this polyp and take it out. It's just put some 10% local anesthetic spray, and you can just do this in the OPD itself. Third option is you can just take one ampule of dexamethasone and inject it into this polyp. So these are the three options that you have. When you inject it, it will just regress on its own.
How much times it is injected?
Sorry?
How much times?
Injection. Just 1 or 2 sittings, that's more than sufficient. One sitting is actually enough. It will completely regress. If you inject it into the polyp, it will regress.
Actually, what is the routine protocol post-operative follow-up the patient?
So the first time that I see the patient after surgery will be after 1 week. The reason that I see them after 1 week is that even though they are doing the douching, in my hospital, what happens is patient starts douching the same day of surgery. Like morning if I've operated, evening they start doing the douching. So that way what happens is you're not allowing a lot of clots or mucus to get collected. Because once it gets collected, it becomes hard. And when it becomes hard, it becomes more difficult for them to clear it out.
And so you don't use pack actually?
I don't use pack.
So douching started from the beginning?
Day one. Day one I start douching. So you saw the surgery which we did. We didn't have any bleeding there. Why do you want to pack a patient? Because when you pack a patient, there is evidence now. There has been meta-analysis also which has proven that it causes pulmonary hypertension for the patient. That will make him bleed more when you remove the pack. So you can be honest and you just go recollect when you have removed the pack. I'm very sure that most of us would have experienced bleeding. It is just mental satisfaction that okay, well, I'll go home and I'll sleep comfortably. Nothing of that sort happens. It's all bullshit. Because when you remove the pack the next day, he will bleed. Because all that piled up blood will definitely come out. And let me tell you, especially if you are operating on a patient who is CRS without polyps and he's got bad bacterial infection, you don't want to pack. The basic of general surgery is that when you have an abscess, are you going to pack it? If you're packing, you will put a betadine pack. But otherwise, you would want to leave it open. You want it to drain. You want air to go in and sanitize that space. So at least I wouldn't want to pack. Even in skull-based surgery, I don't pack. After doing a JNA, I don't pack now.
In case of recurrent polyposis, there is more chance definitely in comparison with fresh case. In that case, do you avoid any packing?
So if you observed, sir, today's case, if you have removed all this osteotic bone, then the chance of you having bleeding itself will come down. If you leave behind osteotic bone, that will bleed. Why? Because inside of the bone, we have these Haversian canals. So that bleeding will not stop. So the bony Haversian canals, what we did, what was the whole fund of using the drill today was, when you drill out that bone, you're closing off all those Haversian canals. So you're not going to have bleeding to begin with. If you want, we can try this out. I'm here tomorrow also. We'll not pack today's case. And we'll see what happens tomorrow. Only thing is, you will have mucosal bleed. If there is no compromise for you leaving an open artery and saying, I'm going to pack and come out. Because tomorrow when you remove the pack, that artery is going to bleed again. So you have to make sure that you've got good hemostasis and not pack the patient. That's pretty much it. There's been probably only one case in my life when I packed. That is because the patient had very bad hypertension which was not coming under control. So that is the only case where I have packed. Otherwise, I have not packed so far.
I agree. I agree totally with Gaurav. We also follow if only polyp, but sometimes we routinely, doing the septoplasty with polyp, doing the terminoplasty with polyp, then pack required. And our hospital protocol is the after 2 days the removal of pack and dosing started. If pack is there.
What is the posterior nasal douching actually? It is very important for
it's very important. The namaz position is the best position, but it's not possible, every time. So my explanation to the patient, just target towards eye. This is easy and just bend and try to. But otherwise, if you want to proper douching, the namaz position is the best way. But namaz position is very difficult for me also, no. So
for the preparation of
preparation is now the mixed preparation is available in India. Sodium bicarbonate. You mentioned there was the boric, but I don't know the boric acid available. Maybe, but in our India nowadays, lot of preparation is ready with nasal douching powder is available with sodium bicarbonate.
Now, sir, what is the
we usually practice only normal saline douching. I think that is sufficient. That is enough. Not to make it complicated. But somebody practices somebody practices adding steroid, adding antibiotic like neobacrine, Nebanol ointment like this. I find that normal saline douching is, if properly done,
How many days continue?
at least 1 month.
1 month.
At least 1 month.
And regarding steroid use?
Yeah, budesonide use basically 2 cc normal, 200 cc normal saline and with 1 respule budesonide. And if you may patients continue, if allergic component is there, otherwise sometimes problem after 1 month is not sufficient. Some patients it may continue 6 months, 1 year. When disease progresses subside, up to this maybe continue to prevent the recurrence of the polyposis.
Dr. Tushar,
Actually,
after finishing surgery,
sir,
how many days after surgery you will start topical steroid? Operation শেষ করার অপারেশনের পরে কতদিন পরে you will start topical steroid?
Basically after bag removal on 3rd day, intranasal corticosteroid started. Spray. Wash, douching, everything.
We start 3 to 4 weeks after surgery, after healing. I think if you use immediately after steroid, I think healing may be delayed.
Not immunity, but in case of polyposis, there is the another from another surgery. So the different protocol, different allergic, different system.
Gaurav?
So for me, spray I don't use a lot, especially after surgery. The reason being, see, whatever practice that I'm doing, it's all evidence based, unfortunately, because I have to actually write, as per NABH guidelines, we have to have SOPs, that is standard operating procedures, and these SOPs have to be backed by evidence. The problem with a spray is that it can only go in one direction. You cannot expect a spray to curve or, so you have maxillary sinuses are on this side. So when you're spraying in the nasal cavity, it will not reach the maxillary sinus. Frontal sinus is here. It cannot bend and go like this. That is the reason why we use 70-degree scope, curved, punch, curved debrider, all these things. Because so if you look at it, even, and this is not just logic. They have actually done studies where they've used nasal spray. They put a dye with the spray, and they've actually in a cadaver sprayed and checked what is the deposition. The problem with the spray is that 90% of the drug gets deposited in the anterior part of the nose, even anterior to the middle turbinate. 90% drug deposition happens here. That is the space where you don't need any nasal spray to get deposited. So what are you doing? You are allowing bleeding to happen, because with that spray you're causing mucosal atrophy. When you cause mucosal atrophy in the littles area, the blood vessels will become more superficial, and whenever the patient has raised blood pressure or dryness in that area, it's going to bleed. So you are not really doing any benefit to the patient by giving the patient nasal spray. The whole point of us doing surgery was that you make the patient douche. The other problem with the nasal spray is that spray can only reduce inflammation. It cannot clear out debris for you. Okay. Now a patient who's got allergic rhinitis like this patient, you want to flush out that thick mucus that he had. You want to flush out all the dust, pollen, dog hair, cat hair, or ragweed pollen, whatever he had, you want to flush it out, because that is what is instigating your reaction. So one is spray cannot bend and go inside the sinus. 2, it cannot remove all these debris that is there. So I would always prefer to do a sinus rinsing rather than do only a spray. When do I reserve spray for? So the first 15-20 days of after surgery, my patient is on a rigorous washing spree. Literally 2 times a day they have to wash, and 2 times a day they do head low position wash also. Sorry?
Antihistamine?
No, I don't prescribe long-term antihistamines, because there is absolutely no benefit of giving it, because if a patient is getting surgery done, he's already in phase 2 of the allergic reaction. Antihistamine is not going to benefit. But when do I give antihistamine? I do give antihistamine, but it's not for 6 months. The plan of giving antihistamine is, suppose, let us say he's got pollen allergy. And in the pollen season, which is now, in summer, that is when the trees are all blooming, there's going to be a lot of pollen in the environment. That time I can put him on prophylactic antihistamine, because you don't want the reaction to happen itself. But that doesn't mean he's going to stop washing. What happens with time, after about 3 weeks of doing twice a day washing, I drop it to once a day, then I make it once in 2 days, then it depends on the pathology of the patient. Like if the eosinophil count in the histopathology of the polyp is extremely high, like 50, 60, 100 cells per high power field, then you know for a fact that this patient's tissue is infiltrated with so many eosinophils that even small amount of dust or pollen will trigger the reaction. So his washing has to be much more than if you take a patient who's got 5 eosinophils. You know that he's not going to have such a bad reaction, so he can wash maybe once a week. So the prognostication, that is why taking the biopsy is so important. That is why I don't give steroids before surgery, because I want a good biopsy. If the problem is genetic, he has to continue for a lifetime. Probiotic, I would agree, there is a very, very big role of probiotic. But
any immunotherapy, any flu shot.
Yes,
because
I agree. So these things
routinely, yearly, they should use the flu shot.
Absolutely.
They use the probiotic.
Absolutely. These are things which I would agree with. But see, when you are giving an antihistamine, you want to give for 6 months or even for a lifetime if you are considering giving antihistamine, are you really doing justice to the patient? Because if the patient has got other issues, like for example urticaria, or if he's got asthma, then you don't have a choice. You have to give.
Say in India, there is a combined drug, both the Montelukast and antihistamine.
Yeah,
and some of your prescribing is the years together. It's a combined drug. Patient
So
is feeling better.
I don't give Montelukast so often. So the clear-cut indication when you want to give Montelukast is if the patient has got lung involvement. In the upper airway, Montelukast will not do a lot of benefit to you. It can at the most reduce minimal amount of inflammation, but the receptors, leukotriene receptors, are maximally located in the lower airway, not in the upper airway. So if you are putting Montelukast with antihistamine for a upper airway issue, then you are not doing justice to the patient. And now Montelukast, there has been evidence that it causes psychological disturbance also. That is a black label warning by the FDA. So I wouldn't want to definitely prescribe Montelukast unless the patient has got lower airway involvement, and that has to come from a pulmonologist. So in my hospital, I have a pulmonologist just sitting next to my office. So if the patient requires Montelukast, I would definitely tell the pulmonologist to prescribe it. I don't want to be involved if the patient develops depression, suicidal tendency. I don't want to be the one.
Chinese are even using the spring water nasal spray routinely. They have done for nasal dosing and clearing.
Yeah.
Every day before sleep, spring water.
So I have read that
and
paper.
Steam inhalation at bedtime.
Steam inhalation somehow, so there has not been any evidence to prove that steam inhalation works. In fact, they have found that it can be counterproductive. So let us imagine that you have an injury on your knee and it's already inflamed. Are you going to put more steam on it to make it worse? You're not going to do that. Steam inhalation, in fact, if the temperature is very high, it can kill the microflora inside of your sinus. The whole idea of spring water, I agree with that. Why? Because spring water contains a lot of healthy bacteria. So that is the reason why they want you to do spring water douching. Probiotics, again, now there is evidence that if you take probiotics for 3 months, then the IgE value in your blood will actually come down. The inflammatory process in your sinuses will come down. There is proper evidence. In fact, this was my thesis research. We even did a study on this where we did a probiotic. We took 2 separate Petri dishes. We harvested nasal epithelial cells. And in one dish, we added pneumococcus 23. And in the other, we added probiotic, that is lactobacillus, with pneumococcus 23. So for a patient to develop an upper respiratory tract infection, the first process by pneumococcus is called internalization. That is, it has to make a break in the cell membrane and then internalize itself. What we found is that in the Petri dish which had probiotics, it prevented internalization itself. So the chance of patient developing URTI becomes very less. But that was a phase 1 clinical trial. Of course, it's going to take us many years to get approval for patients to wash with probiotics, but definitely that is going to be the future. Now we have so much evidence, even cognitive development is linked to probiotics. So if you give your children, small children, probiotics and flavonoids, that has shown to really boost their cognitive development. If you have observed, now we have lot of cases of autism. At least in India, we have lot of cases of autism. Why do you think that is happening? So what probiotics our parents or grandparents had, we have probably 10-20% of that diversity. So with each generation, this diversity will keep coming down because of the rampant use of antibiotics. That is one, if you want to take one point from today's or the whole workshop, it is this. Don't hesitate to take a nasal swab and then decide if you want to give antibiotic or not. That sinus infection is not going to kill the patient. Okay, but what you're doing unknowingly is that you're killing all the gut bacteria and making it worse for the patient in the long run. When you take away the balance between TH1 and TH2, okay, so what is TH1, TH2 in the thymus? From the bone marrow, the cells go to the thymus and there they are categorized into two groups. TH1, which is going to fight your infections for you, TH2, which is going to cause allergy and autoimmune conditions. So if you take down all the TH1 cells, then the TH2 is going to increase. That is why we have so many patients with allergy, so many patients with asthma, so many patients with autism. Yes, immunotherapy works, but the problem with immunotherapy is their immune system is set up a certain way for the last 20, 30, 40 years. So to change that, immunotherapy will take at least 3 to 5 years. And the long-standing effects of immunotherapy, we don't know. The reason being that compliance is a problem here. Okay, so what happens in immunotherapy is whatever the patient is allergic to, dust, pollen or whatever, you give the same thing in a lower dose. And very slowly you increase the dose.
Thank you, Dr. Godop. Though we are using antibiotic and antacid and montelukast regularly, including our pulmonologist, but we should, this is the time to think the side effect of this according to the opinion of the Godop. And we actually, we are regular, sir.
So that biopsy becomes very important there. If the fungus is outside of the mucosa, okay, that could be saprophytic or that could be allergic. There is no role for systemic antifungal because it has not penetrated your sinus. If I take a swab from your sinus also, we will find fungus because it's ubiquitous. You cannot escape fungus. But if the fungus is inside the mucous membrane or if there is angio invasion or neuro invasion, yes, definitely I will give antifungal.
Thank you, sir. We usually practice sometimes turbinectomy, cauterization of the turbinate, and the view of control of allergic rhinitis. There is any role of this? What is your practice?
No, but all allergy rhinitis not a routinely we are doing, but in case of polyp surgery, during polyp surgery we do if nasal obstruction due to DNS and correct DNS and turbinate is hypertrophied, definitely we not cauterize turbinoplasty with microdebrider. We always prefer. And also one slide not mentioned, skin prick test and immunotherapy also we are doing routinely in case of allergic polyposis.
You don't practice cautery?
Not cautery. Last 15 years and I'm not doing cautery.
If the turbinates are hypertrophied and it prevents medication to go inside, in that cases some sort of turbinate reduction may be done, but not the surface cautery. It can be done by submucosal coblation, by coblation probe, or any type of turbinate reduction by submucosal probing, or by, as he has said, by microdebrider. We can reduce the turbinate to make approach for breathing and drug to reach the nasal cavity.
Thank you, sir. There is a lots of question in our question bank, but due to short of time, I have to escape the most of the question. Our last question is, what are the main obstacles to become good endoscopy surgeon in developing countries? This is an interesting question. In developing countries, we have to work at lots of limitation regarding important logistics support and update logistics support and financial consistency. Though we are working well overcoming this problem, and I'd like to request Babur sir as a endoscopic renowned endoscopic surgeon in our country.
There are
what
many,
is the limitation?
Yes, there are many obstacles there. Actually, I have faced some problems, and I can say these things. Number one, instrumental facilities. Number two, training facilities. Number two, posting and transfer of government doctors. And number four, doctors who are posted in private medical college, they are thinking, the medical college authority is thinking about their business sides as well. and everybody is not as potential as like Professor Ashraf. He could manage everything in a private medical college. So you can give a clap for Professor Ashraf as well. And these are the things.
What was the logistic support? My God, this is the main obstacle in every medical college.
I told about the instrumental support, the logistic support as well.
This is the main thing.
And even in
training of the trainers and training.
Training and trainers, yes. Even in government medical colleges, in every medical there is no dead body morgue facilities. So even in BSMMU, we had for very short time we have a cadaver facilities, maybe 6 months or like that. And Dhaka Medical College, they have huge supply of
in our country, the office time is main.
At office time, yes, it should be.
There is no CMA credit for the students, whether they train, but it should be.
ঢাকা মেডিকেল কলেজে কেন রুমি এখানে আছে কয়টা দিতে পারছে ওরা কয়টা বাড়িতে পারছে যেটি আমলেস আর ডেডিকেশন যার ডেডিকেশন হি উইল ডেভেলপ হিমসেলফ ইট ইজ ভেরি ভেরি ইম্পর্টেন্ট ডেডিকেশন থাকলে কোনো না কোনো দিন শিল বি গুড সার্জন বাবর যে এন্ডোস্কোপিক সাইনাস সার্জারি তোমার কয়টা ট্যাবলেট দিয়ে শুরু করছিল কয়টা করছিল ইউ হ্যাভ গট ট্রিমেন্ডাস ডেডিকেশন টু দিস সাবজেক্ট দিস ইজ ওয়াই ইউ কেম আপ unless because it is a long learning curve. Endoscopic sinus surgery, complicated structure, nasal structure, complicated sinus structure, lot of anatomical variation. Unless and until you know the proper anatomy, including variation, and also the dedication to the subjects. এখানে আমরা যারা আছি, those who completed postgraduate, প্রত্যেকেই কিন্তু endoscopic sinus surgeon, endoscopic sinus surgery, but this is not. And until you develop dedication, you have no devotion to the subject, you will never be a good surgeon to that particular topic. It I mean bolte chai dedication
dedication আমাকে এগ্রি বলি ইন শর্ট আমি ঠিক অপোজিট বলছি হোয়াট আর দ্য মেইন অবস্টাকল আমি বলছি ফেভারে বলছি যে অবস্টাকল নেই বেসিক্যালি ডেভেলপিং কান্ট্রিতে আরো সুবিধা মানে এটা কারণ হচ্ছে অনেক বেশি পেশেন্ট রয়েছে অনেক বেশি ক্যাডাভার চান্স আছে আমার মনে হয় এখন ডেভেলপিং কান্ট্রি থেকে গুড এন্ডোস্কোপিক সার্জন ডেভেলপ করছে তো ডেভেলপ কান্ট্রি তো প্রবলেম তো ওদের স্কোপ কম হয় ওদের অনলি লজিস্টিক সাপোর্ট আছে এন্ডোস্কোপ তো এটা ব্যাপারটা সিম্পলি বলছি পাস করার পরে যদি পরের দিন আমার সময় আমার এন্ডোস্কোপ ছিল না ডিপার্টমেন্ট তখন হয়নি ডেভেলপ আমি যখন পাস করেছি তো ওটা পরে শিখতে হবে তো পাস করার পরে যদি আমি প্র্যাকটিস করতে শুরু করে দিই তাহলে কি করে ডেভেলপ করবো কিন্তু প্রচুর এনাফ স্কোপ হচ্ছে প্রচুর ট্রেনিং সেন্টার প্রচুর জায়গায় ট্রেনিং হচ্ছে এভরিডে তোর সিম্পল যখন প্রচুর স্পাইস ক্যামেরা সবসময় প্রথমেই ডেভেলপ করবে না তো আপনি একটা ভালো এন্ডোস্কোপ নিয়ে একটা ছোট ক্যামেরাও আছে সিঙ্গেল চিপ ক্যামেরা হচ্ছে আপনি যদি ভালোভাবে পরপর স্টেপ বাই স্টেপ 1 সেকেন্ড ভালো করে এন্ডোস্কোপি সেফ 20 সেকেন্ড টার্মিনাল প্রসেস স্টেপ বাই স্টেপ এবং বারবার করে ট্রেনিং নিতে থাকেন এনাফ স্কোপ আছে লট অফ ট্রেনিং সেন্টার লট অফ ক্যাটাগরি ডিসেকশন হচ্ছে এভরিওয়্যার তো কেন স্কোপ নেই আমার তো হচ্ছে উল্টোটা
থ্যাংক ইউ ডক্টর তুষার
And another thing, Dr. Zakaria, I have to mention, এখানে আমার সিনিয়ররা আছে অনেকে কেউ কিছু মনে করবেন না স্যার মাই বেস্ট টিচার ওয়াজ ইউটিউব I have learned many things. I don't know many things, but whatever I know, many of these things I have learned from YouTube. So nowadays internet, YouTube, everything is available everywhere. So I think everybody should go for internet and you will find many things in YouTube.
Thank you,
Dr. Babur, YouTube is one of the methods. But now the ample scope. There is so many training going on Bangladesh, so many in nearby country, India. So if someone is interested and they are not interested to go there for a long time, by 1 week they want to be master. You have to give time. This is the important dedication for our juniors. The people should think in this way. Otherwise they cannot develop.
Thank you, sir.
Okay, sir.
In short, any suggestion for our junior colleagues? In short.
I think you should just train and train. That's it.
Thank you very much. Thank you.
Thank you, sir. We are running very short of time. Now I would like to request to say something in short, our chairperson sirs. First of all, Shadhan.
Thank you. We have learned many management issue, different common issue in different phase. Sir.
In private, we have two instances of private service in India. These big two, they are working in private sector. So if government or private doesn't matter. If Professor Khabir just said, dedication, sincerity, and cadaver dissection. And Prangobasa Jita was actor. You should either a skull-based surgeon or audiology or rhinology or head neck. Okay? Don't go for tonsil and adenoid for flat and Nishan car, private car, buildings. Don't go.
Thank you, sir. Thank you, sir.
Thank you very much.
Okay, we are in fact in conclusion. And learning is a continuous process. We have learned many things from our experts, and this will continue as the days will come. And one particular thing about the anterior posterior ethmoidal arteries and sphenopalatine arteries, they should be identified and not to expose to get to complication. And one particular thing I like to mention here, we all know the pressure in the sphenopalatine artery and pressure in anterior posterior ethmoidal artery is much higher than the similar size arteries anywhere in the body, because they directly come from the heart to the direct stem of the blood circulation up to there, and their blood vessel wall is also more atherosclerotic than others. So we have to deal these blood vessels particularly, and the other tips of the surgeries what we have learned will continue. Thank you very much.
Now we are near to end of the session. Now I would like to request our director sir to hand over the crest to our panelists and chairpersons. First of all, to Dr. Gaurav Shankar Medhikari. Then crest going to Dr. Tushar Kanti Ghosh sir. Thank you, sir. Then Professor Dr. Sheikh Hassanur Rahman sir. Thank you, sir, accepting our crest. Then crest going to Professor Alamgir Chaudhary sir, to Khurshid Alam sir and Shadhan Kabir sir. Thank you everybody. Now
আমাদের সিনিয়র স্যার ফ্যাকাল্টিদের আমি রিকোয়েস্ট করবো, স্যার আপনারা তিনতলায় যাবেন। কামরুল স্যার এবং সিনিয়র স্যার যারা আছেন আপনারা তিনতলায় যাবেন, তিনতলায় রফ স্যার সহ তিনতলায় ডাইরেক্টর রুমের পাশে, আর অন্যরা দোতলায়। এবং এরপরে আমাদের নেক্সট সেশন হচ্ছে CSF রাইনোরিয়া। After lunch, our session will be started just 2:15. And that time, the live surgery, yes, 2:15. That time, live surgery will be done by Professor Sheikh Hassanur Rahman Babur, and he will do the repair of CSF leak. Hope you will enjoy the session.
You are watching Raj TV, Jagorone, Bangladesh. Please subscribe our channel.